Sadanah Shubham Kurutvam Kalyanam Arogyam Dhanasampadah.
We begin our workshop on this divine note after invoking the blessings of Ma Saraswati. We hope and pray that the flame of knowledge will be ignited in all of us today. Good morning, esteemed faculty and dear delegates. So I am very happy to invite our head of the Department of BMMC and Safdarjung Hospital Department of Obs and Gynae, our dynamic Dr. Anjali Dabral, to welcome all the delegates for this critical care obstetric conference today. Dr. Anjali, please.
Good morning, everyone. Am I audible?
Yes.
Yes, yes.
Yes, you are audible. Hello.
Okay. I know many of you must be fasting today, and I thank you for sparing your time to join our program on critical care and obstetrics. With vast improvements seen due to improvement in referral system and Janani Suraksha Yojana, ensuring an exponential increase in hospital deliveries, in hospital facing a deluge of patients brought in time but in critical condition, and comprising the deadly triad of hemorrhage, sepsis, of hypertension. And this has increased more so in COVID times. HDU and obstetric ICU go a long way in decreasing maternal morbidity and mortality due to the intensive monitoring, timely special care provided by the HDU and ICU run by obstetricians with active support from anesthetists and other multi-specialities. Installation of HDU and CCU in all medical colleges and first referral units forms an integral part of Lakshya program, and we were the first to set this up in Safdarjung in 2016. In this workshop, we will share our experience and expertise, and we hope you will find this workshop useful and informative. Thank you once again for joining us. Morning.
Thank you, Dr. Anjali, for all your support, always, which is with us. So now I have the pleasure of inviting Dr. Pratima Mittal, who is the lady behind the establishment of the HDU and the ICU at Safdarjung Hospital, the first in Delhi and one of the first in India, under the inspiration of our Foxy president, Dr. Alpesh Gandhi. So Madam is the former HOD, and she is the pillar of strength for all the activities of critical care which are going on in our department. And I welcome her and request her to give the introduction about this workshop today.
Good morning, everybody, and it's a good, happy Karwa Chauth to all the ones who are having the fast today. And I just, want to tell the journey, what we have taken, why we have taken this. Because initially, when we were having lots of, maternal mortality, but the reason which when we identified it was mainly that they were not able to get the ICU facilities, and the not getting the ICU facility was a big factor. Out of 5, only 1 used to get ICU facility, and that prompted us to look into the matter, and we decided, and then government was also making guidelines that all the good institutions should have ICU facilities. And in this, I think my seniors, Dr. Jyotsna has just put it as responsible for that I have been instrumental, but I think it is the support of my seniors, Dr. Sudha Salan, Dr. Shashi Pratik, Dr. Aruna Batra, who were my, in those time it started, we started working on it. It was only me that it was executed at that time. So I got all the credit, but I think the credit goes to all my seniors, all the seniors which I have named earlier. And besides that, the confidence of the pulmonary medicine head of the pulmonary medicine department, Dr. J.C. Suri, in the obstetricians, that yes, we will teach you, you will be able to manage it yourself. That was, I think, very big factor in our starting the ICU on our own. And since we have started, we have got all sorts of patients, and it feels so nice to see them surviving and going back to the ward. I mean, you really feel that you are doing something to so much work for our humanities. And besides that, now our institution is also been awarded this ICOG fellowship for this critical care in obstetrics. And we have around, in 2019 we had around 1100 patients, more than 1100 patients who who were treated into this obstetric ICU. And my senior residents, my junior residents, my faculty, all of them, they have really become so trained now that at times I feel that in any patient we can manage any patient anywhere. That is the confidence which they have got in working in such difficult circumstances. So we have faced challenges, they were challenges, but our administration also helped us. And at the moment also, whenever we ask for anything for our ICU, I think we never get a listen to say no for this. And definitely having these ICUs and having these critical care trainings and workshops, and we have been conducting these trainings all over the country also with the help of Dr. Alpesh Gandhi. Dr. Alpesh Gandhi was the one who initiated us in starting these trainings, in having the international conference in Delhi, which you sort of pushed, gave a boost to all these activities. And this all has trainings. This training also, I'm very sure is going to be very, very beneficial to all the ones who are attending it. And in this training we are going to talk of the practical skills. We are dealing so many things, but we really don't know whether we are doing right or wrong. So in those things, I think the practical points which will be discussed in this conference will be really, really helpful. And I wish success to all the faculty for making this conference. They will make this conference a great success. Thank you.
Thank you, ma'am, as always, for those beautiful and encouraging words. Now I request Dr. Mala Srivastav, our prolific, dynamic AOGD president, who is ever smiling and who is never tiring, I think, to kickstart our workshop. Thank you, Dr. Mala, for having entrusted us with this.
Thanks, Dr. Josna. Good morning, everyone. On behalf of the organizing committee of the 42nd Annual Conference of AOGD and First E-Conference, it's my privilege to be a part of this workshop on critical care in obstetrics, which is nicely planned and designed by Dr. Josna Suri, who is the chairperson of the Safe Motherhood Committee of AOGD. Together with Dr. Rekha Bharti and Dr. Shiva Marwa, under the guidance of Dr. Pratima Mittal, who is teacher of teachers. During this workshop, one will learn how with multidisciplinary approach and the inputs of the senior, we can actually save our high-risk mothers. Critical care in obstetrics is an upcoming branch, and I'm very happy that Safdarjung Hospital has taken a lead into making a dedicated unit for critical care medicine in their obstetrics and gynae department. I'm sure all our postgraduate students, residents, and delegates who are listening today will highly benefit from this e-conclave. Over to you, Dr. Josna, for today's proceedings.
Thank you, Dr. Mala, for those beautiful words. So now I hand over to Dr. Rekha, who will introduce the chairpersons for the first session. Dr. Rekha, please.
Good morning, everyone. So without wasting much time, we go on to our academic session. So begin with, we have our inaugural session, and I would like to invite the chairpersons for the inaugural session. Dr. Pratima Mittal, as has already been introduced by Dr. Jyotsna Suri. Madam has always been there to guide us and to advise us, and she's also advisor of this workshop also. So our next chairperson is Dr. Renu Arora. Madam is a professor consultant, and she was a former HOD of Vardhaman Mahavir Medical College and Safdarjung Hospital. and Dr. Mala Arora. And Madam, we all know, Madam is the chairperson of the organizing committee of this AOGD workshop. And so with this, I hand over the session to the chairpersons to start with the academic session, first academic session.
Thank you, Dr. Bharti. It's my pleasure to introduce our speaker of the day, Dr. Alpesh Gandhi. Sir is the President Foxy, Vice President Foxy 2013. He had been the Governing Council of ICOG, Chairperson Practical Obstetric Committee of Foxy, Vice President Gestosis, past President of Ahmedabad Obstetrics and Gynae Society. And he has done so many work all over the country for the sake of obstetrics and gynae. He is always ready to help us, and during his tenure, he has converted our adversity into opportunity. And the entire country, we are having so many webinars, so many CMEs, so many conferences under the able guidance and leadership of Dr. Alpesh Gandhi. Sir is going to speak about why women should become critically ill, preconceptional care as relevant in high-risk pregnancy. Over to you, sir. We are all waiting for your deliberation.
Respected chairpersons, Dr. Mala Srivatsav, Dr. Pratima ji, Dr. Rupali ji, Dr. Renu ji. Thank you for the kind words, kind introduction, and giving me this opportunity to share my views on this very important topic. Routinely, I am speaking for the role of obstetric HDU and ICU. And intentionally, this time I have selected a topic which is, we can say, a basic topic, and we can say ignored or neglected topic, but a very important topic. Before I start, I would like to congratulate Dr. Mala and team AOGD and Dr. Anjali ji for this very important and useful workshop. A very vibrant AOGD and vibrant Safdarjung Hospital. Every year I have visited Safdarjung Hospital. Even during this year, we have on 28th February, we have a program on Surakshit Naritva, and during that time also we had planned a TOT for pap smear and cervical cancer, and I have visited Safdarjung Hospital. So during this COVID-19 year also I visited Safdarjung Hospital. So I have a personal, it's very close to my heart. So thank you, Dr. Pratima ji, Dr. Anjali, Dr. Jyosna, Dr. Rekha, Dr. Siba, and all at Safdarjung Hospital who are involved in this workshop. Coming to today's topic. Namaste. Very good morning to all of you. I bring greetings from Foxy. In 2189 nations made a promise to their people to free them from extreme poverty and multiple deprivations, which was very well known as Millennium Development Goals, which was to be achieved by 2015. And one of the 8 goals of MDG was to improve maternal health. In India, maternal mortality rate was 398 per 1 lakh live births in 1997 and 98. And India was required to reduce maternal mortality rate to 109 by 2015. Different time has different problems, and different problems has its own different solutions. To achieve this, our priority was to bring more and more pregnant women to the hospital for safe delivery, because during that time, hospital delivery rate was very less, 27.6% in 1998 in India. Several schemes were introduced in our country, but the Janni Suraksha Yojana has brought revolution in Indian obstetrics, which was introduced on 12th April 2005 by the then Prime Minister. And because of the scheme and various efforts from FOXY and various organizations, our country has significant improved in maternal mortality rate. Hospital delivery rate, which was 38% in 2005, has increased to 84% in 2015. And because of this, there was a good improvement in maternal mortality rate. As here we can see, every year it was improving by 15 to 20. And with this pace, we were expecting we would be able to achieve a MDG goal by 2015, when we should reach to nearly 100. But what has happened after 2011, the maternal mortality rate was not improving with this pace, and which was 178 in 2010-11 has reached to 262 by 2015. More and more women are reaching to the hospital, but still maternal mortality rate was not improving with the expected pace. Why is this observation? Why this progress has stopped? This is because of the lack of quality obstetric healthcare at the hospital level. India is one of the countries having highest incidence of PPH, preeclampsia, eclampsia, prematurity, IUGR, diabetes, septicemia, severe anemia across the world. But sad part is, case fatality rate is significantly high in India. Incidence of placenta accreta is high in developed countries, but case fatality rate is significantly high, nearly 10% in India. Why this observation? Why this much high case fatality rate in our hospitals? This is because of a lack of quality obstetric health care. At every 5 minutes, one woman dies from a pregnancy-related complications in India, as per the UNICEF, and as per WHO, the near miss cases incidence is very high, 8.23% in India. We understood the importance of the quality obstetric healthcare. We advocated a lot to the government of India, and government of India was convinced, and we came out with the guidelines. Now our country has guidelines on obstetric HDU ICU, which was published in March 2016, and in 2017 another guideline on operational guidelines for obstetric HDU ICU was published. And now we can say across the country we have nearly 250 to 300 obstetric HDU ICU functioning in medical colleges. This we can say a second revolution in Indian obstetrics. And with the advent of obstetric HDU ICU, it has observed that at many places, in many institutes, maternal mortality rate has decreased by 60% in only in 1 or 2 years. And now government of India, when presenting when attending some health conferences outside India, they are presenting the data of obstetric HDU ICU in India. And across the world, everybody is appreciating India. Even from SAFOC countries, everybody is contacting us for establishment of obstetric HDU ICU. And recently, Bangladesh Society has also had seminar on this. Initially, it was thought we would be able to reduce maternal mortality rate and fetal mortality if patient delivers at hospital. But later on, we understood that it is not sufficient. Maternal mortality rate was a decrease, but it was not the desirable. Then we realized that if we gave good emergency obstetric care, good perinatal care will prevent many adverse outcomes for the mother and fetus. Then again, it was realized that maternal mortality rate was improved, but still it has not reached to the desirable level. Then we understand the importance of good quality obstetric healthcare like obstetric HDU and ICU as a backup. And then again, we realize that yes, now we are able to reach to MDG goal and SDG goal. We will definitely achieve these goals. But again, if we want to reach to the developed countries where the maternal mortality rate is 20 to 30, then we need to think something else also. And now here we should think why our mothers should become critically ill. What we can do to prevent them from becoming critically ill. And then we realize the importance of realize that the best prenatal and quality care will still not be adequate to reduce mortality and morbidity in several certain pre-existing conditions, situations which are existing before pregnancy. Thus, we arrived at a significant concept of conceptional, periconceptional care before pregnancy and immediate after pregnancy. So that is periconceptional care and medicine. It's now developing into new branch of obstetrics in developed countries, and it is recognized as a preventive obstetrics of primary kind. It requires more insights into the patient's history and examination, and aim of preconceptional care is to promote health of women before conception in order to reduce preventable adverse pregnancy outcomes. It refers to intervention that aim to identify and modify biomedical, biobehavioral, and social risk to pregnant women and her baby before and immediately after conception occurs. And we all know that prevention is always better than cure. WHO also organized a meeting to develop global consensus on preconceptional care to reduce maternal and childhood mortality and morbidity, and has developed a package of preconceptional care intervention in 2012. At this juncture, I would like to bring to your kind notice a few eye-openers why preconceptional care is required. 4 out of 10 women report that their pregnancies are unplanned, and so essential health intervention is too late in 40% of the pregnancies. Perinatal deaths are 50% higher among babies born to mothers less than 20 years. Up to 10% of pregnancies among women with untreated gonococcal infections result in perinatal deaths. Up to 35% of the pregnancies among women with untreated gonococcal infections result in low birth weight infants. Maternal undernutrition and iron deficiency anemia are one of the major risk factors, account for at least 20 to 40% of the maternal deaths directly or indirectly. And in India, it is said that 54% of the women are anemic. Female genital mutilation increases the risk of stillbirth and neonatal death by 15 to 55%. In the absence of interventions, the rates of HIV transmission from mother to child is between 15 to 45%, and if intervention is done, the rate decreases to below 1%. Pregnancy is absolute or relative contraindicated in certain conditions, and I would like to discuss few clinical cases to understand the importance of what could have been done to save these mothers during preconceptional period. A 23-year preemie in 37 weeks of pregnancy, admitted with dyspnea, she was diagnosed to have rheumatic heart disease and severe mitral stenosis before conception. After admission, she was treated with diuretics, varapamil, and oral penicillin. Cardiology reference was done, echocardiography was done, and it confirmed that patient is having severe mitral stenosis and suitable for balloon mitral valvotomy. She went into CCF, remained in failure despite treatment, delivered a healthy baby after cesarean section, was ventilated overnight, stable for 24 hours, but developed refractory pulmonary edema and succumbed 2 days after cesarean section. What could have been done to save her during preconceptional period? I will not go in detail antenatal and intranatal management because we are interested in discussing preconceptional period. So I will just very briefly mention the history. Cardiologist reference and maternal echocardiography could have been advised and performed preconceptionally or during the early pregnancy period. If ejection fraction is found to be less than 30%, then we should always remember when it is less than 30%, pregnancy carries a significantly very high mortality, maternal mortality rate, that is 60 to 70%. 60 to 70% mother will die if ejection fraction is less than 30%. So we cannot allow such pregnancy to be continued, and such pregnancy should be terminated, and mother should undergo balloon mitral valvotomy. And after that, after some time of the balloon mitral valvotomy, again echocardiography should be performed, and ejection fraction one should try to know the ejection fraction of the mother. A 24 years gravida 2 presented with the right heart failure at 25th week. Past history was suggesting primary pulmonary hypertension 3 years earlier and advice against pregnancy. First pregnancy was terminated at 3 months on advice of cardiologist. She was again advised MTP at 5 weeks of present pregnancy, but she opted to continue pregnancy at her own risk and antenatal visits were regular. She went into spontaneous labor, delivered vaginally. She developed fever on day 3, breathlessness on day 4. Oral warfarin was started. She developed chest pain on day 8. Pulmonary embolism was suspected. She was put on parenteral heparin, failed to improve and died on postpartum day 9. Again, what could have been done to this patient during preconceptional period? Pulmonary hypertension constitutes a contraindication to pregnancy. This may occur as primary pulmonary hypertension, which commonly occurs in young women. Any symptoms of chest pain on exertion or syncope may be a manifestation of pulmonary hypertension. Pulmonary artery pressure may be estimated using non-invasive echocardiography testing. High suspicious cardiology reference, echocardiography, and MTP probably would have saved this mother, saved her life. So there are 3 important aspects during preconceptional period. We should try to identify of any pre-existing cardiac problem or any diseases during preconceptional period as the present risk factor. If it is present, then we should evaluate the severity of this cardiac problem as the risk factor in relation to the expected hemodynamic changes of pregnancy. And we should try to identify if any intervention is required to improve cardiac status prior to pregnancy. For some women, pregnancy may worsen their cardiac condition, their cardiac functional capacity, and this has to be kept in mind during preconceptional period. There are certain absolute contraindications like pulmonary hypertension, certain relative contraindications like severe mitral stenosis, but they all have its own potential risk, and we need to identify this absolute and relative contraindication and its potential risk and severity related to the hemodynamic changes during pregnancy, and accordingly we should counsel and accordingly we should do the intervention whatever is required to save the mother. When patient is having already chronic hypertension, the potential risk of pregnancy, there is a potential risk to pregnancy, labor and delivery. It should be discussed with patient, her family during preconceptional period and evaluation. We should do counseling. That is a high risk pregnancy. She may have complications. She will require frequent investigations. She may require close monitoring. She may require admission in obstetric HD or ICU, and she may have some fetal complications as well. For example, the patient may require prolonged admission. It should be discussed that all complications cannot be fully anticipated also. So during preconceptional period, we should try to control pre-existing hypertension to modify and optimize the drug required. If she is on atenolol or ACE inhibitors, she may require to change the antihypertensive drug. If she is on warfarin, then it is to be changed because it can lead to teratogenic in first trimester. To anticipate complications like early onset preeclampsia, eclampsia, and IUGR, and to take steps to prevent these complications and to take care and undergo delivery. We should counsel with the patient during preconceptional period. If she is having chronic hypertension, then that you will need a delivery at a tertiary care center and should be delivered only at a tertiary care center. A 40 years primary with BMI 35 years was admitted at 38 weeks with pain in abdomen. She had regular antenatal checkups. She had a cesarean section for fetal distress under spinal anesthesia. No antenatal or intranatal complication occurred. On 4th post-operative day, patient became dyspneic. She was given steroid and bronchodilator. She was shifted to ICU. By that time, she was in shock. She was intubated and put on ventilator. But within 20 minutes of onset of symptoms, patient was declared dead. The final diagnosis which was declared was pulmonary embolism. Again, what could have been done to save this mother during preconceptional period? We should identify the risk factor here. There are 2 risk factors: 40 years of age of mother, and there is a high BMI, 35 BMI. So we all know that it can lead to many complications. she may require additional investigations, precaution. She may require longer time of thromboprophylaxis, and we should advise such patient to reduce her weight during the preconceptional period. And if required, we should also offer and advise for bariatric surgery. Weight loss after bariatric surgery may reduce the risk of complications. And if bariatric surgery is performed, then it is ideal to delay pregnancy for 1 year, as this is the phase of rapid weight loss, and all patients with history of bariatric surgery should be screened for nutritional deficiencies such as iron, folate, vitamin B12, vitamin D, and calcium. So we should be very much watchful when patient is having obesity, and particularly she may require a thromboprophylaxis for a longer time compared to other patients. A patient of 27 years came with history of 4 months of amenorrhea with SLE. Mid-trimester MTP was performed. Patient was discharged from the hospital on the same day. And routinely there is a habit, a practice across India, across the world. We can say that patient is usually discharged immediately after performing MTP within few hours. She developed intracranial hemorrhage 5 days after MTP, followed by coma and death. Available history showed that she was having active SLE. It is well known that relapse of SLE can occur after delivery or even after performing MTP. The risk of lupus flare during pregnancy is increased dramatically in women with active lupus in the 6 months prior to conception. Pregnancy exacerbates SLE activity and increases the likelihood of maternal disease flare in 15 to 65% of the pregnant women with SLE. These patients require close observation. This patient require admission in obstetric HDU for a longer period, and these patients require close monitoring on her hematological and immunological parameters, and we should discharge the patient once hematological and immunological parameters are normal. We should not do hurry in discharging such patients after MTP. And such type of patients require higher doses of prednisolone. Probably higher doses of prednisolone could have saved her life, but we should do counseling during the preconceptional period about all this possibility and requirement. A 27 years old patient with G2A1P0, known case of diabetes mellitus, was on oral hypoglycemic agents. History of previous 1 DNE was performed at 8 weeks for missed abortion. This time patient came directly at 22 weeks with FBS 150 and PP2BS 220. Sonography was advised. A lethal cardiac anomaly was identified. Baby delivered with a cardiac anomaly and died within a few hours. If she is having history of type 2 diabetes, the base indicator for congenital anomalies for fetal outcome is HbA1c. When HbA1c is less than 7%, congenital anomalies risk approaches to general population, but in contrast, when it is more than 11%, it corresponds to a risk of fetal anomalies as high as 25%. So when HbA1c is more than 11%, 1 out of 4 mothers will have a fetus with congenital anomalies. So during preconceptional period, we should counsel with the patient. This is a very interesting study where we have comparison of congenital anomalies in diabetes mellitus with preconceptional care and without preconceptional care. In all these studies, it has been found that with preconceptional care, the incidence of congenital anomalies between 0 to 2.5%, whereas without preconception, it is between 4.2 to 12%. Means that if preconceptional care is not done, then the rate of incidence of congenital anomaly is increasing by 4 times when patient is having a diabetes mellitus. So in such case, medical history and obstetric history is very, very important. We should try to know the duration of diabetes, type of diabetes, whether patient is on any drugs, oral drugs or insulin or not. We should discuss the acute complication, chronic complications of diabetes mellitus with patients. And we should also discuss the complications during pregnancy because of the diabetes mellitus, gestational diabetes or pre-existing diabetes mellitus with the patient. And we should also try to rule out any concomitant medical disorders, conditions in such patients. And we should teach them about the need for the glucose monitoring and all what is required to manage the patient and for the safe delivery. 27 years old patient with gravida 2 abortion to para 0, history of previous one abortion at 8 weeks, and MTP was performed at 18 weeks for congenital cardiac anomalies. This time patient came directly at 7.5 months. Sonography was advised. A big open spina bifida was identified at lumbar region. A baby delivered with a spina bifida and died within a few days. We all know that folic acid, vitamin B12 and B6 are micronutrient vital for the programming of healthy life. There is a significant important role of folic acid, vitamin B12 and vitamin B6 in pregnancy and lactation. It prevents neural tube defects, congenital anomalies, and it is required for the growth, proper growth and development of the fetus. It reduces hyperhomocystinemia and related complications, and it decreases the risk of preterm birth, preeclampsia and placental abruption and many other complications. When patient is having hyperhomocystinemia, pregnant woman may have 3 to 7.7 fold increased risk of preeclampsia, abruptio of placenta and many other related complications. And in India, methyl tetrahydrofolate reductase polymorphism prevalence in India and incidence is nearly 28.20%. We can say it is nearly out of 3, every 1 woman is having this polymorphism. So proper diet is very, very essential. We all know that improper diet can cause preterm, premature birth, low birth weight, can lead to there will be inability to breastfeed. Mother may have deformed babies, complication at the time of birth, depression may be there, so many other complications. Baby may have fewer brain cells, so many other complications it can lead. So the proper dietary advice is also very, very essential. This is a period, this is a window of opportunity, we can say, to evaluate the vaccination status of the patient. And this is a period where we can discuss, we can know the vaccination status, and we can give, if required, MMR, Tdap, HBsAg, varicella, influenza vaccines. And we can also discuss with the patient about the congenital rubella syndrome, which can lead to so many complications like microcephaly, fetal growth restriction, cardiac malformation, and many more. So this is the time to determine, to assess the vaccination status and to give vaccines. Yes, as per the CDC reports, we should also try to find out whether patient is having history of tobacco use or smoking or not. Smoking can cause problems with placenta. There can be a premature delivery. Then it can lead to sudden infant death syndrome, and it can lead to cleft palate and cleft lip. Similarly, we should also try to find out whether patient is consuming alcohol or not. Drinking alcohol during pregnancy can cause miscarriage, stillbirth, a range of lifelong physical, behavioral, intellectual disabilities, and these disabilities are known as fetal alcohol spectrum disorders. We should also try to find the history whether patient is on any drugs or not. If suppose patient is on anti-epileptic drugs, we all know that it is associated with a greater risk of fetal malformations. So we should try to find out if other medicine is available, possible or not. And we should also discuss these possibilities. We should do counseling with the patient during preconceptional period. And we should also, particularly for patient, you all are practicing in Delhi, this is very, very important, effects of pollution and toxins on pregnancy. It can lead to many complications. Fetus who are exposed to pollution and toxin during pregnancy can suffer from miscarriage, birth defects, low birth weight, stillbirth, childhood cancer, thyroid dysfunction, attention deficit hyperactive disorder, cognitive impairment, neurodevelopmental abnormalities, autism. It can increase its infant mortality rate. It can lead to sudden infant death syndrome. It can lead to adult onset diseases like diabetes, hypertension, asthma, earlier onset of Alzheimer, Parkinson's disease, premature aging, so many problems it can lead to. So we should also counsel with the patient about the effects of pollutions and toxins on pregnancy and future generation. Lead pollution can lead to impaired attention and concentration, communication and learning disability, hearing loss, defective motor skills, low IQ, low memory. Similarly, mercury can lead to loss of IQ, decreased performance, memory, attention, reduced spatial cognition, and language skill deficit. Noise pollution also can lead to hearing loss, elevated blood pressure, and mental retardation. So we should discuss everything, all these aspects with the mother and their family members, and we should advise them to avoid visit areas having high air quality index by checking daily air pollution forecast through mass media and stay indoor when the levels are high. Avoid active and passive cigarette smoking. Avoid cosmetic during pregnancy like lipstick and nail polish. Avoid go to noisy places. Avoid living near to steel mills, waste or water treatment plants, sewage incinerators. Avoid vaporizing during open air cooking with food, and also advise to use exhaust fans in the kitchens to reduce air pollution from indoor cooking and to reduce use of mobiles, laptops, ovens, cosmetics, all these things. So it's a preconceptional period. Preconceptional care is an opportunity. It's a window of opportunity to evaluate a couple. 7 integral components of this care: physical assessment of a couple, identification of risk factor related to pregnancy, laboratory investigation of a couple, vaccination status, and to provide vaccines, counseling regarding pregnancy risk, severity of the possible complications, management options and reproductive alternatives, monitoring and correction of nutritional status, and initiation of intervention when possible to provide optimum pregnancy outcome. These are the 23 important risk factors. We should always try to evaluate whether these risk factors are present in possible mother, and if these risk factors are present, then we should discuss, we should do counseling with the mother, and we should do whatever is required and essential for the mother. And we should always keep these 23 high risk factors always in our consulting room. We should always try to find opportunity to discuss with the patient whether she is not even she is not pregnant, or when she comes to our hospital as a relative, whichever opportunity we get, we should try to discuss all these things with the patient and relatives. These are the investigations which we should advise during preconceptional period to wife and husband, and these are the areas we should be addressed during preconceptional period, from nutritional condition status to vaccine status to genetic status to subfertility status, female genital mutilation, unwanted pregnancy or sexually transmitted infection, HIV status, interpersonal violence, mental health, psychoactive substance use, tobacco use, so many things. These are the package, and this is an opportunity to discuss, to counsel, and to teach them regarding the personal hygiene, psychosexual counseling, use of contraception, process of childbirth, need of lactation, proper technique of lactation, family planning measures. So many things we can discuss, we can do counseling during preconceptional period. And preconceptional period has a very positive effect on a range of health outcomes. It decreases maternal mortality, it decreases child mortality, it decreases birth defects, it decreases preterm delivery, it decreases low birth weight, it decreases early onset of diseases in a baby, like mental retardation, like early cancer, and so many things it can prevent. It can prevent vertical transmission of HIV, and so many things. There is lots of positive effect on health outcome. And previously there was a now paradigm has been changed. Previously we were thinking, we were concerned for the healthy babies, then we understood the importance of healthy mothers for the healthy babies. So the paradigm was healthy mother for healthy babies, and now it has shifted to healthy women for healthy mothers, so that there will be healthy babies. So now paradigm has been changed to healthy mothers. So there is improvement of preconceptional period and periconceptional period. In conclusion, today more and more often pregnancies are possible after treatment of gynecological, surgical, fertility conditions. But the preconceptional aspect of these circumstances have often been underestimated, neglected even today in their importance for overall good outcome. Time has come to rectify this situation. We should start a special preconceptional clinic, or we should have when we are also thinking for adolescent clinic. Similarly, this generation also require a premarital counseling, preconceptional clinic later on. Preconceptional counseling care management would have made a difference to many such cases. It is the need of the hour. Periconceptional care involves wide range of situations. The dream is to be able to address them in each and every patient, but the challenge lies in getting these women to come to us on time and providing them adequate time and motivation. Every health visit by a woman at reproductive age should be used to make her aware about the need of and about the importance of periconceptional care and medicine. Our ultimate aim is improved maternal and child health outcomes in both the short and long term. Every year, 3,000 pregnant women die in the world as per the WHO 2015. And it is said if quality obstetric health care is provided in time, then we could save 80% of these pregnant women. I mean, 240,000 women can be saved in the world by providing quality obstetric health care. But now there is a time to also think why these mothers should become critically ill, what we can do to prevent them becoming critically ill. Pre and periconceptional evaluation, counseling and intervention plays a significant role to prevent later intensive care admission and complications. Even though if they require intensive care, then also the severity may be less and we may save those mothers. We did not come to fear the future. We came here to shape it. Once American past President Barack Obama declared this, and I believe in I believe in Barack Obama's this declaration, this statement, and Benjamin Franklin declared that by failing to prepare, you are preparing to fail. We should understand the importance of preparation, and we should use this preconceptional period and immediate period once she becomes pregnant for the preparation for the better outcome of pregnancy and to save them from become critically ill. A big section of society in our country is still unreached and underprivileged, deprived of benefits of healthcare. And as an organization and as a college and as an individual practitioner, it is our moral responsibility to see that they it is our duty to see that they should not be continue as unreached and underprivileged, and these benefits of healthcare should reach to them. And at the end, you all know the theme for this year is Foxy is safety first for Indian women and Foxians, and for the safety of Indian women, I think periconceptional care, preconceptional care, obstetric HDU, ICU, all these things are very important and essential. Let us work together for Foxy 2020 theme and to achieve SDG goal for mothers and for our country before 2025 instead of 2030. And I think it is doable if we all 38,000 gynecologists, and if all the colleges, and if Government of India and all the state governments decide to achieve SDG for maternal mortality and neonatal mortality before 2025, I think this is a possible dream and doable dream. Thank you very much for giving me this opportunity, and I wish grand success to this workshop. Thank you very much.
Dr. Alpesh, you have beautifully highlighted the importance of preconceptional care, the components of preconceptional care, the effect of preconceptional care is by showing these important cases. Beautifully you have shown all the cases, So, and I'm sure, as you have made, you were the person who made, those manuals, that HDU manual guidelines and the operational guidelines for HDU ICU. Similarly, I think for preconceptional care also, the nationwide, we will start this preconceptional clinics. In our hospital, we are already running a preconceptional clinic. Dr. Renu Arora is, running that. And but I think all the hospitals should have a preconceptional care, because clinics, these things only can, promote health of the women, then prevent complications. Especially optimizing the health in the preconceptional period, and then definitely this will help in preparing the woman for the pregnancy. So I think all these things are very nicely explained, and I would like Dr. Renu to talk about a little bit about the preconceptional clinic which we have. Renu, unmute yourself, please. Renu, unmute.
Thank you, Dr. Alpesh. It was a very nicely explained the role of preconceptional care in making pregnancy safe and decreasing the mortality and morbidity. I, the other way, feel also that just spending some time in the preconceptional period will make even the obstetrician life very well. This will decrease the stress. It will make sleepless nights will decrease, because naturally whenever we are taking care of the patient, it is very important for us that woman is healthy, fetus is also healthy, and for that preconception care is very, very important. So as Dr. Pratima Mittal has already said, that we also have a preconceptional clinic in our own hospital, where we are addressing these people in the first trimester, even prior to that. And suppose if they have some disease, medical disorder prior to becoming pregnant, we do motivate them that they should come. We have a coordination with the medicine department, that they come to the preconceptional clinic, and then also we advise them what to do. Moreover, if the patient, suppose if that, because we are dealing with the patients who are really poor and they are not very knowledgeable, they do not know these things. But in case they have already had one baby, then that is also the time to address the preconceptional care. That is when they come next, how they should come next, what all should be addressing when they come prior to the next pregnancy. I think that also is very important. Preconceptional, prior to the next pregnancy, that is the time when most of the obstetricians are actually acting there.
So thank you, ma'am. And with this, I thank the chairpersons for successfully conducting this very informative session. And now I hand over to Dr. Shiva Marwa for carrying forward with the workshop. Dr. Shiva.
Thank you, ma'am, for the kind introduction. The critical care obstetrics, as we all know, is incomplete without hands-on.
Shiva, Dr. Alpesh wants to say something.
Wants to say something, Shiva.
I just want to take your permission to leave, because I have some other duty to perform. So please excuse me. Thank you very much for this opportunity. Though I am interested in this topic, in this subject, and all the faculties, eminent faculties, and I want to know your experience, I want to stay, but because of some other responsibility, it would not be possible for me to join. So continue. So please excuse me. I wish grand success to this webinar, and it's congratulations that Safdarjung is having this preconceptional clinic, and you are running very well. Safdarjung is always ideal for so many other obstetric department, and I wish across India, all the medical colleges, we can have this such type of clinics. And now we all need to work at government level to advocate this as the supporting aspects of obstetric HDU ICU. Two things main: one is blood bank facilities with the components, and other is the preconceptional clinic. So thank you very much for giving me this opportunity and for the nice words. Thank you.
Thank you,
Dr.
so
Alpesh. I think we have been, taking you for granted as a faculty of Safdarjung only at times, especially in the conferences. Thank you.
Yes.
Thank you, sir. So, as we all know, the critical care obstetrics is incomplete without hands-on management and useful bedside tips and tricks for all the obstetricians practicing critical care obstetrics, which goes a long way in averting morbidity and mortality in such patients. But this being an online virtual event, keeping this in mind, this session was conceived that entails simulating bedside rounds and discussion covering important aspects of critical care, including oxygen therapy, ABG interpretation, fluid management, etc. So to begin the first case discussion, I would like to invite Dr. Pratima Mittal ma'am. Ma'am needs no introduction. She is the brain behind the critical care in Safdarjung Hospital, and she's the advisor for the workshop. I also invite Dr. Archana Mishra ma'am. She's an associate professor at Safdarjung Hospital, and she has keen interest in critical care and high-risk pregnancy. And now I hand over to Dr. Pratima Mittal ma'am and Dr. Archana Mishra for a discussion on oxygen therapy, including NIV.
Thank you, Shiba. Thank you very
Shiba.
much. Archana, now would you like to take me to the case, to the bedside of the patient?
Yes, ma'am, it's my honor that you are my expert. Ma'am, Shiba Marwa, she has to stop sharing screen, then only.
Yes, ma'am, I'm doing that.
So is my screen visible?
Yes, yes.
So a very good morning to Pratima ma'am and a very good morning to all the organizers and audience. And I'm going to start with my presentation on oxygen therapy. So this is my first case. So these are the cases which we are seeing in day-to-day practice. So it was a 20 years old primary gravida at 35 weeks of gestation with preeclampsia, with severe features in early labor. And she has been referred to us from some other hospital with chief complaints of shortness of breath. At that hospital, she came to us on advanced life support, and in that hospital, she was administered injection labetalol 40 mg IV, injection dexamethasone 12 milligram IM, and loading dose of Maxelf. And patient was shifted on oxygen support with a face mask, simple face mask at 3 liters per minute. So we examined this patient. So her respiratory rate was high. It was more than 34 per minute. And her pulse rate was 110 beats per minute. PP was high, 160 by 110. JBP was not raised. Pallor was mild and she was having edema. And most important thing was that her chest was full of basal cryptation. In CVS, we were not able to find any murmur, but tachycardia was present. And she was in early labor. And on abdominal examination, we found that she was IUGR. So her SpO2 on room air was 82%. Immediately we draw a ABG. Within 15 minutes, it was available. Her pH was 7.30 and PO2 was 52.1, which is much lesser than needed. PCO2 was 15 mm Hg, bicarbonate was 9.6, and lactate was 4.1. LFT and KFT were mildly deranged, electrolytes were normal, and there was thrombocytopenia, and coagulation was normal. So immediately clinical diagnosis of pulmonary edema was made. Now she was put on oxygen by non-breather mask, but the oxygen saturation was not improved. It was only up to 90%. In pregnancy, we need at least more than 95%. And we can see that the work of breathing was even increasing. And in the meantime, her consciousness further deteriorated. So immediate decision of intubation was done. And patient was put on mechanical ventilation. She was administered 3 milligram of morphine slow IV. Injection furosemide was given 20 milligram slow IV followed by 40. But in half an hour time, urine output was not increasing at all. So immediately we put the patient on anti-G drip because her BP was also high. So it was started at 5 mics. At every 10 minutes, we increased by 5 mics and reached up to 20 mics when we were able to control the BP. And then it was 150 by 90 mm Hg. In view of poor Bishop score and deteriorating condition of the patient, decision of cesarean section was done. So with the grace of God, the baby and mother both were fine in the post-op period.
So, Archana, see, you have beautifully highlighted the management in this case, but what we will focus on the first 2 points which you have started. So, what do you think? You know, were they right in sending the patient on the just the face mask, a simple mask, or they should have used some other device? And what are the other devices available? What are the devices? How do you plan which device to be used in these critical care cases for oxygen transmission?
Ma'am, I'm not sure in which condition they found the patient, but their decision of sending the patient at 3 liters per minute face mask was not right. Because if you are using a simple face mask, the oxygen flow should be at least 5 liters per minute. Because if you are using it lesser than that, then carbon dioxide is contained in the face mask only. It will not be able to wash off the carbon dioxide, and patient will be inhaling that carbon dioxide, because these are the low flow devices. So patient is inhaling your oxygen
let's
and room
start
air
with
both.
what all devices are available and how do we plan our oxygen therapy, as it is also a medication. So how do we plan our oxygen therapy?
Okay, ma'am. So now I'm going to just give you a glimpse of oxygen therapy. So first and the foremost thing that in our wards, in medicine ward, you will be seeing that left and right, everybody is using oxygen. So even they don't need any physician order. So nursing staff, whenever they found any patient sick, so they start on oxygen therapy. But you should have a fair idea that oxygen is a drug and it must be used meticulously, diligently, and at a definite rate. And you should know that what your goal is to achieve a target goal. If abused, it can cause complications. So now, what are the types of hypoxia we encounter in our day-to-day practice, and where the oxygen is useful, where it is not? So most common which we are encountering is hypoxic hypoxia, where oxygen saturation is low due to low alveolar because of the alveolar hypoventilation or low FiO2. So oxygen therapy works best in these conditions. Second one is the problem is not with the lungs, problem is with heart. So due to low cardiac output or vascular occlusion, so it is a type of stagnant hypoxia. So perfusion is not good, although the ventilation is perfect. So oxygen therapy may help up to some extent. Third one is our anemic woman, or where hemodilution is present, or carbon monoxide poisoning, which we are not seeing very frequently. So this is a type of anemic hypoxia. So oxygen therapy is useful to some extent. But last one, which is least commonly seen, is the cases of poisoning, cyanide poisoning, where cells are not able to utilize oxygen. So that is a histologic type of hypoxia. And oxygen therapy is not going to help this patient. So common indication of oxygen therapy is hypoxia is one. Normoxic hypoxia I have already talked about, such as in cases of MI, anemia, hemodilution, carbon monoxide poisoning, or acute metabolic acidosis. Third one is trapped gases like obstruction, COPD. And a special situation is like anesthesia, where the patient is hale and hearty. Even then you have to start with the oxygen therapy. So what is your goal of oxygen therapy? Your goal of oxygen therapy is to increase the alveolar oxygen tension, decrease the work of breathing, and decrease the myocardial work. So what are the prerequisites of oxygen therapy? By any device, you may provide oxygen, but these 4 things will remain constant. First thing is physician's order, except in cases of emergency. Nursing staff can start with the oxygen therapy if they know how to use the devices, in what flow rate they have to be using all these devices. But it is best that you should have a prescription order for starting the oxygen. Then second thing is that you have started oxygen and you have left the patient. It is never should be the case. There should be continuous clinical observation. Arterial blood gas measurements. Many times my junior asks me, ma'am, at what interval we should send it. It depends upon the condition of the patient. If you are starting a CPAP, the patient is unstable. So you may have to send ABG at even at half an hour interval. Then you can increase it to 1 hour, then 4 hours, then 12 hours. During weaning, you can decrease it. Pulse oximetry is a must. you have to monitor the patient, what oxygen you are giving, is it working or not working, or do you have to change the device? So these are the salient points of physician order. First thing, that you have started oxygen. Second thing is the date and time. Method of the delivery, at what concentration and flow rate you have asked the nursing staff to start the oxygen. What patient observation you have asked the this thing. If your patient is in CPAP, she may go in hypotension. So you have to just definitely see what his pulse is like, what his blood pressure is like, what his urine output is like, what are our electrolytes and all the other things. So if your patient is going to need oxygen therapy for a longer time, it's always preferable that you should add oronasal care to the nursing care plan. So courtesy ma'am, this is a very nice prescription of a oxygen. When you have prescribed oxygen, it has mentioned everything: month, date, time, at what saturation you have asked, what is your target. So here the target is 94 to 98%, and it has to be given in a continuous manner, not in an intermittent manner. It has to be given by a nasal cannula, and the patient's name, MRD, because you need to identify the patient. Sometimes we are really in an overworked situation, it is difficult. So you need to identify the patient, and you have to write down the condition for which you are applying this oxygen. So what are the devices to deliver the oxygen? So there are two types of devices mainly. One is variable performance low flow system, and another one is fixed performance high flow system. That is also called high airflow oxygen enrichment devices. Variable performance system, they contribute partially to the oxygen pattern the patients breathe in. So your breathing rate should not be higher than 25 per minute, and your tidal volume should be between 300 to 700, and the breathing pattern, the respiratory pattern, it should be predictable, it should be normal and regular. Then only these low flow system will work best. So these are nasal cannula, simple mask, partial rebreather mask, and non-rebreather mask. In other condition, if patient condition is not that good and you need a specific and constant percent of oxygen independent of patient's breathing, patient is at the higher risk of carbon dioxide narcosis or carbon dioxide retention, you need venturi mask, trachea collar, or TPs. But in the beginning only, I will like to clarify that high flow does not mean that it is going to deliver high FiO2. The situation may be these low flow system may be giving more FiO2 than high flow system, but they are not predictable. It can be just estimated, cannot be accurately titrated that how much oxygen the patient is taking in. So this is a very important chart everybody should know. Nasal cannula, it can be started at 1 liter, and the highest ceiling is 6 liter. And FiO2, which we will be able to provide, will be from 24% to 44%, 0.24 or 0.44. This is the highest limit. And if you are going to start more than 4 liter, then it is always better to humidify the oxygen. Simple face masks, they should be started from 5 and up to 8 liters you can per minute, you can provide the oxygen to the patient. And FiO2 which they are going to provide is 0.40 to 0.60. This is the limit of a simple face mask. If your patient requires higher than that, then it is better to use partial rebreathing mask, which is started from 6 liter per minute, and you can go as high as 10 liter per minute. And FiO2 which you are going to provide is from 60% to 80%. Plus, and non-breathing masks, these are the best, which is started at a very high flow rate, that is 10 liter per minute, and you can go up to 15 liter per minute. And highest FiO2 which is provided by these is 90% plus, that is 0.9 plus. So nasal cannula, we all have seen, we all have used. It is a very simple disposable plastic device with 2 protruding prongs for insertion into the nostril, and it is connected to the oxygen source, and sometimes with the humidifier also. And it is used for low medium concentration of oxygen from 24% to 44%. This is a small video I'm going to play to show you how we are going to insert a nasal prong. But before that, I will like to just emphasize it again that you have to assess the patient condition, see for patient's consciousness, how conscious is your patient, is she maintaining her cuff reflex, is she vomiting, and whatever her other problems is. Send a baseline ABG so that you should know what her present situation is and what is your target. You should wash your hands, prepare the equipment, your nasal cannula, oxygen tube, your oxygen flow meter, humidifier, all these things has to be prepared beforeward. And very important thing is that you should explain the procedure to the patient before putting anything to her face or to her nose. Please explain the procedure to the patient so that you can have patient's cooperation. If patient is a claustrophobic and you are putting a face mask, then she will not feel good, and there are high chances that she will remove it more often. And you have to attach the oxygen supply to the tube or humidify the cannula and face mask beforewards. At every 8 hours, you should do a oronasal care of the patient. So it's a very small video. Here it has been shown to the patient also that we are going to put oxygen prong to your nose, and you will be going to breathe easy after that, and it is securely put. So now what are the advantage and disadvantage of nasal cannula? The best thing is that it can be used in the home setting, and patient is able to talk, eat, vomit, anything, and there will not be much problem. Disadvantage, for a prolonged period, it will cause irritation to the nasal and pharyngeal mucosa, and in mouth breather, it is useless. So you have to specifically ask the patient to breathe from nose only. Face mask can be a simple face mask, partial rebreather mask, non-rebreather mask, or a Venturi mask. Venturi mask is a high flow device. But for all the face masks, there should not be any distortion in the face, and it has to be secured properly. The nasal clip, which is made up of metal, it has to be pinched, and the patient should have a good seal. Then only all these things will be effective. Simple based face mask also a disposable plastic device. They deliver 35% to 60% of the oxygen flow rate. I have already told you. If it is a best device if you need oxygen for less than 12 hours. So rest of the things are same. The only thing for both nasal cannula and face mask, it's preferable to keep the patient in a semi-fowler position. The patient is also comfortable and you are also comfortable, and you have to fit it securely. Very important thing is that there is pressure, there is moisture, so there is chances of facial rashes. So at every 2 to 3 hours, you should just remove the face mask and let the skin dry. And nursing people should be told that you don't have to powder the face, because patient will inhale the powder, and which is not a very good situation. So I'm just going to play this small video of a face mask. We have just secured the NST assembly, and then we have started the oxygen and we have put it on the patient's face. It has to come below chin, and the seal has to be very secure. Then only it is going to act. So advantage, for a short period of time, it's a very good device. Tight seal is required, it's a disadvantage, and facial rashes, wasting to be removed during the eating, drinking, and vomiting. Preferably at that time, you should use nasal cannula. Partial rebreather masks and a non-rebreather mask, they both have a reservoir which is of almost 600 to 1000 ml capacity. It must remain inflated during both inspiration and expiration. It collects the first part of the patient's exhaled air, and oxygen which it will be able to deliver will be almost 80%. And it has to be started minimum from 6 liter per minute up to 10 liter per minute. And to ensure that patient does not rebreathe the large amount of the exhaled air, and remaining exhaled air will exit through the vent. So how does it work? So it has just one valve. The oxygen is directed towards the reservoir, and the patient which it is going to inspire, it is from the gas from the bag or the room air. That is why first 1/3 of the expired gas will go into the bag, and that will be rebreathed. And dead space gases mixes with the oxygen which you are supplying. and it ultimately delivers the 60% of the oxygen. What is its advantage? Why we are using partial rebreather mask when we are having a non-rebreather mask also? That patient can inhale room air if oxygen supply is interrupted, which may occur at some circumstances. Disadvantage, they are all very claustrophobic and there is drying of the mucous membrane. Non-rebreather masks are having two type of valves. The mask provide the highest concentration of oxygen, we all know. And it is similar to the partial rebreather mask, except that it is also having one more valve, two valve. One way valve presents that oxygen is directly going to the patient respiratory system, and exhaled air is not going to mix in it. And valve over the exhalation port prevent the air entrainment. Air entrainment, I will tell you later. So bag is an oxygen reservoir. The important thing is that this bag does not has to collapse at any point of time. You have to specifically tell your patient this thing and check the valves and rubber flaps for functioning properly before putting the mask to the patient's face. Monitor your oxygen saturation on pulse oximeter and never allow anybody to squeeze the bag empty. So this is a small video how to start. This is a important video. You have connected with the oxygen supply first, and you have just connected the assembly. Unfurl the oxygen bag. Now you are going to fill this bag almost 1/3 to half with the oxygen before putting it to the patient's face. Or patient is going to exhale and fill this bag with the, although there is a valve with, so it is not going to inflate them. And securely fit it on the patient's face. And you have to tell this patient, this doctor is telling this patient that it need to be full. You don't have to squeeze it. So what is the advantage? Highest possible oxygen saturation is provided with it. It is suitable for the patient breathing spontaneously with severe hypoxemia. But impractical for a long-term therapy because it may build up oxygen and it may lead to little bit suffocation. It is expensive. It is not very. So the thing which decide your what devices you are going to use depends upon the patient condition. I have already told you about the respiratory rate. I have already told you about the tidal volume. The third thing is patient comfort and cost and her respiratory pattern. These are the things which will decide which device you are going to use.
So, Archana, you have nicely explained us, but do you think in these cases, before we plunge into the high flow system, I would like to ask you that what the doctor did in the emergency room, was it right? Because she started on simple mask, 3 liters per minute. Her oxygen saturation was only 82%. I believe.
No, ma'am, I don't think it's a good idea at this. Either she should have opted for a non-rebreather mask. And if it does not work, she should have, just because it was a case of type 1 respiratory failure, pulmonary edema. So I think that CPAP must have worked much better in that situation if they have to keep the patient there. But if they have to transfer the patient, at least they should have transferred it on a non-rebreather mask.
Okay. And another thing which I want to highlight is that you have also said that prescription, we have to understand at every level that oxygen supply is oxygen therapy is a prescription. It is a medicine. So it has to be given in a proper way, that how much to be started, which, device to be used, and what is your goal. So that all things should have been there in the prescription whenever their patient is being shifted from anywhere to any place. Because what we generally see, patients only, to the patients, everybody says, put oxygen, sister, oxygen laga do. So that should not be the treatment. That should not be our order. Our order has to be very, very specific. Now, I would like you to highlight about the fixed flow system, fixed performance system or high flow system. But generally in our emergencies, we are using the low flow system only. Only high flow system mostly is used in the cases in which there are chronic pulmonary diseases. So you can be a little short about this system, but and then we can, and then you tell me that whether this patient should have been intubated or not.
Yes, ma'am. I will be coming to that point. Just a little bit about the high flow system. So these are the Venturi masks. They work on Bernoulli's principle. So whenever a very high jet of oxygen goes through a very small orifice, so it causes air entrainment. So exhaled air will be exhaled out, and even room air will be inhaled in along with the oxygen. So these are fixed performance. So they are not depending upon the patient's breathing or her respiratory pattern. So the performance is specific, and chances of carbon dioxide retention is least. So in chronic pulmonary disease, it's a boon. And the liter flow is from 4 to 15 liter per minute. We can start from the Venturi masks. Venturi masks come in different setting. So these are color coding, and we can predict which amount of FiO2 they will be able to just they will provide to the patient. So advantage, most precise oxygen concentration does not dry mucous membrane. Disadvantages, these are uncomfortable and risk of respiratory depression in COPD because they are providing very high oxygen. The oxygen drive is very less. So respiratory depression also can occur if they are used for a very high concentration for a very prolonged period, more than 48 hours. ET tube, it can be used while weaning from the ventilator. It provides the accurate FiO2 and provides good humidity also. So now coming to the non-invasive ventilation has a very important role in obstetrics. So in the first picture I have shown you, there is a mask, there is a jet, and there's a securing mechanism. And second thing is showing you the CPAP machine or non-invasive ventilator machine. So these are the pictures where we are monitoring the patient's vital SpO2, and we can start it. So if in which condition BiPAP has to be started and which condition CPAP has to be started. I have already told you the patient was in pulmonary edema. So there is a lot of fluid. I'm just keeping it very simple. The patient is having a lot of pulmonary edema, a lot of fluid in her lungs, which has to be just washed off, or it has to be just kept out of the lungs. So we need constant positive airway pressure in this situation. The constant airway pressure, it can be started from 4 centimeter of water. So values are a little bit different here. It is 4 centimeter of water, and it can be increased by 5 centimeter of water. The highest limit is.
For my benefit of my obstetric colleagues, I would like you to highlight the difference between CPAP and BiPAP.
Okay, ma'am. I will be okay, ma'am. So BiPAP is better for COPD person, where inspiratory pressure and expiratory pressure is little bit different. So you have to start with a higher inspiratory pressure, that is 10 centimeter of water, and for expiratory pressure we keep it at 4, because patient has to be alert, patient has to be conscious. So these are the patients, and in type 2 failure, the BiPAP is very much beneficial. Both the pressures are different. CPAP is very much beneficial in the cases of sleep apnea and for acute type 1 failure. So pulmonary edema is the most common condition, or cardiac edema, which we are facing in our settings. So role of non-invasive ventilation, it is good for a conscious and alert patient who is maintaining cough reflex and who can protect its airway, because it's also like a mask. And mild to moderate respiratory failure is there, and pregnant woman is at a higher risk of aspiration, because this positive airway pressure is also going into your stomach. It causes stomach inflation. So there may be a risk of inflation. There may be risk of aspiration if patient vomits. That is why we need to just ensure the patient's consciousness and alertness.
Ma'am, we need to conclude soon, please.
Yeah, I am going to. So I have, I think, already covered these things. So there is no sedation required, adequate nutrition can be given, humidification is this. This is a very important slide. I would like to, and this is the answer of ma'am's question also. Which are the cases where we have to directly jump to the intubation, where we can see there is increased work of breathing, shallow respiration less than 8 per minute, inability to maintain PO2 of 70 mmHg, and SpO2 of 95% with mask, or even with NIV if we are not able to, because in pregnant patient, we need 95% of the SpO2. In chronic, the COPD patient, it can be from 88 to 92. But in these patients, we need higher. And GCS, that mental status is less than 8. The patient is not conscious properly. Hemodynamic instability is there. Patient is already on vasopressors. Inability to protect airway from vomiting, gastric lavage, and this thing. And if you see that patient is having normal PCOT, so sign of impending respiratory. Patient is breathing, not breathing at all. There's no carbon dioxide retention now. Severe metabolic derangement and cardiopulmonary arrest. We all know that we have to intubate the patient. So these are the advantages, disadvantages of intubation. We have already discussed it. So hazards of oxygen therapy. So drying of mucous membrane is one, depression of ventilation in COPD, and reversal of the compensatory hypoxic vasoconstriction. Atelectasis due to absorption collapse. Why does it occur? We are providing so much oxygen. Why would atelectasis occur? It will occur because in room air there is 78% nitrogen. And because of which our alveoli remain open because nitrogen is not absorbed. But when we are providing 95 to 100% of oxygen, it is absorbed and there is high chances of atelectasis. And oxygen toxicity may also occur. These are the symptoms of oxygen toxicity: non-productive cough, nausea, vomiting, substernal chest pain, fatigue, and all the other symptoms. So if patient is having oxygen concentration.
Let us summarize.
Yeah, ma'am, it's almost in the last, when we have to stop it, when the breathing pattern is normal and tidal volume and work of breathing is also normal, patient is pink, there is no confusion, disorientation, and rest of our ABG parameters all normal. So oxygen saturation is within normal limits. So this is the time when we have to taper and stop. Thank you for a patient hearing. I hope I have not
Archana, you have clearly
passed the limit.
I'll just summarize that we know oxygen at the room temperature is about 21%, and when we have to increase at 4%. It is increased by giving 1 liter per minute, and generally by up to 6 liter per minute we can use nasal cannula or a simple mask, and if it is requirement is more, then in those cases we have to use a non-breathable mask, or we have to use other means of ventilation. And important thing to see is that it should be in a prescribed format. That is the most important thing, that we have to give a prescription of oxygen and just not say that it is to be given like this. Whenever we want, what the rate of oxygen, the method of oxygen, the device which has to be used has to be very, very clearly identified and prescribed. Thank you.
Thank you, ma'am.
Thank you, Mittal ma'am, and thank you, Dr. Archana ma'am, for that very enlightening session on oxygen therapy. Now I would like to invite Dr. Jyotsna Suri ma'am. Ma'am is the convener of this workshop, and she's the force behind it. She's in charge of critical care obstetrics in Safdarjung Hospital, and she's the chairperson of the Safe Motherhood Committee of AOGD. Along with her, I would like to invite Dr. Niharika Dhiman. Ma'am is an associate professor at Maulana Azad Medical College, and she's also a member of the Safe Motherhood Committee and has many publications to her credit. Now over to Dr. Jyotsna Suri ma'am as an expert and Dr. Niharika Dhiman to touch on the practical aspects of ABG and bicarbonate therapy.
Thank you, Dr. Sheba. Dr. Niharika, you will be sharing the screen.
Yeah, thank you, Dr. Sheba, and I'll be sharing my screen now.
Yeah, so we'll have I think a very practical discussion we'll do about the ABG. We'll try to make it very simple for the audience because this is a little bit of a tough and tricky topic for those who are not used to seeing the ABGs routinely. So, Niharika, would you like to start by saying that what is the role of ABG in a critically ill patient?
Yes, ma'am. Thank you, ma'am. Thank you for giving me the opportunity. And yeah, so are my slides visible?
Yes, they are visible, very nicely visible.
So an ABG analysis, it is a diagnostic tool which helps in guiding our management, our treatment plan. It aids in our ventilation management and also helps in getting a normal acid-base balance. So basically, this is done by three things. An ABG gives us the acid-base status by the pH which it shows, by the ventilation, how much the patient is being perfused, by how is the ventilation.
Niharika, the slides are not moving.
Just a minute, ma'am.
It's only the first slide we are seeing.
I'll just share again. Okay, I'll just share again. Yeah. So Yeah, is it?
Yeah, we can see your, yes, it's visible now.
Yeah. So basically, acid-base analysis helps us in determining the acid-base status by the pH, the ventilation by the PaCO2, and the arterial oxygenation by the partial pressure of the oxygen.
Okay, so are there any physiological changes in pregnancy which make the interpretation of ABG different from that in the non-pregnant?
Yeah, so that's a very good question that has been put. So pregnancy is a state of respiratory alkalosis, a mild respiratory alkalosis with a normal pH and the maximum compensation done by the kidneys. So what we expect in respiratory alkalosis that the pH in pregnancy increases slightly with a narrower range, that is 7.4 to 7.46. The PCO2, partial pressure of carbon dioxide, is lesser, that is 27 to 34. The partial pressure of oxygen increases so as to provide more oxygenation to the mother as well as to the fetus, which is 95 to 105. The bicarb levels decrease because of more renal clearance, that is 18 to 21. And the saturation of oxygen increases to 95 to 100% as compared to 93 to 100% in a non-pregnant state.
Yes, thank you, Niharika. I think this slide everyone should memorize because only yesterday when I was seeing a patient who had collapsed in the labor room, whose PCO2 was 45. She was a pregnant woman, full term, and PO2, she had acute breathlessness. She had gone into pulmonary edema and her PCO2 was 45. So when I told my colleagues there, the residents, that she is having her PCO2 is high. So the first thing was, Madam, PCO2 40 is normal. So the thing is that if we don't know these, she was having a respiratory acidosis rather than metabolic. So it is very important that we should memorize that in pregnancy these changes take place. So the interpretation of the ABG should be done accordingly. Thank you, Niharika. So I would like now that we take step by step. How do we interpret? What are the steps? You tell in a very simplified way. How do we interpret an ABG?
Yes. So we'll try to keep it very simple so that we can interpret it easily. So just to have a base of how to interpret a ABG, we should always remember that in the body the bicarb acts as a base and carbon dioxide acts as the acid. So as the logic goes, metabolic acidosis will be primary decrease in the bicarb. Metabolic alkalosis will be the primary increase in bicarb, whereas respiratory acidosis would be a primary increase in CO2 and respiratory alkalosis would be a primary decrease in CO2. So just remember, bicarb is equivalent to the base in the body, carbon dioxide is equivalent to the acid in the body, and so you will be able to know what is the primary cause. So coming on to the stepwise interpretation of ABG, if we go by these steps, it is very easy to interpret a ABG very correctly. So the first step is, whenever you look at the ABG, look at the partial pressure of oxygen and the SpO2, whether it is normal or the patient is hypoxemic. Second step is look at the pH, whether it is acidotic, is it less than 7.35 or 7.4 in a pregnant patient, or it is alkalotic, that is levels are more than 7.47 in a pregnant patient or more than 7.45 in a non-pregnant patient. Third thing you're going to see is the partial pressure of carbon dioxide, whether is it altered, increased or decreased. So we need to know two things, whether it has caused the alteration in the pH or it is compensating the alteration in pH. Step 4 is, after looking at the partial pressure of carbon dioxide, you will look at the bicarb levels. Again, you will see whether it is altered, increased or decreased. Has the alteration been so much that it has caused a change in pH, or the alteration has not been so much, it has compensated for the cause. Second thing is to decide that this abnormal pH which we are seeing in the ABG is either because of the PCO2, which I have already told will be because of the respiratory cause. So your primary cause becomes the respiratory cause if it is because of PCO2, or because of bicarb if it is a metabolic cause. Next is to determine how much compensation is present. This is determined, see, we should remember that PCO2 and bicarb, they are like close friends. If there is alteration in one, or one causes the effect, the other is going to compensate for the effect. So if one of them has caused the effect, and there is change in the other component. So we need to, if there is a change in the other component, that means compensation is present. If there is no change, that means a compensation is not present. So we should always remember partial pressure of carbon dioxide and bicarb levels will help us determine which is the cause and which one is compensated. For cause and compensation, one will cause the cause and the other will cause the compensation. Yeah, ma'am. So a simple way to remember is by a mnemonic called as the Rome. So how to use this mnemonic? Once we have seen the ABG, what I do and what we do in our practice is we just make a table. We put in the pH, we put in the partial pressure of carbon dioxide, we put in the bicarb, and we just see from the ABG whether the pH is decreasing or PaCO2 is increasing. So if they are going in the opposite direction, then definitely the primary cause is respiratory. However, if the pH and bicarb are going in the same direction, that means they are having equal change, then the cause is primarily a metabolic cause. So that is how you can, easily remember whether it is the primary cause is respiratory or it is a metabolic cause.
Yes.
So Rome you should remember.
Yes. So you have very nicely explained. I think this is a very simple method for everyone to remember. And what about the formulae for compensation? Are there some formulae?
Yes, ma'am.
You would like to share?
Yeah, so we should remember, as we had mentioned in the 6th step of ABG, that we need to see whether whatever changes are happening in the pH, are it being compensated by the body or not. So, the body is very sensitive. It responds to even smaller changes in pH. And basically the system which are responsible for, for bringing about these changes are the buffers. The common one is the bicarb. The respiratory system, which can either wash out the carbon dioxide or retain the carbon dioxide to bring upon the necessary compensation, or the renal system, which can either cause more of excretion of H ions or bicarb, or can retain them. So that is how the buffer system works. And for these buffer system compensation to occur, we should know that the lungs and kidney should be in their normal working position. And one should remember that tends to return this compensation tends to return the pH back to normal, but never does it come back to complete normalcy, except in cases of primary respiratory alkalosis. So compensatory response, basically lack of compensation in time defines presence of a secondary primary disorders. If compensation is not happening appropriately, then there will be a second primary disorder. The compensatory response creates a second laboratory abnormality, and the appropriate degree of compensation can be predicted. This is a very important point. It can be predicted, and as ma'am said, there are formulas which can help us to know whether the compensation which is happening is appropriate or not. So these, it is difficult to memorize this table as such. So you can, keep a snapshot of these formulas.
I think all those who want to learn ABG and how to interpret this formula, you should keep in your phone as a ready reference. Once you keep doing the seeing the patients with and their ABGs, you will learn them by heart. But at the moment, it is difficult for you to remember. You should take a screenshot of this and keep it with you. So very well explained, Niharika. I think we should now discuss with this background. We could discuss a few genuine cases which have come for treatment in our hospital. So can you show the case? The next one we can discuss that.
So we can go on to the first case.
Yes. So this was Mrs. M, P3L3. She came on 24th October to our hospital, and she was referred from district hospital after she collapsed intraoperatively due to unsuspected placenta accreta spectrum. And she was a case of previous 3 cesarean section. So after the placenta did not come, probably it came out piecemeal, and she had severe PPH on the table and she collapsed. She came to the red zone of our hospital in an intubated state. And on examination, her peripheral pulses were not recordable, BP was not recordable. She was cold, clammy, and absolutely white. So next slide, please. Yeah, so the diagnosis we made was a hemorrhagic shock, hypovolemic shock due to the acute blood loss. Yeah, so this was the ABG, the first ABG at around 6:23 p.m. when she had come. So Niharika, would you like to comment on this ABG?
Yes, ma'am. So this was the immediate ABG which was done for this patient. So if we go on to the stepwise analysis of the ABG, as I've told you, so I'll be highlighting it. So first we see the partial pressure of oxygen, which is quite less. So it is less than 95, or I would say in a non-pregnant state, it is less than 85. So there is a condition of hypoxia in this patient. It is only 59.7. So coming on to the next step, we look at the, we look at the pH here. pH is 7.027, which shows a clear picture of acidosis, next, we see the partial pressure of carbon dioxide, which is 34 and which is on the lesser side. The bicarb, coming on to the bicarb, it is 8.5, which is quite less, which usually we take it as 22. So it has decreased tremendously. The lactate level is quite high. Normally we take it as 1.5 to 2. It is 9.5. So again, we draw this table here. So the pH is decreasing, and there is more decrease in bicarb as compared to the partial pressure of carbon dioxide. That means there is a clear, and they both are going in the same direction. So if you remember Rome now, both are equal, ME equal. So there, that means the primary cause is metabolic. So basically the diagnosis, metabolic acidemia with respiratory acidosis with hyperlactinemia. So coming on to the respiratory acidosis, why we have mentioned respiratory acidosis, and if you see at the arrow that I have put in the PCO2 box, it is a small one. So I just want to highlight here that the compensation, see, if bicarb is going to decrease, the CO2 will also decrease. They both are friends, I would say. So it will also decrease. So how much it has decreased to cause an appropriate compensation, that we'll find out with the formula that we are going to apply. So we are going to apply the Winter's formula here, as mentioned in the previous slide, which you can see is a simple formula. Here we need to identify. Now we need to use the Winter's formula, because PCO2 we need to calculate, which is the one which is being compensated. So if we use this formula, we see that the level comes out to be somewhere between 19 to 23. However, the PCO2 of the patient is 34.2. That means the compensation has not been appropriate, and it is giving a picture of respiratory acidosis here.
Yes, and that is the reason why her pH fell to 7.0, because if she had been compensated by the lungs, her pH would not have fallen. So this is very important, that because the lungs did not compensate, she went into a state of severe acidosis, not only metabolic, but respiratory component was also there. So you told that the bicarb was very low, and also that the pH was 7.0. So do we need to give her anything for this? What is the plan? How do we, because ABG is also guiding your management, how would you manage this patient?
Yes. So this is the diagnosis for this patient. So for the treatment plan, I would always like to highlight, I would like to highlight that you need to treat the basic cause first, which has caused the alteration in the ABG, rather than straight away treating the ABG. So what you need to do is you correct the hypertension in this patient, give her blood transfusion, correct the cause which is leading to the bleeding, and keep her well perfused. Because see, if the buffers are normal or the compensatory mechanism is maintained, then only the ABG is going to improve, and give her ventilatory support, which was very well done in this patient. So for correction of metabolic acidemia, which is present in this patient, and the bicarb levels are very low, what we need to do is we use a formula for correcting metabolic acidosis, which is bicarb deficit, which is calculated is by the deficit, that is the desired bicarb. Usually we take the desired bicarb as 22, and the measured bicarb, which is represented on the ABG, the bicarb which the ABG is showing, into 0.5 into the body weight in kgs. So what our aim is in correcting metabolic acidosis is to increase the pH to greater than 7.15. We do not give bicarb therapy if the pH is somewhere between 7.2 to 7.35. It is only given.
Why do we give bicarb correction only when it is below 7.15? Is there any reason?
Yes, ma'am. So why? Because see what happens when we give bicarb therapy, it produces carbon dioxide, and the effects of bicarb itself can have adverse effect on the system itself, causing hyponatremia, volume overload, hyperosmolarity. All these can be caused. So we do not give it beyond 7.2. So preferred pH.
7.15, I think this is the important message, that please don't rush to give bicarb to someone who has 7.3 pH or 7.25 pH. It is 7.15 unless there is also an added renal disorder. Then we do go, our threshold is little higher to give it. But otherwise, in those who are coming in hypovolemic shock, septic shock, keep the level to treat with bicarbonate as lower than 7.15. Now, Niharika, how would you, could you tell us how much bicarb you gave to this patient?
Yes, ma'am. So if we see, each ampule of bicarb is 10 ml in its volume, and it is 7.5% weight by volume. So it might look a little bit difficult how to calculate the exact thing, but you should roughly remember that 1 ml of this bicarb solution is equivalent to 1 milliequivalent. So what do we do with that formula? We calculate the total. I'll just tell you the basis of it. What we do, first we calculate the total dose, the deficit, bicarb deficit, which is required, and we do not administer the total dose. We only give the half dose in the initial 20 minutes in normal saline. How much amount of normal saline, that depends, how much hypovolemia your patient is in, or how much, the patient is likely to go into pulmonary edema. So we need not overload or hypoperfuse the patient. And what we do after 20 minutes, we are going to repeat the ABG and again apply the formula and correct accordingly. So our main aim is to give the minimum amount of bicarb that brings about the correction. So as we've already mentioned, there can be various side effects: hyponatremia, hyperosmolarity, volume overload, or increase in PaCO2. So what we did for this patient was, so if as I've told you, as per the formula, you can see that 22 is the normal value, the desired bicarb level. And for our patient, it was 8.5. So we subtract into 0.5 into 60 kgs. That was the weight of the patient. So the total amount comes out to be 405. So in the initial 20 minutes, we gave her 20 milligrams, which was half of the total dose. And so we had to take 20 ampules and dilute it in normal saline. You can even take 200 to 250 ml of normal saline, and you have to give it over 20 to 30 minutes. So that is how we corrected the bicarb in this patient.
Yes. So did we do a ABG after that?
Yes,
after
ma'am.
correction?
If you can see these two consecutive ABGs, one is at 6:30 p.m. when the patient got admitted. If we compare it to the ABG at 7:30, that was after 1 hour after giving bicarb correction, we see there is a lot of improvement in the pH. The pH increased to 7.2, which is a very good sign. Partial pressure of oxygen also increased, though a little bit on the higher side. She was intubated, so we need to see the settings. And the bicarb, however, remained same, but it did not drop further. And so the CO2, the bicarb also increased from 8.5 to 15.3, which is quite a good value. And the lactate levels, a very important point from the ABG is the additional information we get. The lactate levels have shown a falling trend. So ma'am, if you could just tell us whether, lactate, seeing lactate is how important for us. So
yeah, so lactate, Niharika, is a very important marker. It is a marker, first of all, when we see the patient, if the lactate is more than 4, we know that this patient is a very, very critical patient who has a risk for mortality. So the second thing is, so it helps in prognosticating, one thing. Next is that it helps in guiding the treatment. So once you know that the lactate is because of hypoperfusion to the tissues, you have given the fluids, you have given the blood, and you have given the fluid resuscitation, you have oxygenated her. So if your treatment is going in the right direction and the patient is responsive to your treatment, the lactate will fall, and this can be a guide to your further management. So now that here we are seeing that it has fallen, we know this patient is someone who is responding to our treatment. We should further carry on in the same direction, and she's not, someone who is irreversibly in damage. So it is a very good, encouraging sign for us. So lactate is a very important guide to see that you are going in the same direction. Plus, further, you know that you have to give her more. The fluid resuscitation is still going on. You have to continue, give more blood to her and blood products. So after this, have we taken another ABG after the next day? Okay.
Yes, ma'am. So this is the next day's ABG when we had actually managed
Yes.
her
We
containing
had
her
done
blood.
the hysterectomy for her.
Yeah.
Yeah, she was taken to OT. She was given 6 units of Paxil and 6 units of FFP, PRP. Hysterectomy was done, and then she was stabilized. And the next morning, after almost 12 hours of her arrival, this was the ABG in which we can see almost everything has come to normal except the lactate, which is still slightly higher, but it will take little bit time. But from 9.2 to 4.2 in 12 hours, it's a remarkable, I think, achievement. And the patient is already now discharged. She has gone home alive. So I think ABG is a very, very useful tool to help us in guiding the management. And also to make the diagnosis.
It would also, if you can see on the ABG, it has been written that the FiO2 is 40%, and the ABG picture has improved tremendously. So she is also candidate for extubation at this point of time.
Very good. That's a very valid point, Niharika, because PO2 is 171, so she doesn't need that much FiO2. So definitely she now is a candidate for weaning with this picture. Yes.
So, ma'am, we move on to the next case. We have 2 more cases.
I think we'll just do quickly because already we are running late. We'll do it in 2 minutes, the next case, and then finish it off. Yes.
So a 26-year-old woman with acute diarrhea is brought to the emergency room. Her BP is 105/65 in supine position and 75/35 in the sitting position. So this is her ABG, ma'am.
Okay, so the ABG which you are showing me again, the pH is low, 7.10, and the PCO2 is low. So both of them are going in the same direction. So the primary problem here is metabolic, as you told. Okay, so this is just a revision for everybody. So it is a metabolic acidemia. Now the next is we have to see whether adequate compensation has taken place. So by the Winter's formula, the expected PCO2 should be 1.5 into the bicarbonate level, that is 5.5 plus 8 plus minus 2. So it should be somewhere between this 14.2 to 18.2. Now, what is our PCO2? How much is ours?
So, ma'am, it's 18. For our patient, it's
this
18.
is hidden by the picture, so I couldn't see. Yes, ours is 18. So that means that there is a appropriate compensation by the respiratory, by the lungs. So this is a case of metabolic acidemia, appropriately compensated respiratory alkalosis is there. And the last thing which I want to highlight is about the anion gap. So here the anion gap, actually anion gap is calculated by sodium minus chloride plus bicarbonate. So here the anion gap is 10.5, which is normal. And anion gap is something we do to see what is the pathophysiology of the metabolic acidemia. So the normal anion gap metabolic acidemia is there, and the wide anion gap metabolic acidemia is there. If the anion gap is high, that means that additional acids have been added, as in lactic acidosis or keto acids or alcohol. And if it is a normal anion gap acidosis, there is a loss of bicarbonate, and the most typical histories of diarrhea. In diarrhea, we'll have a normal anion gap metabolic acidosis, as was seen in this patient. And also when we give lot of saline to the patient, again it is a hyperchloremic state, which also leads to a normal anion gap metabolic acidosis. So I think we'll end it here, and you can just read out the take-home message. We'll leave the last case.
So we skip the third case?
You tell the take-home message for everybody.
Okay, so So the take-home message is that ABG is an important tool in diagnosis and management of critically ill patient. It provides us with additional information of oxygenation, electrolytes levels, and the lactate levels. And administration of bicarb is only warranted when the pH falls below 7.15 in particular conditions. And lactate levels can guide us in management and prognosticating the patient. So we thank you all this. So ABG is a guiding light. It carries us through the darkness of our management during a critically ill patient.
Thank you so much, Niharika. I am really, really so proud of you that you have worked so hard and done this beautifully. Thank you.
Thank you, ma'am, for giving me this opportunity. And I always thank Team Safdarjung for, being there and guiding us throughout. And it's being like, it's coming back home. So thank you so much.
Thank you, Dr. Jyotsna ma'am, and thank you, Dr. Niharika ma'am, for that very crisp lecture on the importance of ABG interpretation and how do we go about it. So, not wasting much of time, now another cornerstone of management is fluid management in critically ill patients, and I would like to invite Dr. Rekha Bharti ma'am. She's an associate professor at Vardhaman Mahavir Medical College and Safdarjung Hospital. Ma'am is editor of Nachi Delhi branch and a member of Safe Motherhood Subcommittee of AOGT. Also, I would like Dr. Monica Gupta to invite Dr. Monica Gupta, ma'am. She's a professor at VMMC Safdarjung Hospital. Ma'am is secretary Nachi Delhi, and she's a fellow of urogynecology from UK, and she's special interest in critical care obstetrics. Both of them would tell us about fluid management and vasopressor therapy in shock. Over to Rekha ma'am and Monica ma'am.
Thank you, Shiba, for the kind introduction. And can you stop sharing your screen? Thank you. So, yes. So I have with me Dr. Monica Gupta, whom Shiba has very nicely introduced. So we start with the case presentation. Monica, could you just please tell us the main highlights of the case which we are going to take up today?
Thank you, Rekha ma'am, and thank you, Shiba, for the nice introduction. And ma'am, if I could just ask you to please share again, because it's not still visible, the slides.
Shiba, can you see my slides?
No, ma'am, you've started sharing, but we can't see your slides.
It has been paused. Why it has been paused? Sumit, can you just check?
Ma'am, you can double click it once again.
Meanwhile, I'll start describing the case, ma'am.
I'll do one thing. I'll again share it.
Yes.
Maybe.
Yes. Yes.
Yeah. So is it okay now?
Yes, ma'am.
Yes, ma'am. It's visible now.
Okay. Yeah. So this is our. Yes, Monica.
Okay. So after two very important discussions in critical care medicine, we come down to a very pertinent case for fluid therapy and use of vasopressors. So here we'll be describing a case of a patient who was a second para 2 L2 with 2 live issues, and she was referred to our hospital with a history of second stage cesarean for arrest of descent of head. And her cesarean and in fact the antenatal period were uneventful as per the referral slip, and on day 2 of her operation she developed breathlessness. And when we received her in our hospital, she was drowsy at the time of examination, and in the ABPU criteria she was responding to vocal commands. Her GCS was 14. She didn't have any pallor. She was afebrile, though her extremities were warm. Her pulse rate was 130 per minute. Feeble, blood pressure was 76 by 48 millimeter mercury. Mean arterial pressure being 57. Respiratory rate 34 per minute, and her oxygen saturation was 90% on room air. Chest was clear, and tachycardia is mentioned in cardiovascular examination, though there was no adventitious sound. In the local examination, we found that she had soft distension, diffuse tenderness all over the abdomen, lower abdomen, and her bowel sounds were sluggish. When we saw the dressing, we found that it had a dry, pulperish discoloration. And on removing it, we found that the discoloration was extending beyond the stitch line. So, pervaginally, she had foul smelling discharge. So, after having seen that,
so very clearly, Monica, you could make out that she is in frank sepsis and now she is in shock also. So what has already been done for the patient?
Yeah, so as you very rightly said, ma'am, suspecting septic shock, we in the emergency room, we started her with, since she was already carrying one IV line, we started another white bore 18 gauge IV line. Fluid resuscitation was started with ringalactate. She was given oxygen at 5 liter per minute. Broad spectrum antibiotics was started. She was catheterized, though it wasn't draining much of urine, and we decided to open the stitch line to let the collected pus drain.
So now the thing is, we are not going to take up the other aspects of the treatment, and we are just going to focus on the fluid management. So Monica, you just described this word fluid resuscitation. Like we are
Yes,
not
ma'am.
using that we started IV fluid. So what do we actually mean by this fluid resuscitation?
Ma'am, as the word suggests, resuscitation is like kind of reviving something, and we are using fluid here. So it's basically the fluid resuscitation is the administration of fluid. I mean, given rapidly and in boluses, like in huge chunks, to the patients and who have impaired hemodynamic status. This is the literal meaning of fluid resuscitation.
So very rightly said that you have to give it rapidly in boluses. So it is not just you start IV line and let the fluids be infused. So they have to be given very rapidly. So how do you decide that which are the patients who actually need this kind of resuscitation, fluid resuscitation?
Ideally, ma'am, fluid resuscitation would be required by people, by patients who are hemodynamically unstable. And of course, with the idea in mind that this provision of this fluid will mean that it will be providing oxygen, means oxygen delivery to tissues will improve after this fluid administration. That is the basic idea behind giving resuscitation to any
Yeah,
hemodynamically
so
unstable.
basically those patients who are fluid responsive, and responsiveness means that they need their resuscitation to the level of their tissues also, okay, to improve the tissue delivery, oxygen delivery to the tissue. Now, the next point comes is that how much fluid we should be administering. How should we administer fluids to these patients?
Ma'am, since we are here dealing case, we decided to follow the surviving sepsis guidelines, and it says that we should be giving 30 ml per kg body weight boluses of 1 to 2 liters in one go, and this whole amount should ideally be finished over.
Monica, is my screen visible to you?
Your screen is visible, but we can't hear Monica.
Acha, Monica's connection has gone bad. I thought there is some problem with my connection. So as she was describing till she joins, I'll just continue that according to the surviving sepsis guidelines, you should at least be infusing 30 ml per kg of the fluid. So which means if a patient is around 50 kgs, 2 liters of fluid you have to infuse. And in hypovolemic conditions like PPH, we all know that administration of fluid is also much faster, but we have to be careful in patients who have CHF or who have end-stage renal disease. So these are the cases, where you should not have be giving fluid large boluses. But yes, if the patient is in shock, you need to give fluids even to these patients. So next thing is like which fluids should be infused. So this is very important. We have so many fluids available with us. We have crystalloids, we have colloids. So the important thing is like which fluids should be given to these patients who come to us in shock. So there are advantages and disadvantages of both crystalloids and colloids. As we know that these crystalloids, they have low oncotic pressure, so they don't stay for very long in the intravascular compartment. So they go into the interstitial space, and they can also lead to pulmonary or cerebral edema, but still they are considered the first and the important fluids for initial resuscitation. And colloids, because they stay longer in the intravascular space, but then when they do go into the extravascular compartment in the interstitial space, they increase the oncotic pressure there. So the fluid transfer, which will be going into the interstitial space after that, will be much higher, but they still have some role in situations when you have massive blood loss and you are waiting for the blood products to be available. So the meta-analysis which has compared colloids and crystalloids, it has favored the crystalloids over colloids in respect to mortality. So the golden rule is to start initial resuscitation with crystalloids in all kind of shock, be it hypovolemic shock or be it septic shock. Then it is very important to know certain things, like about these crystalloids and colloids, that how they distribute themselves into the various spaces which are there. So this, if you see, the red thing is the actually intravascular space. So if you see on the top that 5% dextrose and dextrose saline, as soon as you infuse these, it goes into the extravascular space and then also enters into the intracellular compartment. And so, it can cause intracellular edema and can have complications related to that. And whereas if you see this 0.9% normal saline and ringer lactate solution, this also goes into the interstitial space, but then it doesn't enter into the intracellular compartment. So intracellular edema is less with this. And colloids, if you see, they generally retain inside the intravascular compartment. The duration for which they're going to stay in will vary. And now this is a chart, which basically depicts the composition of the plasma and compares it with two important fluids that we commonly use, the normal saline and the ringer lactate. So if you see the ringer lactate, it has more of, components of what the plasma has in relation to the pH, the sodium levels, even the chlorides. So this is one of the fluids which is preferred, but normal saline is also a good option. And these two fluids have basically one more advantage of being cheap and easily available. But the problem with the normal saline is that you have to watch for hyperchloremia, chloremic acidosis if you are giving too much of saline. Nowadays, even plasma light A is the solution which I have written in the end, which is considered to be isoosmolar with the plasma. And buffered saline solution is also one solution which is available and a very good option to be there. So this is basically, regarding the various colloid solutions which we have, that how much time duration they are going to stay inside the intravascular compartment. So if you see 4 to 5% albumin and 20 to 25% albumin, it stays for almost a day in the intravascular compartment. So, but dextran, it goes within 1 to 2 hours into the interstitial space. Hence, it has one, like the many studies have shown, especially if you are resuscitating patients who have septic shock, HES should not be used because it is associated with higher mortality and kidney injuries in patients of sepsis. So now the next question which arises is that how to determine, like we have started fluids, we are giving fluids, we have calculated that this much amount of the fluid is to be given, but for how long this initial resuscitation would continue. So at times, we have patients who are being referred from other hospitals and they have already received some amount of fluid and which is not properly documented. So when they reach us, we again start a fluid resuscitation initially because they are in the shock. But then how do we know that now is the time when we should go for other modalities and the fluid resuscitation initial phase is complete and the maintenance phase has to be started? Because very important thing is that these patients, they go into acute kidney injuries very fast because maybe because of hypovolemia or because of sepsis. So there are various things, which tell us about the tissue and organ perfusion, which includes mean arterial pressure, the urine output, capillary filling time, and various mixed venous oxygen saturation. So these options are available. So the surviving sepsis guidelines, they say that you monitor the mean arterial pressure of the patient. If it is more than 65 and patient starts having urine output of more than 0.5 ml per kg per hour, and her central venous pressure reaches 8 to 12 millimeter of mercury, there is normalization of the lactate, and then maybe that the initial resuscitation is complete. But we have seen over time that this mean arterial pressure only and CVP may not be very good indicator of telling us about the fluid responsiveness. So we have to have other parameters we should consider. So these are the tests which we say they are the dynamic tests for assessing the fluid responsiveness. So they don't need any invasive testing basically. So you can do them as bedside test also. So very simple test which is available is passive leg raising test. Now, you know, this test is more or less like the fluid challenge test which we give. But when you are not sure of continuing with the fluid challenges because of certain conditions, maybe the patient has hypertensive disorders of pregnancy, so you don't want to push in too much of fluids to the patient, or maybe you do not know initial fluids that she has received, or maybe you have already given her enough fluid and now you want to know that how should you be assessing the further fluid responsiveness of these patients. So this is a test which is available. So what you basically do in this is you take the blood pressure of the patient in with the head raising at 45 degrees, and then you raise the legs to 45 degrees. Now the important thing is when you are shifting the position of the patient, it should be done rapidly. It is not that very slowly, you know, you take your time and shifting. So it has to be done rapidly so that the fluid from the legs, it comes into the intravascular compartments, and you see it as a change in the pulse pressure. So when we say pulse pressure, this means the systolic minus the diastolic blood pressure. So if with the passive leg raise test, which actually leads to around 250 to 500 ml of the fluid coming into the intravascular compartment, it is equivalent to 250 to 500 ml IV bolus which we give. So it changes the pulse pressure. If pulse pressure increases by 9% or more than that, it means the patient still needs fluid. The main advantage of doing this passive leg raise test over giving the fluid bolus is that it is reversible. See, if your patient has was not fluid responsive and you give her fluid, there are chances the patient may go into pulmonary edema and have other complications related to overloading. But with the passive leg raising test, the moment you straighten the patient, the fluid is going to come back into the pooling is going to occur in the legs. So this is a reversible method. So next thing is, Monica, are you back? You want to continue?
Yeah, ma'am, I'm back.
Yeah.
Sorry for the technical issue.
It's okay. So we have described the passive leg raising. So you can tell us about the second test of this dynamic test, which is available for fluid responsiveness.
Yeah, so a very important other test of dynamic test for fluid responsiveness is this ultrasound method which we have, and there we see the IVC collapsibility. Now, what we do is that we position the patient in supine position and obtain a sub-xiphoid view of the heart and identify the right atrium. And after identifying, turn the probe to 90-degree clockwise, counterclockwise to identify the IVC, where it enters the right atrium. And the point where we have to actually measure it is somewhere around 2 centimeters from the right atrium. And what exactly is to be seen is, we know that the IVC diameter is around 1.5 to 2.5 centimeter. Whenever it is less than 2 centimeter at the end of expiration, it suggests volume depletion. And if it is more than 2.5 centimeter, it suggests volume overload. So this difference, and ideally collapsibility is the maximum diameter minus the minimum diameter over the mean diameter into 100. So we will get a figure in percentage. If this is greater than 12%, we can kind of conclude that the patient will be fluid responsive. So this is one very important test and very reliable as well. The other test,
So
which is
this we have actually talked about the pulse pressure variation. So this is
just one very
the,
small thing that
yes.
whenever the patient is sedated or ventilated, this test of pulse pressure variation is a very good indicator. Pulse pressure variation and stroke volume variation in both inspiratory expiratory cycle. This variation is a good indicator even in sedated patients.
Yeah, and you know, it has been found in a systematic review of 29 studies that this pulse pressure variation, it is a better indicator of fluid responsiveness than the central venous pressure. And you don't need any invasive monitoring in this. You don't have to put a CVP line in this. and just calculate by the difference in the pulse pressure. So this method, just calculate it and you can know that patient is fluid responsive. So now, Monica, this patient has been with us for an hour and we have given her around 1.5 liter of fluids, but still her heart rate is 128 per minute. Mean arterial pressure is 60 millimeter of mercury, respiratory rate is 30. SpO2 has marginally picked up to 90%. So patient, we have found out by our test of, these tests that patient is still fluid responsive and we are continuing with the fluid resuscitation. So what should be done next for this patient? Should we just wait for the time we give her further fluids and or what else can be done in this patient who was in septic shock?
Ma'am, as per the given information, even in 1 hour, we have not been able to achieve a mean arterial pressure of 65, which is kind of the index to show that the patient is being adequately resuscitated. So she needs further resuscitation, and if bolus is not helping, then now is the time to probably add vasopressors. Basically, they are indicated in septic shock after starting fluid resuscitation once we find that the bolus is not adequately helping raise the mean arterial pressure, and we'll have to titrate it for a target of 65 millimeter mercury mean arterial pressure, and of course adequate urine output and alert mental status or an improvement in the mental status, which is other index.
So this is very important, that we do not wait for the fluid to be complete fluid to be infused to the patient, which may take 2 to 3 hours. And in septic shock, it is important that you start the vasopressors early. So it is important that, at 1 hour or maybe before that also, you may take a decision, but you are still going on with you are continuing with the fluid resuscitation. But in the meantime, you start vasopressor. But here is a catch here, that patients who are in hypovolemic shock, it is better to transfuse them fluids and other products, whatever are required according to the cause of the hypovolemic shock, rather than going on to these vasopressors very early. So there, fluid should be very rapidly given and you should concentrate at that rather than starting the vasopressors early. But in septic shock, these do help because there is peripheral vasodilatation, which we all know. Whereas in the hypovolemic shock, there will be vasoconstriction. So we don't want to constrict them further. We want to give them fluid first, and then maybe
in
if
fact,
further required, yes.
In fact, if hypovolemic shock is because of massive hemorrhage, we have to be particular that fluid cannot substitute for blood. And we have to make sure that adequate amount of blood is available soon. And as soon as we have blood in hand, the replenishment has to be through blood. And we should not keep on relying with the crystalloids.
So here, you can consider after you have given around 1.5 to 2 liters of fluid in hypovolemic shock, you can consider of giving colloid 500 ml if you are still waiting for blood. So here is the role of colloids in these patients. Yes, so could you, Monica, just tell us about the doses? And very important thing is, we all read, this is the dose which should be given and how it should be increased. But at times it is very difficult to calculate this dose and convert it into, how much ml of these doses which you will give them. So can you just describe these things? How will you calculate?
Yes, ma'am. Before describing the dose, I would just like to reiterate to everybody that in septic shock, the drug of choice and the vasopressor of choice would be noradrenaline, not dopamine, which is sometimes the routinely used drug. Dopamine is mainly used in the cardiogenic shock. The shock where we have a cardiogenic involvement. So the noradrenaline, as we all know, is a potent alpha-adrenergic agonist, and the ideal starting dose is 0.1 microgram per kg per minute. But the range is from 0.2 to 1.35. And we should know that in septic shock and things and conditions of sepsis, we have to use a higher dose. So we start with somewhere around 3 to 3.3 microgram per kg per minute. Because there is an element of alpha receptor downregulation in septic shock. So the commonly available ampules we have in our ICUs and HDUs is a 2 ml ampule, which has generally the weight is, as you can see in this diagram, the weight is not written, but it is written 0.2% weight by volume. concentration of the drug in 2 ml of ampule. Now, if we go on, there is a whole lot of calculation involved, but 0.2% weight by volume means that it has 2 milligram in every ml. And thus the 2 ml ampule, what we have usually available, will have 4 milligram of drug in total available. Now, how we can give this drug? The best would be in settings of ICU and HDUs. We can give this by infusion pump, which you can see to the left of your screen. They can be easily mounted on an IV stand and placed right next to the bed of the patient. Or if this is not available, then on to the right of your screen are the simple dial flow infusion sets. Now, why this dial is important is that you can actually regulate the amount being given and the rate being given over an hour. Now, this infusion pump, if you can see, ma'am, could you just please go back? Yeah. So in this infusion pump, there is this slot, this orange knob, which you can see. Here is the infusion syringe. Usually we take 50 ml syringe, which we adjust here, and then there is a tubing attached to that syringe, which goes into the IV access of the patient. And as far as the dose calculation is concerned, a simple formula is, especially for infusions, 1 ampule of NORAD, as I said, has 2 milligram per ml of drug. We take 2 such ampules, making 4 ml of adrenaline in 46 ml of dextrose normal saline or 5% dextrose. These, we have to remember, these are the 2 fluids used for dilution of noradrenaline to make a 50 ml solution. Now, this syringe is fit onto the infusion pump, and the calculated concentration of this solution will be 160 microgram per ml. Now, how do we calculate how much to be given? Is in accordance to the dose which is required. Suppose, for an example, for starting, if we need 8 microgram per minute to be given to an average pregnant patient in our HDU, so the dose will be calculated as desired dose over the drug concentration of the solution which we have into 60, that is to get a per hour ml rate. And the calculation as given at the end of the slide, you all can see, would even eventually amount to around 3 ml per hour. So if you go on to the next slide, ma'am, you can see that here on to the left of this column, this black column where 16.0 is written, here is the place where we adjust the ml per hour. And the column, the indicator next to that indicator in green shows us what drug is being given and how many ml of that drug has been taken, the drug concentration. And rest are the keys where you can adjust the rate and other things for this particular drug. And this infusion pump has inbuilt memory with all these types of vasopressors and other essential drugs which can be given through infusion. And this index is already inbuilt in that. So this is in short how we use the infusion pumps for vasopressors. And
So
if we
now,
don't have,
Monica, so
if we
it is,
don't have
basically-
infusion pump, in that case, we can simply calculate the drip rate as per, and I would again suggest that we should be using that micro drip set, because it's a very important drug. We cannot just let it flow inadvertently in huge volumes. So we should use a drip rate, micro drip set, which provides 60 drops in 1 ml. For that infusion pump, this is the simple calculation. 1 ampule of the drug is, as I previously described, has 2 ml and has 2 milligram per ml concentration. We dilute 2 such ampules in 100 ml of 5% dextrose or dextrose normal saline, and for a starting dose of 3 microgram per kg per minute in a 60 kg female, this 180 microgram will be the total dose to be given. And if we convert into milligram, it will be like 0.18 milligram per minute. Now, what we have to calculate is how much ml will be required to be given to deliver this dose. And very simply, that can be calculated as, because we have a total 100 ml solution, so 0.18 milligram will be given in 2.25 ml of that solution. And to calculate the drip rate for that, we can simply multiply it by 60, because in a micro drip set, 1 ml is given by 60 drops. So this will come out to be 135 drops per minute, which can be easily titrated. And in the dialoflow, when we have ml per hour to be given, there we can adjust it after converting into per hour calculation through a dialoflow, which is given at the end.
So very well said, Monica. When the patient comes in emergency room, many of the times we don't have infusion pumps available there. So while shifting, you can go on with these dial flow, and then when the patient is stabilized in the HQ, then you can shift over to the infusion pumps. So like now these patients, it is quite possible, especially in the patients who come to us late, or where some patients, was at some other health facility, and when they reach there, you give all these things, but still patients are not responding. You have started the vasopressors, you have given the fluid resuscitation. So what are the other options for these patients?
As per the consultations we keep having with the intensivist as well, the next vasopressor to be added if Ednoret is not helping is ideally vasopressin. And if even these two are not helping, then we should resort to dopamine, thinking about that there is some probably cardiogenic issue which has set in, and it will now help the patient for this thing, for helping improve her hemodynamic status.
We are not basically going into the details of further management of septic shock, which may involve many other, supportive therapies, because we are restricting ourselves to the fluid management and vasopressors. So now, because dopamine is otherwise used to be a very commonly used drug in the past, but now we all know that for as a vasopressor, it is more of an inotrope than a vasopressor. So it can even lead to tachyarrhythmias. So as obstetricians, because initially we had all used dopamine for low blood pressure, for shock patients and all. So we should all know. So this is very important that all of us should know that dopamine will lead to further tachycardia of these patients who are already compromised. And so you have to be very careful with the drug. It can be later on combined if indicated, but it should not be the initial drug of choice. And
Yes,
especially we should all remember it is not a vasopressor, it is an inotrope. So this is very important thing which is to be done. So I think we summarize, because we are already going, we are short of time now. So in summary, I would just like to say that whenever a patient of shock is managed, there are 5 pitfalls. And this is something, which as clinician and especially as obstetricians, because we have so many patients of shock coming to us, we should all know. So first thing is the failure to diagnose shock. So because, we all know the management of shock, we all keep attending and updating ourselves. So we know that what is to be done. But many a times it happens that there is failure to diagnose shock, and this mainly happens in patients of septic shock, because in hypovolemic shock, maybe it's a concealed hemorrhage, or it is a revealed hemorrhage, or loss of fluids in some other way. It is evident, so you can make that out. Okay, so there we all are, we know that we have to give push in fluids and all, but septic shock is one thing, which is very commonly missed shock. So this is one very important thing, that we should be very vigilant to diagnose shock. Now, second thing is that as clinician, since our training as interns and all, we are taught to take systolic blood pressure. So I even remember, when we were young, so we used to just by palpatory method, we were taking that systolic blood pressure is 90 or it is 96, and we used to feel no, patient is okay, not very bad. So it is high time that we should shift over to mean arterial pressure rather than, sticking on to systolic blood pressure measurement. Second thing is that lack of enthusiasm in treating shock. So this is one thing, shock is not a condition, where you can be lax. Like a whole of your team, including your nursing staff, they have to be very enthusiastically, and it has to be aggressively treated. So this is one very important thing, that it should be on war footing. It should just not be मैंने order कर दिया, sister ने लगाया नहीं, cannula नहीं लगा. So this is very important things, even as a consultant, even if you have to do something for the patient to start the treatment, and it has to be very aggressive therapy. Now the second thing is, which happens, now we know fluid has to be given, and aggressively we give fluid also. So too much of everything also is harmful. So if you are giving administering fluid without assessing the patient, whether she needs further fluids or not, then also it can be harmful. So we have seen it in many cases, like in pulmonary, hypertensive cases. Many a times, it has happened with us. The patient was taken up for cesarean section, and during spinal, she had some drop in blood pressure, and anesthetist gave fluids, just to resuscitate the patient at that time. And in the post-op period also, without realizing that how much fluid patient has already received, and considering that they have constriction of the intravascular compartment, we keep giving them fluid as we give in any other post-op patient. So we never calculate the fluid amount which has been given, and we never assess now whether patient is fluid responsive or it is some other modalities which we have to switch on to. So it is very important. So it is a very simple test of passive leg raising test, because I can understand IVC collapsibility because a special machine is required. You may not have it in your wards or in your labor rooms, and most of the HDUs also are not equipped. So there it may be a problem, but passive leg raising is a very simple test. The only thing which you have to remember is that you have to rapidly change the position of the patient. That is very important, because if you gradually change, it is something like giving fluids gradually to the patient. So you want to give a bolus, so the change of the position has to be rapid. So this is very important thing here. And then second thing is, that as I said, we should be relying more on mean arterial pressure. Another important parameter which we should be calculating for all patients is, and we don't need any other, basically to do any other test on the patient. It is a simple heart rate and blood pressure which we are taking those into consideration. We should calculate the shock index.
Shock index.
So shock index is a very good predictor of hyperlactemia also. So even before you get your ABG and all, you know that this patient will be having high lactates and all, and the chances of mortality or severe morbidity are very high. So if you calculate shock index, you know where your patient should be treated, whether the patient can go to a labor room or a ward, or patient needs HDU care. So this is one very important index which as obstetrician we should all be careful, and that we should calculate this index, and where the patient should be cared should be looked after by assessing patient as a whole. So this is something which I just wanted to mention as a take home message.
Just a small thing.
Yeah, sure.
For those who are wondering that mean arterial, since we have now to shift on to mean arterial pressure, and those who don't have probably a multi-channel monitor which automatically detects it electronically. It's a simple calculation. It's diastolic blood pressure plus 1/3 of pulse pressure, which is systolic minus diastolic. So it can simply be calculated on bedside whenever we are doing such kind of tests and variation.
Yeah. So it is systolic plus twice the diastolic divided by 3.
It's
Yes.
That is
So
a
this
combined equation. If we know the pulse pressure, then it is just diastolic blood pressure plus 1/3 of pulse pressure.
So, chalo, we are lucky, now the
those monitors are there.
BPs are
Exactly.
so we get, but
and
still,
we are so much used to see them on monitor.
But then still, despite being displayed, we are not used to take it into consideration. So this is something which is very important.
Very important.
So with this, I would like to thank Monica for being such a, enthusiastic and
thanks to you, ma'am, for getting.
I was very lucky to have you with me. So thank you so much. And
this is all right, ma'am. And
audience,
thanks to the Jyotsna ma'am to give me this opportunity to discuss this case. Thank you so much, ma'am.
Thank you to all the experts and all the speakers for a very enlightening session touching all the aspects of critical care obstetrics. And now we quickly move to our keynote address, and I would pass on to Dr. Rekha for introducing the sponsored session, that is the keynote address.
Thank you, Shiba. So now we move on to our next session, which is also a sponsored session. And we are thankful to Plus Life Sciences, who have kindly agreed to sponsor this session. And to chair the session, I would like to invite on Dr. Bindu Bajaj. She is a professor and consultant at Safdarjung Hospital, and she has done WHO fellowship in high risk pregnancy in 2007. So since then, she is involved in the management of high risk pregnant patients, and also she is in charge of our fertility clinic, which is very soon going to be converted into IVF center. So I welcome Dr. Bindu as the chairperson for this session. And next, I would like to invite on Dr. Zutshi. So, just by looking at the slide which she has given us to share, we can make out that she is such a well-known personality that she needs no introduction. She has hardly written anything on her slide, though basically she is a gynecologic oncologist, but she has been active in all aspects, like be it ward rounds, be it HQ, care of patients or anything. Like she has a vast experience in whole of the obstetrics and gynecology. So I welcome ma'am. And she is also unit in charge in the Department of Obstetrics and Gynae at Subdivision Hospital. Dr. Anjali Dabral, we have already heard to her before also, and she is our head of the Department of Subdivision Hospital. And madam is also very actively involved, and she supports our these critical care activities, and she has always been a source of support to our team. So I welcome all three chairpersons for this very important session on the keynote address. So welcome, ma'am.
Hello. Am I audible?
Yes, ma'am,
Yes,
you're
ma'am.
audible.
It is my proud privilege to introduce Dr. J.C. Suri. Sir has given his unstinted support as former consultant professor and HOD of pulmonary critical care and sleep medicine in bringing up the present obstetric CCU in our hospital, Sadhajang Hospital. He is the editor-in-chief, Indian Journal of Sleep Medicine, ex-president, National College of Chest Physicians, vice president of Asian Society of Sleep Medicine, founder, president, and chairman, Indian Sleep Disorders Association. Presently, with COVID pandemic, he is the member of the expert committee constituted by Ministry of Health and Family Welfare, Government of India, to reassess the clinical management protocols for COVID-19 patients. Sir is also a member of task force on COVID-19 constituted by Ministry of Health and Family Welfare, Government of India. He is the national advisor to DCGI. At present, he is the director, Department of Pulmonary Critical Care and Sleep Medicine at Fortis Hospital, Vasant Kunj, New Delhi. Welcome, sir. We are honored to have you with us today for the keynote address on acute respiratory failure in pregnancy, what the obstetrician should know.
Thank you, Dr. Jussi, for this nice introduction. Actually, I have been watching the last three presentations, and I was so much impressed the way the ABG was being discussed, the way the fluid management was discussed, and much more than that, the way oxygen therapy was being discussed. I think they were, discussed in such perfection that any critical care specialist or a pulmonologist would envy. So I don't think I should give all credit to Dr. Pratima Mittal for taking this initiative and starting this unit. I feel really proud and privileged to have made a small contribution to that. But what I see, my original presentations on oxygen therapy and ABG, they have been evolved and improved and taken to such next level by you people that I have myself was quite surprised and learned a lot of things from those presentations. So thank you very much for taking critical care obstetrics to this level, and thank you very much for this invitation. I think in my presentation, most of the things have been discussed by the previous speakers. Let me put those things together. I would like to be very simple in my presentation because I don't want to teach this subject to obstetricians who already know a lot about this thing. So I'll just add my experience to what has been discussed, because I thought the individual differential diagnosis for acute respiratory failure, like preeclampsia, cardiomyopathy, you people know more than I can discuss with you. Little bit about asthma or ARDS, that of course, you can actually involve a pulmonologist as a part of the team. So I personally feel that this topic is my screen visible?
Yes, sir.
Screen is visible, no?
Yes,
okay.
sir.
Yeah. So what I'm basically going to do is a little bit talk about how important is acute respiratory failure in obstetric practice. What are the differential diagnoses one should look for, and how quickly one should actually evaluate this patient to get into the exact diagnosis, so that the specific management can be directed to the case. But what is more important is actually the initial management, because the initial management is going to be same, whatever may be the underlying etiology for acute respiratory failure. And that is, I think, is the most important thing. So I'll be just about the magnitude. You can say about fewer than 2% of women require actually admission to an intensive care unit. But I think looking into the number of deliveries conducted, particularly in Safdarjung Hospital and other major hospitals, this number can be quite significant. People going into requiring intensive care, 2%. So every 100 deliveries conducted, so you actually really need a much bigger HDO or an intensive care unit. And if you look overall, 1 in 1,000 or maybe 2 in 1,000 people may require mechanical ventilation. But again, though it may look to be a rare complication, maybe in the Western literature, but I think from the Indian point of view, this is quite significant, and having a separate obstetric ICU and learning about the general management, as was discussed in the previous lectures, it's really a very, very important, I think, asset which you people have acquired, and I think you don't need the assistance of any other intensivist, this thing. So, and because by the time you have a patient, by the time, as Dr. Rekha was telling, you recognize, which is actually very late in recognizing that your patient is in respiratory failure or in shock. By the time the patient is shifted, it's already too late to manage, because they have already gone into irreversible shock. So that's why, if you know these principles, if you have the setup, if you have the facility, if you have the equipment, then you can, manage this patient, early. And that's actually, the time is the essence here, time is life. And if you manage, particularly the fluid resuscitation, if it is done early, effectively, and rapidly, that can actually, save this patient. So you can see that this failure, acute respiratory failure, is a significant cause of morbidity and mortality. So why there is an increased morbidity and mortality in pregnant women? I think to understand that, we must know the basic physiological changes which take place. We know that there is almost 30 to 45% increase in cardiac output. There is also an increase in the minute ventilation. So when the minute ventilation goes up, the PCO2 falls, because PCO2 levels are directly linked with the minute ventilation. So when the PCO2 is low, there is a chronic respiratory alkalosis, and with alkalosis, you can see the bicarbonate goes down. But the question is that why should we need this in pregnancy? Why should we have a low PCO2 and alkalosis? Because we need to have much higher PO2. So you can see that the PO2 is between 100 to 110, as against other non-pregnant individual, it will be between 95 to 100. So that means you need more PO2 for the fetus, and the PO2 which is required to define acute respiratory failure. Normally, in non-pregnant individual, we take it as 60 millimeters of mercury, but in pregnant women, we take it 70. And we will define acute respiratory failure, if you want to use pulse oximeter, below 90%, but in pregnant women, it is 95%. So this is a very important adaptation which one has to understand. So with the increase in the cardiac output, with the increase in the minute ventilation, that means you are already encroaching on your reserve. So these patients have very less reserve available to them in case of emergency. That's why they break down, they decompensate, and they become critically ill, because they are like athletes. They are using their reserve, almost going to 75% of the total reserve. They are there, and they may not be able to increase further. And particularly, if they develop some kind of a problem which compromises their ability to increase cardiac output, like if they have cardiomyopathy, postpartum cardiomyopathy, or if they have a situation like a valvular heart disease. So any kind of limitation, or if they develop a respiratory disease like acute asthma or pulmonary edema or ARDS, so they become suddenly, they become decompensated because they are not able to meet even the physiological demands of the growing fetus, or the pathological condition, because in shock, or this thing, or even a mild illness like pneumonia or ARDS or pulmonary edema, you need to increase your minute ventilation. You need to increase your cardiac output to provide that kind of oxygen to the tissues. So that ability is not there in them. So that's the reason. And then their oxygen consumption is high. They have reduced FRC. Their lungs are smaller because of the diaphragms are up, and because of the enlarging uterus. So they have less capacity that way, more demand. They are working at a higher level. They also have a decreased lower esophageal sphincter tone, which makes them vulnerable for regurgitation and aspiration. And also they have decreased chest wall compliance. Again, that puts them into a situation where their ability to increase their minute ventilation is compromised. So you can see, there is a double way. Once there is an increased demand, and second situation is that there is a decreased ability so their actual capacity is going down and their demand is going up. That's the reason for increased mortality and morbidity in pregnancy. So the reason is physiological changes in pregnancy, reduce respiratory and metabolic reserve because you are already going up, you're using much more of it, presence of fetus, difficult airway because their upper airway is edematous. So their airway is narrowed. In case they need intubation, it is a difficult intubation. So you have to probably do it with maybe bronchoscope, or with the help of, you need an experienced person to do it. Risk of aspiration, as I told you, because the lower esophageal sphincter is patent, autocable compression during resuscitation. So they need to be done with a board and in their left lateral position. And overall, then, there are pregnancy-related complications like preeclampsia, where the pathophysiology is not true. So if you don't know the pathophysiology of a person, it is very difficult to manage them because you don't know how to manage them on the basis of their pathophysiology. So if you look into the etiologies or the risk factors for development, then definitely they are the factors which are there before they were pregnant, like pre-existing pre-pregnancy conditions like cardiovascular disease, hypertension, ischemic heart disease, congenital heart disease, valvular diseases, arrhythmias, cardiomyopathies, obesities. So these are all, factors which are there. And then there are problems which are specific to pregnancy. That means they will develop during the course of pregnancy, like preeclampsia, postpartum or peripartum cardiomyopathy, sepsis, preterm labor, amniotic fluid or pulmonary embolism. So then there are other things like you have drugs, and I think one of the most important thing which Dr. Rekha Bharti was again mentioning is the over-jealous use of fluids. If you are giving fluids more than 2 liters to any patient, you should always be careful, because many of these pregnant women during their late pregnancies or in their peripartum period, which I have seen, in my practice, they have some degree of cardiomyopathy, which you may actually miss. You may not be able to diagnose it clinically. So if you give them fluid, they decompensate. They go into pulmonary edema. Their heart dilates. So it's a kind of a stress test. So if you give a kind of fluid even which you are giving to your other normal patients, and this patient decompensates, always suspect that this may be a subclinical cardiomyopathy or decrease in this thing. So fluid, I think, treatment has to be very, very careful. And whenever you give fluid, you should assess your patient, and you should know how much to be given and what is the requirement of the patient. So these are, I think, the important factors which have already been this thing. And of course, timing factors, as you see, as I was mentioning to you, fluid overload. So it will come in the postpartum period. 9, you can see the number of patients. There are some things which are drugs like more in the antepartum period, some in the intrapartum period. So by their basic, nature of the problem, you can see that when the problem is occurring, when the patient is developing acute respiratory failure or pulmonary edema, then that can give you some idea about this thing. Then of course there are many conditions you may actually diagnose for the first time during the peripartum period, like mitral stenosis. This patient may have had rheumatic heart disease undiagnosed. They may be having mitral stenosis, and first time you will diagnose this as case of mitral stenosis during delivery or during peripartum period, because you have given fluids, or the patient has required a very high cardiac output during labor, and they go into pulmonary edema for this thing. So these are things, and global hypokinesia. First time you will see, as I mentioned to you, that they may have subclinical cardiomyopathy, and the moment you stress them, they decompensate and develop this kind of problem. So these are the things probably obstetricians will be diagnosing for the first time in the patient's life, and then passing on the patient to the cardiologist. So that's why it's very important to know at least basically how to pick them up during this thing. And it is very simple, as I'll tell you with one of my case, which I'm going to show. And the causes, you can see, again, of course, without hypertension and with hypertension, you all know about this, the pre-existing cardiac disease, pregnancy associated cardiac disease, aspiration. These are usually respiratory failure without hypertension, and those with hypertension, you can see the chronic hypertension, preeclampsia, eclampsia, intake of illicit drugs. So these are the situation where you are finding. And of course, as I told you, that preeclampsia is another condition. Again, we do not know what exactly is the pathophysiology in the heart, whether they have increased cardiac output, they may have decreased cardiac output, they may have diastolic dysfunction, they may have systolic dysfunction. So they may have multiple ways, they may present or they may have a problem with their vascular endothelial permeability, because in preeclampsia you have endothelial dysfunction, endothelial injury, and so it's a complex disease which you have to understand. So what is once the patient comes to you with this kind of background in your mind, the differential diagnosis, the type of conditions, and this thing, and the time of acute respiratory failure. The first thing is to stabilize the patient, because this patient may be in acute respiratory failure, they may be hypoxic, the fetus life may be at risk. So at that point, irrespective of knowing what is the underlying cause or the etiology, I think this patient needs to be managed. They need to be stabilized, and they need to be given fluid, though in a restricted way. And then once they are stabilized, then you undertake a brief history, physical examination to determine the underlying etiology for this thing. So I think the oxygenation is the most important. The diagnosis, as I mentioned to you, in acute respiratory failures, when their saturation falls below 95% or their PO2 is below 70 rather than 90 or 60 respectively, what we use for non-pregnant people. And the moment you feel that the patient is hypoxic, and you should start oxygen to them. And the preferred method of administration of oxygen depends on the severity of hypoxemia. And the severity of hypoxia would depend upon the severity of pulmonary edema underlying, or ARDS patient has got underlying. So it is depending on the amount of lung involvement or the degree of severity of hypoxia, you will decide that which device, whether you want to use nasal cannula or you want to use mask, face mask, or mask with the non-rebreathing mask, high flow nasal cannula. This is a new thing which has come. I think you should have in your ICUs, and of course non-invasive ventilation and mechanical ventilation. So as I mentioned to you, the oxygenation should be monitored continuously by pulse oximeter. The reasonable goal for pregnant patient is to maintain oxygen saturation at more than or equal to 95% to optimize fetal oxygen content. And adequate fetal oxygen requires a maternal arterial oxygen of more than 70 millimeters. So that's because of the physiological changes which we have. And I think this has been very nicely covered by Dr. Archana Mishra. We have these three devices: nasal prongs, oxygen mask, and oxygen mask with reservoir bags. It's basically, these are three devices to give increasing amount of FiO2. So you can maximum with nasal prongs, you can go up to 0.44, the 40% oxygen, what you want to say, and by increasing their level. So beyond 6 liters, there is no point, continuing with nasal cannula. You go into oxygen mask, and then you can go up to 8 liters. And with that, you can go from 40 to 60%. And then still with 60%, suppose you are not able to achieve 95% saturation, that means the patient's condition is bad and patient is grossly edematous. There is a high level of pulmonary edema. Then you can go to mask, reservoir bag, and increase the liters to this thing. This is with rebreathing 10, and with non-rebreathing, you can go up to 15 liters, and you can achieve 0.8. So what I mean to say is that not that this is immediate achievement of saturation. So once you achieve a saturation, you know that all your patients who require mask with reservoir bag, means their FiO2 requirement is 0.6 and above, should need additional method of oxygenation. That means these people have a lot of shunt. What I mean by shunt is that their alveoli are filled with fluid or with cells. So these patients would require some kind of peak or positive pressure to open up these alveoli which are collapsed, or to push the fluid which is there in the alveoli into the interstitial space of this thing. So that's what it means. So once you put reservoir bag, you just achieve the saturation, and then call for high flow nasal cannula or a CPAP or a non-invasive ventilation. So that's where you have to shift to next, because you can't continue to keep your patient at 0.7, 0.8 FiO2. So that's a very, very important this thing. So when you will use high flow nasal cannula or non-invasive ventilation is that when the increase in inspired oxygen concentration beyond 0.6 is required. So you need to displace this fluid from alveoli into the interstitium, and then you also, once you open up these alveoli, their compliance improves. The lungs become more elastic, so the work of breathing falls. And also when the lung becomes bigger, the airways become bigger, the trachea becomes wider, and this thing, in case you need to intubate this patient. And also by achieving this goal through non-invasive ventilation, you will be able to decrease the need for tracheal intubation and also the complication related to endotracheal tube. But previously, if you ask me, the non-invasive ventilation was not considered to be a good modality for pregnant women, because there were a number of reasons for this. One, because when you give pressure through mask, normally when you put this patient on or you ventilate this patient through invasive mechanical ventilation, you put an endotracheal tube and then you give that pressure to the lung. But once you are using this mask, this oronasal mask, then the pressure goes to both trachea as well as esophagus. So both the passages are open to this kind of pressure. And if due to pregnancy, the lower esophageal the muscle tone is low, then there is a very high chance when you give little higher pressure, this air will enter through the esophagus into the stomach, and it can cause an acute gastric distension and cause aspiration. So that is a very, very important risk is there. But now we have seen from the recent reports that you can apply this modality very successfully, provided your patient, you have rightly selected your patient. Patient should be fully alert, patient should be cooperative, patient should be able to sit up, because that way the aspiration risk is, and even if the patient aspirates, patient's vomits, suppose, the patient should not be able to aspirate because patient is conscious and he will not be able to, it will not. So drowsy patients, unconscious patient, you are not going to do this kind of modality for this thing. The next is, suppose your patient is actually in gross pulmonary edema, or there is a severe ARDS, and your patient, you are not able to achieve that degree of oxygenation. So you have even used your positive pressure, you have used non-invasive ventilation, you have used very high FiO2, and your patient, the saturation is not going to 95%, or you are requiring very high FiO2, which is going to be harmful to the patient. Then you have no choice but to intubate this patient. And we know again, intubation failure is 8 times more common in in pregnant than in non-pregnant. So that's why I would say you should have a kind of some kind of help. Either you should have a very experienced anesthesiologist, a person who can intubate, someone who does this every day in the OT, or you can have a bronchoscope, a flexible laryngoscope or a bronchoscope, which are there. With the help of that, I think you should be able to intubate these patients, because these patients have airways are edematous, hyperemic, and they also have a issue, that during pregnancy, their stomach is full, their gastric emptying is delayed, the abdominal pressure is high. So during intubation, they can actually have a very high risk of aspiration for this thing. So that's why, you have to empty, you can put in a Ryle's tube, you should empty the stomach before you try. And second thing is that because of pregnancy, because of the increased position of the higher position of the diaphragm, their lungs are small, so their oxygen reserve is very low. So what I mean to say is that when you are intubating your patient, you actually at that time sedate and paralyze. You give maybe a scoline or maybe other muscle relaxant. So during that time, patient become apneic. So patient's oxygenation relies on whatever air is there in the lung. So their lungs are small with this thing. So their reserve is very poor. So you need to intubate these patients very quickly, so that that problem may not be there. So invasive ventilation, when you do, it's only when the patient fails on NIV. So you should use lung protective strategy. That means always use small tidal volume, never allow plateau pressure to go beyond 30 centimeters. You should use high PEEP, and sometimes you may have to use you have to use recruitment maneuvers. A patient should be nursed in the left lateral position so that there is no aortocaval compression. The goal is to achieve PO2 of more than 70 millimeter, and you should avoid both hypocapnia as well as hypercapnia. So if you have if you ventilate too much, if they have hypocapnia, then this can cause decrease in the uterine blood flow. And if you have hypercapnia, this can actually cause fetal respiratory acidosis. So both things should be avoided. And then I think you need to, once you have stabilized your patient, then you should evaluate your patient, look into their symptoms, about whether they are typically dyspneic, whether able to speak, they are confused, they are drowsy, agitation, diaphoresis, and the other measures, you have to examine and see what are the clinical features these patients have to see the underlying cause for this thing. So pulse rate, respiratory rate, blood pressure, these are all very important things, for knowing the hemodynamic status of the patient, and as well as, the fluid status of the patient. And I would, these have already been mentioned, but I would like to mention about two things. One, ABG is the most important investigation, because it not only identifies, but also quantitates the severity of any ventilatory abnormalities. It also guides the ventilator management, and the goals, as you know, are different, because the normal PCO2 is 30 to 32. So for any degree of severity of acute respiratory failure, the PCO2 in pregnant patients will always be low. And these are the goals which I have already told you have to achieve. These are certain investigations like complete blood count, LFT, renal functions, respiratory viral tunnel. These are all the important investigation one has to do to find out the etiology. And I think what is important, most important thing is the point of care ultrasound. That means bedside echo and ultrasound. These are the two very important investigations, which I think all obstetricians should learn, and they should extend their skills of ultrasound, bedside ultrasound, from extend from evaluation of, I mean the obstetric evaluation of your patient, to actually evaluation of critically ill patient. With this, you can actually know the exact cause of, or the etiology of underlying respiratory failure. You can also know about the fluid assessment of this patient. And I think these three things, if you can do quickly, and which is very easy to learn, I would say, then I think you should be able to manage your patient very well. Just quickly in 2 minutes, I will like to cover these two cases so that you know. So this is a 30-year-old multigravida G2, P2, L2. she's a known case of preeclampsia, and she presented with acute breathlessness. And you can see that she was a known case of preeclampsia. She has tachypnea, tachycardia, hypertension, saturation is only 82%, and she has all other features for this thing. And you can see in the ABG, she is hypoxic, hypocapnic, and she is alkalemic, and she has lactate of 4, indicating tissue perfusion is poor, and the serum creatinine is also, the urea is high, so this thing, so the ECG shows tachycardia. So you can see here, when you say the X-ray, typically there is a cardiomegaly, and bilateral, you can see the lungs are showing increased markings, and also there is a ground glass opacity indicating probably the pulmonary edema. And you can see here, very clearly, this patient has his left ventricle is enlarged, LS also enlarged. So there is a decreased contractility, and the patient has an ejection fraction of only 40%. And if you look into its IVC, the IVC is full and less than 20% variation. And if you look into the lung, and then you can see that lung shows these B lines. Can you see these B lines, which are multiple, radiant lines, which you can see, which indicates pulmonary edema. This is the fluid in the interstitium, and this is something, which we can see. So you can very easily diagnose that this is a case of preeclampsia with the peripartum cardiomyopathy. Second case, here, another 22 years old primary with no prior comorbidities, with 30 weeks of amenorrhea, again exertional dyspnea, cough, swelling feet, flu-like symptoms as she comes here. His pulse rate was 160. So it's more than what you normally see in a patient with shock. So definitely this patient must be having some rhythm disorder, because the pulse is little out of proportion high, respiratory rate is high, blood pressure is low here instead of this thing. Usually a hypoxic patient, the blood pressure is high. This indicates that probably there may be some obstructing lesion in this patient's heart, which is not allowing for increase in the cardiac output. SpO2 is low here. And again, ABG shows alkalemia, hypoxemia, and hypocapnia. The typical features which we see here again. And you can clearly see in the ECG, this patient has got atrial fibrillation. So if you have a young patient having atrial fibrillation, you know that this probably most likely the patient's left atrium is enlarged, and most likely this patient may have what you call mitral stenosis or mitral regurgitation, that kind of a thing. And if you do their bedside echo again, and you can see there is a gross enlargement of the left atrium, and you can see the valves very clearly. The valves are very narrowed, and the LV size is normal, the LA is dilated, and this is, so there is a case of severe mitral stenosis with moderate mitral regurgitation, the dilated LA and LV. So this clearly, the first time, this patient of mitral stenosis will be picked up in the labor room, when the patient is coming with acute pulmonary edema, and you can see, the lung ultrasound indicating B lines and the pulmonary edema. So this is clearly a case of hypoxemic respiratory failure, rheumatic mitral stenosis with atrial fibrillation. So just then you have to do the follow-up management. So let me conclude my talk to say that acute respiratory failure in pregnancy is an uncommon but a life-threatening condition. Early detection and treatment of high-risk pregnant women with the multidisciplinary team is essential. But I think if you have all the facilities in your HDU, most of these patients can be picked up, because you are very good ultrasonologist. You have your own ultrasound and do your patient's evaluation. So this just extension of that skill probably would add a lot to the management of this critically ill patient. And the focus should be on adequate oxygenation, non-invasive, invasive ventilation, and control of blood pressure. Special attention needs to be given to altered pregnancy-related physiology, early stabilization of mother, and safe delivery of the fetus. Preeclampsia remains an important cause of acute pulmonary edema, and preventive measures such as close monitoring and fluid restriction should be observed in this thing. And then appropriate long-term follow-up is necessary to reduce the chance of further complication in late life. Thank you. Thank you very much for your kind attention. And I'll be happy to answer any question, if you have. Thank you for the opportunity.
As usual, mesmerizing talk. And when we listen to your talk, we feel we can manage everything in the HDU. But that's not true. You have been very modest in telling us we don't need you, but we need you all the time. So that goes without saying. And I was told to comment, although it is, I feel little in front of you to comment on your lecture, but just few queries which came to my mind while I was listening to your lecture. As you said that it's not very commonly seen condition. Well, I was going through this when Jyotsna told me to be in this session, so I also did a little bit of reading. So as I read, that most of these trials have kept ARDS in pregnancy out of their trials as an exclusion criteria. So as you rightly put in your beginning of your lecture, that it is only by your clinical experience that you will be able to manage these cases meticulously. So one point in your slide, you said the preterm labor is an high risk for ARDS. Did I correctly read it, or it was because of the tocolysis, the acute respiratory? One of the slides showed that. I just noted down that. So can you just clarify on that?
Okay, it's actually it was not the preterm.
Probably.
Yeah, it could be that what you are saying this thing, but not. I think it was not with reference to preterm labor.
Okay, so because I read that, I thought I don't know this, so I must ask you. And another thing, what I want to tell our residents, that we are the department is like a Dracula. We are using blood left and right and massive transfusions. And a word about this transfusion-induced lung injury, because they are not using it when it is to be used. That time they are little lazy, and sometimes they just go overboard and use it, and that can also give rise to the lung injuries. Just a word about that to our residents who are listening to this lecture.
Yeah, definitely. I think it's a very, very important point which you have raised. I think obstetrics is one area where a large amount of blood has to be transfused, particularly when you have patients with placenta accreta or a patient with massive postpartum bleeding. The only, I think, other situation where you may have to transfuse such huge blood may be trauma. But most of the other situation, you don't have to actually transfuse such a huge volume of blood. And once you have to give this kind of thing, you need to monitor your patient very closely, not only for not giving in excess, you have to monitor. As I said, now you can use your bedside ultrasound echo. You can look into the IVC size. You can look into the pulse pressure variations, to see the adequacy of that. But also you should look into the transfusion related lung injury, and if you see that your patient has started actually worsening, so there are the situation actually becomes very complex. What I have seen myself in the ICU, a patient who is worsening, it could be due to fluid overload, it could be worsening ARDS, it could be actually the lung injury caused by blood. So you actually need to be very vigilant, and you have to see from all angles, that what is probably responsible for the worsening condition of the patient. So all things, you have to see, and that is why you can't actually depend on anybody else. You have to be on your own, and you have to learn all the skills. You should be able to use your ultrasound, your echo, because you don't need to be cardiologist to do. You are not going to do the kind of echo which cardiologists do. You only have to assess the LV size, LV motility, RV size and RA size. So those things, you need, which I think can be learned very fast. Within a week's time, I think you can learn this bedside skill. And once you know, you will feel so confident, that that you are in the driving seat, you are in total control. How much fluid needs to be given, you can do that. But things need to be monitored. You have to be at bedside, and there should be hourly monitoring of all these parameters. And once you see them, everything is transparent, and I think you can definitely reduce the complication. You can definitely reduce the iatrogenic issues, as you have mentioned, of fluid overload as well as transfusion related injuries. These things are very important things. All residents should be made, or they should be sensitized about it. I think it was a very, very important point which you raised.
Dr. Anjali?
Yes, ma'am. And thank you very much, Dr. Suri. Ma'am said it all. We actually, your contribution was big, not small, in setting up our HTU, and your guidance was very invaluable to us. Thank you, sir.
So now I thank all the chairperson and our speaker for this wonderful session, the keynote address. And our sponsors, you know, they had been very smart to choose the best of our sessions for sponsoring. So now these Plus Plus Life Sciences people, they have introduced this Trimacare, which they claim to be approved by WHO, and it is something, you know, which they want to tell us about, like what are the benefits and all. So we have a small video section from them. It's a 2-minute video, and they will be highlighting the main, basically the advantages of their product. And for this, I have Ashmeet Kaur. She's a senior product manager from Plus Plus Life Sciences. Ashmeet, please.
Good morning to all of you. This is Ishmi, Senior Product Manager from Plus Plus Life Sciences. It's a moment of great honor and a pride for me and Plus Plus Life Sciences to share the same space with the thoughtful and the eminent leaders like you. So briefly taking you through Plus Plus Life Sciences. Plus Plus is a healthcare firm which is backed by science and innovation. We are coming up with the first ever brand, which is the first prenatal brand of India, that is Trimacare. As the name suggests, Trimacare, this is advanced nutrition for each trimester of the pregnancy. It's having the advantage of iron, folate, calcium, vitamin D, iodine, magnesium, and 20 other nutrients, which is formulated in accordance to the ICMR and the WHO guidelines. And it reduces the symptoms such as morning sickness, UTI, constipation, and cramps. So it's good for baby and good for mother. So the Trimacare, as the pregnancy is of 3 trimesters, divided into 3 trimesters. So similarly, we are having the 3 packs. First is Trimacare 1. So Trimacare 1 has the essential ingredient L-methylfolate, which is the active form of folic acid, is 7 times more bioavailable than the folic acid and causes 3 times reduction in the homocysteine level. Along with that, we are having the advantage of pyridoxine and anti-emetic, anti-nauseatic blend, which treats the morning sickness. Since 70 to 80% of the pregnant female encounter the problem of morning sickness during the first trimester. And in that, we are also having omega-3 fatty acids, vitamin D, iodine, and other nutrients as per the RDA for pregnancy. For Trimacare 2, that is the trimester 2, we are having 2 packs, morning pill and evening pill. In the morning pill, we are having the iron component and the other nutrients. Iron we are giving in slow release form, and it is ferrous ascorbate, which leads to less GI side effects and maximum absorption. And plus, we are having the omega-3 fatty acids, iodine, and zinc. In the evening pill, we are also having calcium component and the other nutrients like cranberry extract, which prevents the urinary tract infections, along with iodine, zinc, vitamin D, and other nutrients as per the RDA. For trimester 3, we are having 2 packs, morning pill and the evening pill. In the morning pill, we are having the iron component in the slow release form, ferrous ascorbate, same as that of Trimacare 2. And the evening pill, we are having the calcium component and the other nutrients like iodine, magnesium, zinc. Here we are having magnesium as extra, since during the 3rd trimester, the cramps and the hypertension is a common problem encountered during the 3rd trimester of the pregnancy. So we are giving here magnesium as extra component. Along with that, we are also having a digestive blend which treats the constipation. Since pregnant females usually have 20 to 25% of the pregnant females have the problem of constipation during the 3rd trimester. So we are giving here digestive blend. Along with that, we are having the cranberry extract, which prevents UTI, vitamin D, and the other nutrients as per the RDA for pregnancy. So WHO has also recommended the MMN model. What is this MMN model? This is a multi-micronutrient nourishment model, which reduces the risk of low birth weight by 14%, preterm birth by 7%, and baby is born small for gestational age by 6%. So now this classical iron, folate, calcium model could be replaced by this MMN model as recommended by the WHO guidelines. Usually 40% of the pregnant patients do not adhere to the therapy. The reason being the multiple pills are being prescribed to the patients. So now there is no need to prescribe folic acid, calcium, iron, vitamin D, pyridoxine, and magnesium separately to your patients, presenting the one-stop solution for the better outcomes and the better compliance, that is the Trimacare. Trimacare, having the advanced ingredients, is gentle on stomach, leads to higher absorption, and is having the wet source. So here's a small video which I'll be playing for my brand.
Not busy, man. Please replay again. It's not visible.
Sumit, the audio is not there, I think.
The message has come, I think. The written message is coming, so we can.
Sumit, you did not put on the audio. We'll play. You want us to play, ma'am?
Yes, yes. Can you play, please?
Yeah.
Yeah.
I think we are running short of time. We can play it in the end then, at the end of the session.
You can just go with the this thing, your slides which you want to show, just important highlights you have already shared. Can we have this later after the sessions?
Okay, ma'am. Sure, ma'am. Thank you so much, ma'am.
Because important information you have already given us. I think it is our product which needs to be given a chance, and so we would really like to see the results with your product. So it is.
Thank you so much, ma'am.
Yeah.
Yeah.
Yeah, with this slide, now we go on to our next session, which is a panel discussion. And for the panel discussion, I would like to invite the moderators, Dr. Jyotsna Suri. And you all know, Madam needs no introduction. Can we have the, yes, please, Siba. So she is a very energetic and extremely passionate clinician who is ready to contribute to the management of critically ill women at any hour of the day. Madam also holds many positions in the state and national societies. It is always a pleasure to attend to her panel discussions, as she has an amazing collection of interesting cases with her. So she is also chairperson of the Safe Motherhood Committee and organizing chairperson of this workshop. And I also invite Dr. Shiva Marwa. She is a young, enthusiastic faculty of Vardhaman Mahavir Medical College and Safdarjung Hospital. And she is also the nodal officer for COVID-19 from Obs and Gynae department, and very actively involved in the management of COVID-19 cases. So I hand over to Dr. Jyotsna and Dr. Shiva for.
Thank you, Rekha. So I'll share my screen. Is it visible?
Yes, ma'am.
Okay. Yeah, so very good afternoon to everyone. So we are going along well. I think all the sessions have been really well taken, but as usual, there is a little bit of paucity of time. So we'll try to focus on the key messages in this panel discussion so that important things are not missed out. So it is my really, I mean, I'm very happy to have such a great panel. All senior people are there. But I want to say about Dr. Shiva, she is a very, very lively person and very, these beautiful slides and her love for cricket. It is all very visible in these slides. So enjoy the slides also besides the panel discussion, all done by Dr. Shiva. Now it's a privilege to invite and introduce Dr. Sunita Malik. She is a unit head consultant and professor at our department of Obs and Gynae. And she is an all-rounder with equal brilliance in teaching, performing surgery, as well as conducting research. So welcome, madam. Then Dr. Manju Puri is a director professor and head at the Department of Obs and Gynae, Lady Hardinge Medical College. I think she needs no introduction. She is a very well-known teacher par excellence and has a huge fan following amongst students. And her vast experience is reflected by the wonderful books which she has written, which are a treat for all her students. So welcome, madam. Dr. Asmita Rathore, again, HOD of Maulana Azad Medical College. She is a brilliant academician. She is also the program coordinator for the high-risk pregnancy. She has lots of publications. And above all, she is a wonderful human being. So welcome, Dr. Asmita. Dr. Kiran Goleria is a professor, director professor at the Department of Obs and Gynae in the UCMS and GTB Hospital. And she has got so many well-deserved accolades and prizes. And she's a wonderful and a clinician, wonderful orator. And also her pleasant personality draws everybody towards her. She's very popular with her students and colleagues. Dr. Upma Saxena, she is a professor at Department of Obs and Gynae. She is also a very devoted, dedicated clinician, excellent surgeon, and also is conducting ICMR project and has a lot of interest in research. So welcome. And last but not the least, it is Dr. Anita Rajoria. She is a very, very popular figure in AOGD circle. I think she is very enthusiastic in participation in all these conferences, events, and she has a lot of passion for social causes. And she is the winner of so many accolades again and prizes and recognitions. She is the head of the Department of Obs and Gynae at Sardar Vallabhbhai Patel, Government of NCT Delhi. So welcome to all my panelists. So this Shiba has made the famous huddle, I think. So we are all there together to solve these questions. So a 34-year-old primary gravida, married for 3 years, came at 32 weeks period of gestation. And she presented with preeclampsia with severe features and history of gestational diabetes. And she is on metformin. So considering that she was having preeclampsia with severe features, induction of labor was planned for her. And she was started on injection dexamethasone for inducing fetal lung maturity. 12 hours after admission, the patient complained of nausea, vomiting, and severe abdominal discomfort. So at that time, when she was examined, she was lethargic and confused. She was afebrile. Her oral mucous membranes were dry. BP was on the lower side, seeing that she was a hypertensive patient, 90/60. Pulse was 120, and the respiratory was high. Rate was high, 28 breaths per minute with Kussmaul's breathing pattern. And the RBS was also very high, 350 milligram. Urine dipstick showed 4+ glucose and 3+ ketones. So ABG was done, which showed metabolic acidemia with a pH of 7.23 and a bicarb of 12. The HbA1c with which she had been admitted had a value of 8.8%. Per abdomen, she was 30 weeks and the FHS was 160 per minute. The uterus was relaxed. So Dr. Manju Puri, madam, what is the diagnosis of the case, and are pregnant women at increased risk of diabetic ketoacidosis, and how do we diagnose this condition?
Thanks, Jyotsna, for the question and lovely slides, Shiva. Great work done. So basically, this is obviously a case of diabetic ketoacidosis. And so if you just go by her symptoms, she could have been severe features coming to preeclampsia, that is nausea and vomiting. But if you go by the investigations and the clinical picture, So that is out and out diabetic ketoacidosis. And if you look at the diagnostic criteria, she fulfills all. She's got a blood sugar, which is more than 200 milligram per deciliter. Then she's got urinary ketones, which are 4+. Actually, anything more than 2+ is okay to be labeled as diabetic ketoacidosis. And she's in obvious acidemia. Her pH is less than 7.3 and a bicarb is less than 15 milliequivalents per liter. So this is what this patient is suffering from. And of course, when we say, whether pregnancy can actually have any influence on diabetic ketoacidosis. So we've already discussed in great detail that pregnancy has got a lot of physiological changes associated with it. And, first and foremost is that it is a state of respiratory alkalosis. And already the patient's ability to buffer, any kind of acidosis happening is less. So that compensatory mechanism, which is present in non-pregnant women, is impaired in these women. So they tend to go into acidosis much faster. At the same time, looking at the relative insulin sensitivity, resistance, they tend to do, have more of lipolysis happening because, the glucose cannot be utilized. So lipolysis happens and they have that ketogenesis happening. So in addition to impaired, buffering ability, the ability, their, tendency to go into ketosis is much higher as compared to non-pregnant women. And to top it all, we know that there is, human placental lactogen, progesterone, and cortisol, which would further impair the insulin sensitivity. So all in all, these patients have a great tendency to go into ketoacidosis.
Yes, ma'am. I think that was very important message that in fact, even with a lower level of sugar, even it has been documented up to 180 mg% that the diabetic women can go into ketoacidosis, and that all three of the components are very important for the diagnosis, not just one of them. So
a little point which I would like to make, Jyotsna, is there would be something like euglycemic diabetic ketoacidosis also, in which sugar levels may not be high, but the patient can be in acidosis. So keep that also in mind.
Yes, ma'am. That's very well taken point. So if the other features are there and sugar is even little bit like maybe 160, 170, and she is a known diabetic, sometimes we may have the euglycemic type of picture. So Dr. Upma, what are the precipitating factors and what are the risk factors for diabetic ketoacidosis? So how about in this case, were there any things we could have done to prevent it?
As we all know, the diabetic ketoacidosis occur more in type 1 diabetes, that is juvenile onset, and it's also more in type 2. And hyperemesis gravidum, we know there is starvation ketosis. And many infections which occur in pregnancy, especially any UTI, pneumonia, COVID-19 can lead to diabetic, patient of diabetes who develops COVID-19 can develop diabetic ketoacidosis. Chorioamnitis are also these infections which can lead to diabetic. Other things which can affect the balance, tilt the balance towards diabetic ketoacidosis is beta sympathomimetic drugs given for tocolysis. In this case, antenatal corticosteroids is being commonly given to all the pregnant patients, especially from 23 to 34 weeks, 33 weeks plus 6 days. And that is also a very common cause, which if not controlled, sugar is not controlled, can lead to ketoacidosis. Then insulin pump failure. Patients nowadays sometimes use pumps which can go wrong and can lead to diabetic ketoacidosis. Other important thing is poor compliance, especially the patients who are on insulin. In India, they are not able to afford and they are not very well trained how to take insulin, leading to poor compliance and hence this problem. Then poor management, that is also a very important component. This patient most likely must be having a pre-existing diabetes, and because her HbA1c is quite high and she was being managed on metformin. So it's very important that we do correct management. I don't know when was the GCT done. If the GCT OGTT values were more than 200 then she should have been started on insulin rather than metformin. Most of the guidelines nowadays, they say insulin as a first line rather than metformin. In this patient, most likely either she had a pre-existing diabetes where the insulin should have been started, or she was not very compliant. Metformin should have been switched to insulin, or insulin should have been added to metformin after the sugars were not controlled after giving it for 2 weeks time. And most important is dexamethasone. Dexamethasone, we all know, we give in the dose of 6 milligram 12 hourly, 4 doses, and it leads to blood sugar derangement. So this derangement starts usually 12 hours after the first dose, and it persists till 24 hours after the last dose. So during this period, the patient should have undergone blood sugar charting 4 hourly, and the insulin should have been given according to the sliding scale to prevent this life-threatening condition.
Yes, thank you, Dr. Upma. I think
I think one more thing. And the moment this condition was diagnosed, both the dexamethasone and metformin should have been stopped, because this is the precipitating cause in this case.
Dr. Jyotsna, another factor is the diabetic gastroparesis also, which we are missing.
Yes.
Diabetic gastroparesis itself can slow down the release of food content. And if the patient has not taken meals properly, then she may land up in diabetic.
Yes, that's true. That's very true. I think, Dr. Upma, the important message which you have given is that insulin should have been given, at least the sugar should have been very strictly monitored, and we should have probably given insulin to this patient so that she would not have landed up in this situation. And normally, even if the patient is on insulin, there is a 30% increase in the requirement when the steroids are being given. So I think this is important to know. Even in well-controlled diabetics, we may end up with this situation if we are not careful while we are giving the steroids. So what are the cornerstones of management of diabetic ketoacidosis in a pregnant woman, and what investigations would we do? Dr. Sunita, are you there, ma'am?
Yeah. What in this case, first thing is we have to initially evaluate her status, her cardiovascular status, ABC, that's what we call it, and then volume status, because these people have dehydration, and their mental status, that's very important, and possible, of course, history of precipitating event and previous history. So then what to do about the management is that we have to start her on fluids. That's the most important thing with resuscitation and with patient in left lateral position. For that, laboratory assessment, which has been done already, that is arterial blood gases, glucose level, ketones in urine and blood, electrolytes at 1 to 2 hours interval, especially potassium, phosphate, and magnesium, which is very important. CBC, urine, routine, and ketone bodies, ECG. These are important lab investigation we need to be done. She needs to be rushed fluid initially, and then, of course, maintenance fluid. She needs to be given insulin IV route, no longer the subcutaneous route. That's what it is. Initially lower, and then we gradually increase. Then she has to be given glucose also along with. When the plasma glucose has reached around 250 milligram, we need to neutralizing drip has to begin. Both insulin and glucose needs to be given in these cases. Potassium, and depending on the potassium level, bicarbonate. Then, of course, look at the precipitating event, which needs to be stopped. And then, of course, last is fetal heart rate. Initially, then the mother is stabilized along with fetal heart rate monitoring, and think of the delivery of the patient depending on the situation. These are the various components under which we manage the diabetic ketoacidosis.
Thank you, ma'am. Very beautifully summarized. So now for the next question, I would like to hand over to Dr. Shiba for continuing the discussion.
Thank you, ma'am. So I would like to ask Dr. Asmita, ma'am, what are the fluids of choice in diabetic ketoacidosis, and how do we start fluid resuscitation, as Malik ma'am has said? And what are the immediate and maintenance doses of insulin? And what are the indications of bicarbonate and potassium replacement in such patients? Dr. Asmita, ma'am.
Ma'am, you have to unmute yourself. Asmita, ma'am.
Ma'am, you have to unmute, ma'am.
Yeah, Dr. Asmita, please unmute yourself. Yeah.
Okay, am I audible now?
Yes.
Yeah. At the outset, thank you, Dr. Jyotsna, Dr. Shiva, team Sabdajang, and team AOGD for inviting me. Coming to the case, the fluid replacement is the cornerstone because these patients are volume depleted. And the fluid of choice is a isotonic normal saline, and which is to be rushed in a resuscitation. That is, we start with a dose of 10 to 15 ml per kg per hour. So for around 50 to 60 kg woman, which is an average weight in our woman, it would come to 1 liter in an hour. After 1 hour, we can again monitor her hemodynamic status, and accordingly fluid replacement can be monitored. But usually in second 2-3 hours, it should be around 500 ml per hour, and after 4 hours, we can taper it down to around 250 ml. But throughout this, the patient needs to be monitored for her pulse, BP, and most importantly, her urine output, which should be maintained for around 0.5 ml per kg per hour. Then next is the coming to the insulin therapy. I think Dr. Sunita has already covered. We start with a 0.1 unit per kg per hour. Whether we should give a bolus dose of insulin or not is a controversial issue. It may not be given in all the cases. Some cases it can be considered. Insulin therapy also needs to be monitored and titrated with her blood sugar monitoring, which is done at every 1 hourly. And our target sugars are around 150 to 250. Once sugars come down to 250 milligram per deciliter, we need to add dextrose also to these fluids. The third important component of management of diabetic ketoacidosis is management of her sodium levels and the potassium levels, and the potassium therapy is monitored mainly by the serum potassium levels. If the potassium levels are more than 5.5, usually we do not give any potassium and start straightway with an insulin therapy. But if they are less than 3.3, then we first correct the hypokalemia and then start her insulin therapy, because insulin therapy usually pushes the potassium from extravascular compartment to the intracellular compartment, and which can cause the fatal hypokalemia and cardiac arrhythmias. So we need to correct that hypokalemia before we start the infusion. If her potassium levels are in a normal range of 3.5 to say 5.5, then we start the potassium replacement along with an IV infusion, and the potassium is given in a dose of 40 millimole per liter, and it is to be given initially over 2 to 3 hours. The 1 hour dose should not exceed 20 millimole, and again we need to monitor with her serum potassium levels and accordingly to be replacement titrated. The fourth component was an bicarb replacement. Usually we do not recommend bicarbonate replacement because it is not very safe for the mother and baby both. It should be avoided as far as possible. It causes the compensatory hyperventilation in a pregnant woman. It also has a cardiac depressing effect. But if there is a severe acidosis, which is pH less than 7.1, then maybe we can give bicarbonate replacement to bring it to the level of 1.5 to 7.2, but we don't intend to bring it to 7.3 with bicarb. Your fluid replacement, potassium, insulin replacement should correct these abnormalities, and bicarbonate should be the last choice.
Thank you, ma'am, for very beautifully highlighting the things. So coming to the next question for Dr. Anita Rajoria, ma'am, can you enlist the plausible maternal and fetal risks which are associated with a patient of diabetic ketoacidosis?
First of all, thank you, Dr. Jyotsna and Shiba, for giving me opportunity to share panel with people who I hold in very high esteem, and I really admire all of my co-panelists. We all know that DKA is a medical emergency and it needs management at level 2 or 3 critical care units, maybe at HDU or maybe at ICU. And we understand very well that both mother and fetus are at the risk of significant morbidity and mortality in this. There may be severe maternal complications, which may be due to dehydration leading to acute renal failure, ARDS, cerebral edema may be there, coma, and even death may be there. So various studies have reported that maternal mortality may be around 4 to 15%. Fetus also holds a very high risk of neonatal problems. There has been 9% to 36% morbidity, which has been related in various studies. The morbidity, as has been shown by Shiva, is due to hypoxia-related complications, which mostly are attributable to the increased rate of preterm deliveries we are having in these. There is a fetal brain injury, And during the diabetic ketoacidosis, the fetal brain is very, very susceptible to maternal 3-beta hydroxybutyric acid and lactate concentrations, which lead to decreased glucose uptake and fetal brain damage, which can have long-term effects also. And we understand that reduced neuroplacental perfusion due to severe maternal dehydration and acidosis may cause these problems, and electrolyte imbalance in mothers, especially potassium imbalance, may cause cardiac arrhythmias in mothers and in baby also. And sometimes fetal death ensues.
Thank you, ma'am, for explaining the maternal and fetal effects very well. Now, the next question for Dr. Kiran Guleria, ma'am. What are the features of resolution of diabetic ketoacidosis? When would we say that the patient has come out of this condition? And should pregnancy be an indication for termination in such patients? And if yes, then what would be the timing of termination and what would be the optimal mode of delivery? Dr. Kiran, ma'am.
Sorry, I was trying to unmute myself. Yeah, thank you again, Dr. Jyotsna and the team of Sabdajang, for inviting me. It's always a pleasure to interact with you people. Now, the features of resolution of diabetic ketoacidosis are quite well laid out. And we can know that if the blood sugars are persistently below 200 milligram per cent, and preferably around 150 milligram per deciliter, and on ABG, if we see that her pH has been restored more than 7.3. But most importantly, two things. One is the bicarbonate. If it is showing it's rising and it's more than 15 to 18 milliequivalent per liter, especially in the first 6 hours, which is the time when they give you the maximum information. And closing of the anion gap, that is less than 10 to 12 milliequivalent per liter. And if you have facilities for blood ketones, then also the levels of blood ketones can tell you if they're less than 0.6 millimole per liter, they can tell you that probably the this diabetic ketoacidosis has resolved. But along with this, you have to look at the clinical outcome also of the patient. And if you think that now patient is not having any of the symptoms, she's able to orally take without having any vomiting and emesis. So two important points here are the two important things here are that the closure of an ion gap and rising bicarbonate levels in the first 6 hours are the most reliable indicators of telling you the response to the treatment. And another thing, that urinary ketones may take long to clear, so should not be considered as a feature of resolution. More than that, I think it's the other features which are important to say that that diabetic ketoacidosis has resolved. So now the second thing was that is diabetic ketoacidosis per se an indication for termination of pregnancy? So the answer is actually no. It's per se it is not an indication for termination of pregnancy, because in fact, even if there is another indication for termination of pregnancy, for example, in this case, where you've already planned induction of labor, even then in those cases also it is always better to stabilize the mother metabolically, and then depending upon the situation you can individualize the patient whether she needs termination of pregnancy or not. And that would probably depend on what is the gestational age. If it's a preterm and she has resolved, and then she can continue with pregnancy with the close maternal and fetal monitoring also. But then depending upon if one point which I would like to tell you here is that during this process of diabetic ketoacidosis, you may see some changes in the fetal heart rate, tracings on the CTG. There may be some arrhythmias or bradycardias, or also sometimes there is some kind of, if it is not properly controlled, there is also a risk of intrauterine fetal death, which has to be explained. But if she resolves, that these findings also resolve within a period of say within the next 4 to 6 hours. So then the pregnancy can continue if she was a preterm pregnancy. But otherwise, it will also depend on what is the maternal condition. Has she stabilized, or is there any indication from maternal side for the termination of pregnancy, or any fetal indication? If there is persistent, fetal surveillance tests are showing non-reassuring status, then in that case, we may need to terminate pregnancy also after we have stabilized the maternal condition metabolically. Now, in this particular patient, since she was already planned for, termination of pregnancy, now after her condition has stabilized, I think I would like to reassess this patient again, see what is her blood pressure status. Now, does she have any other complications like HELP syndrome or which needs immediate termination? Or her fetal heart tracing, are they showing any non-reassuring status? Then two things I think which I would like to discuss here are, once the patient has stabilized, I do not know what is the status of her dexamethasone course, whether it has been completed or not. That is one, and whether she was started on magnesium sulfate or not. So I just wanted to know, I think these are the two things which I would like to know about the case.
Ma'am, she was given dexamethasone and she was also started on Maxell therapy.
So what happened during the period of, when her diabetic ketoacidosis was being treated? So what happened that during that time the dexamethasone must have been stopped?
Ma'am, the DEXA was stopped because she went into diabetic ketoacidosis and the management entailed. Yes,
so again, now to restart to complete the course. So then I think we need to really involve our endocrinologist. But since she is under our care and we've already giving her insulin, we can increase her dose of insulin. Maybe we can complete the course. And if there is no other pressing, indication like HELP or some fetal distress. And second thing is, now then, based on these conditions, I would like to do a pelvic cervical assessment and see what is the condition and whether I need to induce her or maybe I can go straight away for cesarean section, because at this gestation, she being primary, I don't think so that she will have a very favorable cervix, and I really want to give her not a very prolonged labor, short labor, where she can be controlled, like both her blood pressure and sugars can be controlled, and I don't want to give her unnecessary long stress of labor. So maybe a cesarean section for her. That is what I think.
Thank you, ma'am. And during the pandemic, no management is complete without discussing about the issues because of COVID-19. So for all the panelists, I would like to ask, what are the changes in management of diabetic ketoacidosis in pregnancy during the pandemic, if any? Dr. Manju ma'am or Dr. Ma'am?
If you ask me, I think one has to keep in mind there could be that patients are more likely to come in diabetic ketoacidosis during COVID pandemic because of their non-compliance to therapy. That is one. And second is, any patient who comes with diabetic ketoacidosis, we really need to rule out COVID because it could be asymptomatic and that could be contributing to diabetic ketoacidosis. And rest all management should be the same. That is what I think.
I just want to add, we can switch to subcute regime. Subcute regime has been found to be quite good during COVID times because you can do blood sugar monitoring 2 hourly. And rapid insulin can be used for giving subcute regime, and that will prevent contact between the healthcare workers and the patient.
But I need to a little bit differ over here. Though subcutaneous insulin has been propagated as a replacement for IV insulin infusion for mild to moderate ketoacidosis. But if you look carefully, for pregnant women, probably it's not a very good idea. So pregnant women should be excluded out of it. And
many
only for
papers
very
have
mild
come.
cases, maybe she can try this giving subcutaneous 1 to 2 hourly. But I think still for a pregnant woman, she needs to be admitted and treated like with IV infusion.
Yes, I think.
Yeah, Manju ma'am, will you like to?
But many papers have come regarding this subcute regime during COVID times, and it has found to be helpful because sugar monitoring can be done 2 hourly. I know it's not a good regime.
Actually, in pregnancy, we don't have much experience. I think it is a very open, debatable topic whether we should or not. I think for mild patients we could try it, but for the more severe ones, we should follow the protocol. But definitely, Dr. Manju said that if someone comes in with ketoacidosis, we should rule out COVID in them, because very often nowadays we are getting diabetic patients and in whom we test and their COVID is positive. So, Shiva, you could summarize this case then.
Will you like to add anticoagulant?
So another key thing is, I just want to add something.
And
Yeah.
Manju, will you like to
Just
add
want to add
anything?
is that in moderate to severe, we start with methylprednisolone. We are giving them steroid further. So again, we have to be careful. Then subcutaneous, I don't think will help the insulin.
Yes,
That time we need regular. Yes, ma'am.
Quite true.
Ma'am, anticoagulant therapy, will somebody like to add if she's especially COVID positive? Yes.
Anticoagulant will be according to the protocols of the COVID-19. I think what are established already, and depending on the D-dimer levels, whether we give the prophylactic or the therapeutic doses. So that is according to that and according to the severity of the condition. So, and of course, in the postpartum patients, it is recommended as of now that we should give till they are in the hospital, at least, and post cesarean also. So, Shiva, you can
Summarize, diabetic ketoacidosis has a very low incidence of around up to 10% in cases with low mortality, 2% mortality rate. Significant error rate in management of diabetic ketoacidosis in pregnancy has been seen. Early specialist involvement with multidisciplinary approach is required along with strict monitoring, and treatment of the underlying cause is the cornerstone of management besides this BSc, which has already been highlighted. And common risk factors have already been discussed in detail, which include new onset diabetes, infections, influenza, and UTI. And treatment regimes are based on aggressive hydration and IV insulin, no advantage of any one insulin over the other. And there is no requirement of immediate delivery just because a patient is in diabetic ketoacidosis, and it has to be individualized as per the patient. So now,
just steady consultation will help a lot in preventing this drastic life-threatening because in COVID times. Steady consultation because they are high-risk pregnancy and it will help.
Yes, ma'am. So now we proceed to the second case. This patient was a 35-year-old Gravida 3 Para 2 Live 1 who was referred to us in the emergency at 35 weeks period of gestation with severe anemia and complaints of shortness of breath, fatigue and swelling in her feet and legs for the last 2 days. She gave history of breathlessness on exertion for the last 10 days, but now at rest also. She had no history of any cough, asthma, chest pain, hypertension, fever, or even contact with any COVID-19 patient. She had history of breathlessness 3 days after the last delivery 2 years ago, for which she was admitted in a local government hospital for 2 weeks, and she did not follow up with any cardiologist after that. On examination on admission, her blood pressure was 130/86, pulse was 120 beats per minute, respiratory rate was 40 breaths per minute, and it was a labored breathing. Her saturation was 89% on room air. Her JVP was raised. She was anemic. A grade 3 pitting edema was seen on bilateral lower limbs up to the knees. Chest bilateral air entry was normal, but fine crepitations were there in basal creps were there. And on CVS examination, the apex beat was heard normally, but S1, S2 were heard. There were no added sounds or murmurs. On per abdominal examination, 34 weeks, uterus was corresponding to 34 weeks with fetal heart 160 per minute in cephalic presentation, and uterus was relaxed. Her investigations, CBC was HB was 7.2, TLC was 6700, platelet was 1.4 lakh. KFT was, blood urea was 34, serum creatinine was 0.8, LFTs, total bill was 0.9, 46, 45 were OTPTs, and alkaline phosphatase were 137. On chest X-ray, cardiomegaly was observed with bilateral pulmonary infiltrates, and an immediate ultrasound was done in emergency after admission, where a single live fetus of 32 weeks period of gestation was seen, and her Leica was AFI was 6. So my first question for Dr. Sunita Malik, what should be the next investigation for this patient, ma'am, and what is the differential diagnosis?
Looking at this patient's history and examination, she has breathlessness, she has edema. It could be physiological, but that much is not there in physiological pregnancy changes. Anemia, that can also cause, but then her HbA 7.2, again, I don't think that has gone, maybe it has contributed further. Or she may have some respiratory problem, but then chest findings are normal and there's no pneumonic patches in the chest. Now coming to the heart problem, the heart problem could be secondary to some disease like in pre-existing congenital heart disease or acquired heart disease like rheumatic heart disease, or secondary to hypertension. but then there is no signs of any added sound in the heart. That's there. No sign of hypertension. That is there. So we now come down to cardiomyopathy, which is by definition is the peripartum cardiomyopathy, which occurs generally in late third trimester or postpartum period, and which doesn't have any identifiable cause. This could also be, we have to find out whether it is peripartum cardiomyopathy, or it is genetic, or idiopathic, or familial, or secondary to HIV, AIDS, and CMP. So we have to investigate on that line also. And the cornerstone of the diagnosis is echocardiography. Echocardiography is required in this case, definitely, which will show you this is a dilated cardiomyopathy. PPCM is a dilated cardiomyopathy. It will show you left ventricular dysfunction with dilatation, with left ventricle ejection fraction of less than 45%. And it may also show right ventricular dilatation with dysfunction, pulmonary hypertension, left atrial or bilateral enlargement of that also. So overall dilatation of the heart can also be there. There may be some functional mitral or tricuspid regurgitation also. And there may be some thrombus also, which is there in PPCM. That's very important to see. So along with echocardiography, we have to do the cardiac biomarkers like BNP, proBNP, ultrasound test to confirm our pulmonary edema findings. These are the main things which we need to do before proceeding further. Thank you.
Yes, ma'am. So we did this echocardiography for this patient and showed that left ventricular ejection fraction was 38% and dilated left atrium, right atrium with global hypokinesia. And there was thin rim of pericardial effusion was also seen, and moderate MR and mild TR were present. And her biomarkers, the NT-proBNP was 5,747 and ECG showed sinus tachycardia. So as coming to the next question to Dr. Anita ma'am, what are the risk factors and diagnostic criteria of peripartum cardiomyopathy?
As already told by Sunita ma'am, a diagnosis of PPCM requires echocardiographic evidence of left ventricular dysfunction with left ventricular ejection fraction, which has to be less than 45%. And often, but not always, left ventricular dilatation is found. And there is a presentation is the hallmark. It is peripartum or in early postpartum period. And there is absence of any other associated alternate explanation for same. The echocardiography, as already highlighted by ma'am, shows right ventricular dilatation and dysfunction may be there. There may be associated pulmonary hypertension, left atrial or bilateral enlargement may be there. Then there may be functional mitral and tricuspid regurgitation. And sometimes you may find intracardiac thrombus also. As far as risk factors are concerned, there is a genetic predisposition. African ancestry is usually found in these patients. Usually they have PPCM. Family history is very, very significant in them. Then the basic problem is underlying sarcomere gene mutations, which are associated with this. Titin gene pathogenic variants, they make patients prone to peripartum cardiomyopathy. And then there may be beta myosin heavy chain variations, myosin binding protein C variations, and other genetic mutant variations may be there. It has been associated with low selenium and zinc levels, and preeclampsia and hypertension are a very important predisposing factor. Multiple pregnancies, which may have been caused by assisted reproductive techniques, is another responsible feature. Then advanced maternal age, obesity, twin pregnancy, anemia, all these predispose the patient to develop PPCM. It is a two-hit hypothesis to be sure. Besides, inheriting gene variations, the peripartum hormonal changes, especially associated with prolactin breakdown products that are 16 kDa prolactin end products, they are formed, which are said to be vasculotoxic, and they cause PPCM. Then besides that, some associated risk factors may be prolonged tocolysis, maybe viral illnesses, stress-activated cytokines, inflammation, or maybe some autoimmune reaction. and hemodynamic stress or oxidative stress is associated with it. So these are the major risk factors which make a woman prone to develop PPCM.
Thank you, ma'am. So the main criteria for diagnosis is absence of any heart disease, as you have already said, till the last month of pregnancy, and her echo findings, which were very characteristic, and absence of any identifiable cause for the symptoms as well. And all the risk factors have already been detailed. So we go to the next question to Dr. Kiran, ma'am. What will be the antepartum management of peripartum cardiomyopathy, and what drugs are recommended in the antenatal period?
So for me,
It was also for somebody else. May have prepared that question.
this is my question actually.
I know, but if you want, okay. Who's
So
question?
I'll answer.
Yes, ma'am. Dr. Upma, ma'am.
But if you want,
Okay,
I can.
so I just want to tell you this peripartum cardiomyopathy, basically it is a systolic failure, and the heart failure in this, the ejection fraction is reduced. So heart failure reduced ejection fraction is defined as the ejection fraction less than 40%. So majority of times the ejection fraction is less. And in this patient, she's decompensated. She has pulmonary edema. She has leg edema, and JVP is raised. So first line of management in this case will be loop diuretics. So I'll give her furosemide, 20 to 40 milligram IV, and if she will not respond, I can double the dose after 1 hour. And till the time she's stabilized, I will keep her on IV furosemide, and then I'll switch to oral therapy. The problem with furosemide is it causes hypokalemia, and that increases the risk of arrhythmias. So in a non-pregnant patient, usually potassium-sparing diuretic is added. But potassium-sparing diuretics are contraindicated in pregnancy because it may lead to feminization of the male fetus. And in non-pregnant, sometimes even thiazide diuretics are added, which is also contraindicated in pregnancy because it leads to thrombocytopenia, RBC abnormality, and even problems in the neonate. So second line, this is the acute therapy. Usually most of the patients of PPCM are put on chronic therapy. The purpose of chronic therapy is to increase the longevity, to survival of these patients. And it also helps in reverting back the damage which has been done to the heart. So in a non-pregnant, usually they are given RAS. RAS is renin-angiotensin-aldosterone system inhibitors. But these drugs, which includes angiotensin ACE inhibitors, ARBs, ARNIs, these are contraindicated during pregnancy because these drugs, they inhibit the renin-angiotensin system of the fetus also, leading to decreased urine output, oligohydramnios, pulmonary hyperplasia, and other problems leading to that. So it's absolutely, they are contraindicated in second and third trimester, and also in the first trimester, it may lead to teratogenicity because it may lead to cardiac anomalies, CNS anomalies. So they are absolutely contraindicated during pregnancy. So in pregnant patients, what option we have? So we use venodilators. That is combination of hydralazine and isosorbide dinitrate. This should be given only when the patient is stable and her BP is more than 90 systolic. And this is continued indefinitely. Other drug which is started, chronic therapy which is started on this patient is beta blockers. Most of our patients in Safdarjung also, they are on beta blockers. And the beta blocker of choice is metoprolol succinate extended release. And it is a beta-1 selective blocker. So it can be safely given in pregnant female and also during the breastfeeding. Propanol and carvedilol are usually avoided because it may lead to hypoglycemia, hypotension, and apnea in the newborn. Atenolol is absolutely contraindicated. But whenever the patient is on beta blockers, then we should be look out for FGRs. They don't cause any teratogenicity. Other drug, fourth drug which can be used is digoxin. Digoxin is used only if the patient is not responding to this. Regarding anticoagulants should, according to European Society Cardiology 2011, they should not be given just for decreased ejection fraction. Should be given only if there is a systemic pulmonary embolism, there is a thrombus in the left atrium, patient is on prosthetic valve, or there is atrial fibrillation. Not just for decreased ejection fraction, should never be started. And beside all this drug therapy, other most important thing is that we should give supportive therapy like oxygen, avoid lifestyle management, restriction of salt, and restriction of fluid. So this is the basic treatment which should be given to all antennatally to all the other drugs. Some are investigational, like we can give IVIG, and we can give autoimmune immunosuppressants and antisense therapy against mRNA. These are all investigational, and they are not are used only for investigational purposes.
So I may add over here is, apart from the drug therapy, I think we have to manage this patient antenatally also. She has anemia, if I'm not mistaken.
So we have to control,
correct her anemia.
Correct her anemia. We precipitating cause is anemia, so we have to look after that. Once the patient is stabilized, then we have to correct her anemia also.
Maybe RCC and also the oxygen and other treatment for heart failure, which is required, should be
support
added to the treatment which you have said.
ABC has to be given.
Yes, ma'am. So now I would request Dr. Jyotsna ma'am to continue further.
Yeah, thank you, Shiva. So very nicely summarized, Upma. You gave a really very good summary of the entire treatment. Now, what will be the timing and mode of delivery in this patient? And what are the concerns in the perioperative period? Dr. Smita, would you like to take this one, please?
Yeah. Peripartum cardiomyopathy is a condition which is temporarily associated with pregnancy, like an preeclampsia. However, whether we should induce the labor and the course of disease will change with termination of a pregnancy is not as established as in preeclampsia, and we really do not have an evidence which says that we should induce the labor only for sake of a peripartum cardiomyopathy. So as in any other heart disease, we do expect her to wait till the spontaneous labor in these cases. However, there might be some cases who have a refractory heart failure which does not respond to any medical therapy. In those cases, probably with an multidisciplinary input, we can take a call as to whether we should terminate the pregnancy by cesarean section. And in some cases, there are case reports which show that the termination of pregnancy has improved their outcome and response to the therapy. Now coming to the second part of a question, what is the mode of delivery? Again, spontaneous vaginal delivery is associated with the best outcome for the mother, and it is recommended according to European Society guidelines in 2018 in all the patients who are hemodynamically stable. In a women who are hemodynamically unstable, and again, as we say in case of a timing of delivery, those patients who are not very stable and need lot of monitoring, it's better to deliver them by a cesarean section under controlled situation, and that can improve their outcome. So as a general rule, we prefer a spontaneous vaginal delivery in a patients with peripartum cardiomyopathy who have a stable hemodynamic condition and are well controlled with their medical therapy. In an unstable patients, either both timing of delivery and mode of delivery can be modified depending on their medical condition. Coming to the third part of the question, what are the concerns in perioperative period? I would put it as a peripartum period because many of them usually deliver quite well vaginally and without any problem. The most important problem that we expect in these women peripartum or post-delivery is an heart failure. Even if they are controlled with a drugs in an antepartum period, immediately after delivery, the risk of heart failure is likely to be increased, and we need to very carefully monitor them, increase the dose of a diuretics or a beta blockers as per the requirement. Second concern is the risk of a thromboembolism, because as it is in a puerperium, the risk of thrombosis is more, and these patients with a reduced ejection fraction are particularly at a higher risk of thromboembolism. So they need to be again reviewed for their risk of thrombosis, and it's generally preferable to put them on a thromboprophylaxis in a postpartum period with either warfarin, and if they are already on an antenatal prophylaxis, we can switch over from low molecular weight heparin to the warfarin. Usually patients who have a lower ejection fraction, less than 35%, and who have an operative delivery will be benefited by giving the thromboprophylaxis. Then the concerns are related to the anesthesia, and it has to be properly planned in consultation with the anesthetist. Usually regional anesthesia is preferred over the general anesthesia. Then other concerns is these women are also at risk of an cardiogenic shock and ventricular arrhythmias. So we need to keep them very carefully monitored in the post-operative period for any of these complications. And again, as with any heart disease, risk of fluid overload needs to be taken into account and needs careful monitoring. And depending on condition, whether we can manage them in HDU or they need an ICU care will be decided by the multi.
I think, and the concept of pregnancy heart team, which I think in your institute you have a pregnancy heart team also. Yes, so I think that is a very good concept, that who can take care of the patient. So
one thing which may be important is we'll need to stop anticoagulants before delivery.
Yes, definitely there are
if they are started, we have to. Low molecular weight heparin is the preferred anticoagulation, and we do stop them as soon as either they go in labor or 1 day prior to elective cesarean.
So if we have planned induction, yes, with 24 hours before you should stop if you are doing a planned induction or cesarean. Yes, definitely. So I would like to ask Dr. Manju about the role of bromocriptine in peripartum cardiomyopathy. And the second part is breastfeeding safe?
Yeah, thanks, Jyotsna. Actually, bromocriptine has been used and has been tried, but its role is controversial. It's been used with the premise that, under oxidative stress, prolactin cleaves and it forms some cardiotoxic, fragments. And those fragments also cause some endothelial damage. And, studies have shown that if bromocriptine is added, it would kind of improve the recovery of the patient. But there is a regional variation. I'm to say Americans don't believe in that. Europeans guidelines, the one which are showing to talk about it. But I think when we talk about bromocriptine, we must keep in mind that, especially in postpartum patients, because if you give bromocriptine, the lactation is going to be suppressed. So that also has to be kept in mind, and we should not be using drugs until unless we have robust data on it. And the level of evidence of the slide which you are showing is also 2A. So it is not very strong evidence. So not that we should start bromocriptine in every and all the patients. So that is one thing. The second thing is about the breastfeeding. So breastfeeding has 3 issues. The first and foremost is that it is a very high metabolic demand condition. So any patient who is unwell, she would not be able to breastfeed her baby. But given the advantages of breastfeeding, I guess that anyone who is stable, we should not prevent breastfeeding in those patients. So that's part 1. Part 2 is, again, when a patient is breastfeeding, then, the prolactin rises, and the same issue about, it might aggravate the condition. We do not have any robust data to say that it actually aggravates. So actually any patient who is sick will not be able to breastfeed. So we should use our own wisdom and not restrict breastfeeding unnecessarily. And the third is that the drugs which the patient is on should be breastfeeding compatible. So Upma is given a very nice description of that we need to avoid atenolol. We need to, avoid ARBs, ACE inhibitors, and, NTG, nitroxide. So we need to look at all the drugs which are coming into, getting secreted in the breast milk. So these are the things we need to look at.
Yes. Very well, I think.
Jyotsna, I just want to, this ACE inhibitors can be given in postpartum period.
Yes.
If she is not getting refractory and she is not able to respond to metoprolol. So these can be added.
No, ACE inhibitors, see, this chart I have put up, enalapril and captopril are considered to be safe.
Yeah.
The other drugs, the other, about ramipril, we don't have much experience, but these two have been shown to be compatible. So we can use them in the postpartum period, in the breastfeeding period, yes.
ACE inhibitors, they are using a lot in our hospital also when the BP is not controlled. I've seen they are starting for hypertensive patients.
No,
if they
it
are
is
not
the drug
controlled
of
on
choice.
amlodipine. It's a drug. This is quite safe in breastfeeding.
It is the drug of choice for the heart failure, but we give it only in the postpartum period. And enalapril is, I think, a good choice to start with. So thank you, Dr. Manju. I think
it is very important that Manjupuri ma'am has brought it to forefront. But bromocriptine may be, given in few patients who are having left ventricular ejection fraction, which is less than 25%.
Yes, Dr. Anita, that is true.
It has been.
We are giving in our ICU. I think Madam's point is very well taken that we should give it. We should give it only in selected cases. as you also rightly said, who have got severe heart failure, less than 25%, and it has to be monitored well, and we have to make sure that they are taking anticoagulant. We have to give prophylactic anticoagulant because there is a risk of thrombosis with it. So we can't give her the tablet and tell her to go home. It has to be given under strict monitoring. So,
and just one more thing that, we can always try bromocriptine definitely in those patients who do not have their babies live, and, and we should research it.
Yes, ma'am.
And
Definitely.
we should try and look at it.
Exactly.
Yeah.
Those very sick patients, many times they do have IUD, and then that concern about breastfeeding is not there with them. So we are trying in such cases. We have been given, in few patients we have given.
And very sick patients also.
Yes,
we
very
also
sick
give
patients.
it.
Yes, we don't have much to lose there. So in the sick patients, we do give. Dr. Kiran, this is the last question. What is the prognosis of peripartum cardiomyopathy? Can future pregnancy be undertaken, and what contraception is advisable for this kind of patient?
So, okay, so see, it's very, if you look at your patient, I think in the last pregnancy also she had pictures of PPCM.
Probably it was that which was not diagnosed. Yes.
Which was not diagnosed, and I just wished that had that been done, then she would have been prognosticated properly, and maybe she would not have landed up in this situation. So what is important is that these patients should be prognosticated, and based on the but whatever evidence we have collected so far, which is mostly retrospective data and some case series and all. So definitely this condition is associated with the higher mortality. It ranges from various, from in first 6 months, it's about 2 to 13% recent figures which have come. With the less mortality in European countries and more in, South African, has already been told by Dr. Anita also. And then in the next 6 to 12 months also, there is a risk of 4 to 14%. Then in the first 5 years, and then beyond 5 years also, the risk may be as high as 7 to 26%. So I just wanted to tell you one thing, that there is one statistics from Indian study also, which says that it can be as high as 23%. So it is very important for these patients to understand that they have a long-term risk of mortality if they are not properly taking care of their conditions. So they are, it is recommended that they should follow up, properly every 6 monthly till their left ventricular ejection fraction is more than 50%. And then they should have annual visits for the next 10 years and continue with their antihypertensive and other drugs unless they are told to stop. Now, full recovery, we say when the left ventricular ejection fraction is more than 50%, and within 6 months, and these are probably also the candidates who would be at a lower risk in the subsequent pregnancy. However, if you at admission, if you see that the left ventricular end diastolic diameter is more than 60 mm, if the left ventricular ejection fraction is less than 30%, and if there is right ventricular dysfunction, then at the time of initial diagnosis, then these are the patients who are unlikely to make, full recovery. In fact, now we also understand that despite the fact that they may show full recovery by a definition of left ventricular ejection fraction more than 50%, it is seen that even patients who make full recovery, they also continue to have some kind of residual cardiac impairment. If you do, they still have those subtle diastolic dysfunctions and decreased exercise tolerance. And as more and more investigations are becoming available, so with some echo tissue doctors and all, they have found out they still have some kind of residual cardiac impairment. So this condition, is not something which you really need to be very careful when prognosticating these women. And patients who continue to have, at the end of 1 year, if their left ventricular ejection fraction is still low, and if she has any family history of cardiomegaly, I think that's the patient where you should also go in for genetic testing. They are the candidates.
Yes.
Now, you had asked about her, can future pregnancy be undertaken? In this patient, of course not, because she's third gravida, she's already had
She already has had, yes.
so not in this patient, but yes, in case there is a candidate who is to go in for the next pregnancy, then we have to give her a risk. We have to risk stratify her. And patients who made full recovery within 6 months period, as per definition of left ventricular ejection fraction becoming more than 50%, are probably the ones who can venture to for the next pregnancy, because then their risk of heart failure and mortality and relapse is slightly less than 10%, especially when if they are if they go into the next pregnancy in a very well controlled condition of and they are the patients who are on follow up, and they are taking their medications properly, and they are the ones who can probably go for the subsequent pregnancy. Now, here probably I think the bromocriptine, which we've already discussed, probably bromocriptine may have a role for the patients who had a very high risk, like their ejection fraction was less than 25%. So in those patients, to make their prognosis better for the next pregnancy, probably bromocriptine can help them kind of undertake their subsequent pregnancy. Now, as far as the contraception is concerned, we all know that in these patients, we would not like to give them hormonal contraception, especially the estrogen containing. And for this particular patient, I think she does not need to go in for any pregnancy further. So either she goes in for the permanent sterilization, which could be tubal ligature, or which could even be vasectomy for the husband, or she can go in for a long-acting reversible contraceptive methods like IUCD. Of course, then for other patients, I think who using it for spacing, there you can sometimes have progesterone only containing contraceptives can be prescribed, even Mirena can be prescribed, or double barriers, which are safe, but they are not very reliable methods. So definitely estrogen has to be avoided.
Yes, thank you, Dr. Kiran. And I really wish to thank all my panelists for such wonderful inputs. I think it has been a really brilliant session, and so I would like to thank everybody and close this session so that we could go into our next video session. I'll just stop sharing my screen. Thank you very much.
Thank you,
Jyotsna. You selected very good cases, 2 of them. And the PPCM, I can never forget one of my old colleagues, she had PPCM. She was managed like any other heart failure. At the age of 50 years, she died of that cardiomyopathy. So I can never forget that patient. So
yes,
that is why
close to your heart. It is important the mental health issues in these patients. These patients are very, very likely to have depression and post-traumatic stress disorders. We must keep them under observation, even of
so that is why I said, in our hospitals, we have to follow these patients. Somehow we have to make some, we should not let them go just like that, like the way she went away last time.
Yes.
We have to keep them on lifelong.
They should be really followed. It's very important.
Thank you, Dr. Jyotsna.
Thank you very much.
Thank you so much. Thank you.
Thanks, Shiba.
I request all our delegates to please be tuned in for the last 2 video sessions, which are really going to make, they have been made with great care and will give lot of inputs to all of you. Please do remain. It has become a little long, but I think it's going to be worth it.
Now you people must be feeling, hungry also. So that will also be taken care of.
You know what, ma'am? Most of us are fasting, I think.
That's what I'm saying. If you listen to the lecture, you will not feel hungry.
Yes, good. That's a very good point.
Yes, ma'am. So, ma'am, it said that I see what mind knows, but often the brain doesn't tend to forget whatever our eyes have captured once. So that is the importance of video sessions, and hence this session was conceived. So for the first video presentation, I would like to invite Dr. Divya Pandey, ma'am. She is an associate professor at Safdarjung Hospital and with a special interest in infertility and high-risk pregnancy. She is a joint secretary of Nachi Delhi branch, and she will be speaking. She will be showing us a video and speaking on medical management of PPH. Dr. Divya, ma'am.
थैंक यू शिवा फॉर घर की तरफ से बहुत साउंड होना चाहिए जब हमसे तो मदर इन लॉ रहती है
Harsha.
Okay. Are my slides visible now?
Yes, ma'am, they are visible.
So thank you, Dr. Jyotsna, ma'am, Dr.
Ma'am, we can't hear you.
Am I audible right now? Am I audible?
Yes, ma'am, now you're audible.
Okay. Thank you, Dr. Jyotsna, ma'am, Dr. Mittal, ma'am, for giving me this opportunity for be here at this forum and be speaking on medical management of PPH and demonstrating supporting procedural care. So, I'll be...
Divya, you have to come closer to your laptop. Your volume is less.
So I begin with this case scenario. This is a 24 years old gravida, previous normal delivery. She had a normal delivery at 8 p.m. Delivered a healthy neonatal. Hemoglobin was 13 g/%. She had blood loss of 250 cc. 4 hours postpartum, she developed tachycardia, developed hypotension, 90 millimeters of mercury. She was anesthesia. Hydration was given. 5 hours postpartum, she became drowsy. Hemoglobin fell to 7 g/%. 6 hours postpartum, cardiac liver enzymes were raised. She went to PIC. 7 hours postpartum, uterine tracking, uterotonics were given. Blood transfusion was started. 8 hours postpartum, was taken. She was taken for his 10 hours postpartum, she landed in ICU. And after 2 days, she had flat ECG. So she died after normal delivery. And she died of postpartum hemorrhage. The operation's nightmare.
Divya, your audio is not very clear.
PPH is a matter of concern because 2 lakh women die from PPH every year. And we should know that 90% maternal death due to PPH are preventable. So how much time we have? We need to identify and have golden hour of 1 hour. 1 hour from PPH. We have to be taking these steps.
Divya, you are not audible, dear.
Divya, madam, you're not using your laptop audio, I guess.
Now,
You're
now
using...
you try. Now try. Divya, now try. Yeah.
Am I audible right now?
No, right. Yeah.
So we have to be prepared. We have to be prepared and handle these optimize this delivery management. We have to identify the patient at risk. These kinds of patients handy and readily available in the room. We should have a delivery policy and some algorithm death from PPH is avoidable as we know most PPH are mostly unexpected. So we should identify staff and PPH bills must be performed very often.
So, Divya, can you speak closer to the microphone? Divya.
Yeah, ma'am.
In between, your voice disappears.
Am I audible, ma'am, right now? Am I audible?
Very, very faintly.
फिर problem obvious. So we have to stress upon
The internet connectivity is not good, madam.
I am using Wi-Fi.
I think you're using a different device for audio and a different device for showcasing your PPT. Is that so?
Yeah.
It has to be the same device. No?
Sharing will be difficult. Please give me a minute, please.
Can we go on to our next presentation till she changes her settings? Dr. Jyotsna?
Dr. Achla, ma'am, are you ready with the video?
Yeah.
So we can do Dr. Achla's presentation first. Divya can sort it out, I think. She has made the video with a lot of effort. I think we should have it for the benefit of all our residents here.
Jyotsna, she can just show the video. If audio is not there.
No, but
I think Dr. Achla can show it first. Divya, you can.
करना पड़ेगा.
Divya, you can stop sharing the screen.
Ma'am, am I audible right now?
Yeah, you are audible now.
So I can proceed.
You close the other device. उसमें echoing हो रही है.
आपका मैं mute.
If you're nearby, I would request you to.
Is it okay right now? Muted.
Ma'am, are you nearby?
Hello?
Yeah, I'm nearby. Can
Yes,
she
I would request you to maintain little distance between the two computers, madam. That will help.
Now is it okay?
Yes, now it's better. Okay, you can carry on.
डॉक्टर अचला का ऑडियो बंद करना पड़ेगा, माइक बंद करना पड़ेगा.
Yeah, unmute yourself, please. Yeah, yes, speak now.
Divya, you can speak.
Are my slides visible?
Yeah, everything is visible. Your voice is also we can hear. You can continue now.
Okay. So I would begin with active management of third stage of labor. WHO also says that it should be offered routinely, and it refers to administration of uterotonics soon after the birth. And the cord clamping should not be done earlier than 1 minute, and delivery of the placenta should be done by controlled cord traction, as you can see here. And it is very important to see the completeness, check for the completeness of the placenta once the placenta has delivered. So you have to ensure that the placenta has completely delivered. Now these are the 4 T's. Everybody knows about them: trauma, tissue, thrombin. We should know about this etiology, and we must know that 80% of cases of PPH are due to uterine atony. We must keep in mind this hemostasis algorithm. H stands for help, assess and resuscitate, establish etiology, give uterine massage, oxytocin should be administered, shift the patient to OT on time, tissue trauma to be excluded and proceed to tamponade, tranexamic acid. So this hemostasis algorithm must be learned by heart by everybody. So major points to remember here are communicate, resuscitate, monitor and arrest the bleeding, and all should go hand in hand. We should call for help. It should be a team effort. We should assess our circulation, airway and breathing. Resuscitation should be started in first golden hour, and it is very important to choose the right size of cannula. It should be 14, 16 or maximum 18 gauge cannula, and minimum 2 IV lines must be secured. This has already been covered by Dr. Rekha in the morning sessions. Resuscitation is very important part. Draw blood for grouping and cross matching. Rapidly infuse the warm fluids, and crystalloids are the fluid of choice. While resuscitating, keep the patient flat, keep her warm, catheterize the patient and monitor her output. We do not want irreversible shock to happen. So how to know whether she is going in irreversible shock? See, if you can see here, there are 10 bottles, which signifies average of 5 liters of normal blood volume of antenatal women. With loss of 3 bottles knocked down, that means it's loss of 1.5 liters. Practically, there is no change in the sign, and no signs and symptoms will appear. But 1 more bottle gone, 500 cc more loss, all signs and symptoms of shock like tachycardia and hypotension will ensue, and it is very important to act before this 500 cc blood loss. So how to assess the blood loss? We can have visual estimation of blood loss. These are various calibrated devices which can be used for quantification of blood loss. This is a pictorial reference guide. Everybody knows about this visual estimation of blood loss, but at times it has been seen that these kind of visual estimation of blood loss pictorial reference guide, we are underestimating the blood loss, because the internal blood losses sometimes we are missing. So a very important tool we can incorporate, shock index, which was covered by Dr. Monica in the morning. It is a very important and very easily doable tool, which can be done even by the junior most person on the floor. This is the ratio of heart rate on systolic blood pressure. less than 0.9, we are reassured, and more than 0.9 indicates hypovolemia, and it must alert us. So shock index is a very useful tool which can be used bedside. No, so resuscitation should continue. We should give her blood, uncross-matched group specific blood can be given, or O negative blood can be given. Check the tone of the uterus. If it is well contracted, suspect trauma, do cervicovaginal exploration. If the uterus still remains relaxed, give uterotonics and massage. Give uterine massage. The uterotonics of choice is oxytocin, followed by misoprostol. If you do not have oxytocin available, you can give 600 microgram for prevention, 1000 microgram for treatment. Other choices are carboprost, 15-methyl PGF2 alpha, and ergometrin. Ergometrin dose can be given up to maximum 1 milligram, but be cautious in hypertensive women. And carboprost can be given up to maximum of 8 doses every 15 to 19 minutes. But again, be cautious in asthmatic and never to be given IV. Another addition in this drug basket is tranexamic acid after the famous women trial. 1 gram slow tranexamic acid over 10 minutes can be given in the patient within 3 hours of the bleeding. It really helps to prevent morbidity and mortality. So continuous vital monitoring has to be done, and you have to monitor the adequacy of replacement with the urine output at least 30 cc per hour or mean arterial pressure more than 65 millimeters of mercury. Now the bleeding is still continuing, uterus is atonic, not responding to uterotonics. You can proceed to various uterine tamponade methods. These are the various balloons which are available. The most common which we are using are the condom catheter and Chhattisgarh catheter. The condom catheter is very easy to make. You just need a 16 gauge Foley scallop catheter and just slip on a condom over it, fix it with silk at lower end, and it can be inserted inside the uterine cavity and inflated with 250 to 500 ml of normal saline. It will give a tamponade effect and will decrease the bleeding. The only problem with this catheter is we do not have a drainage system. You do not know how much bleeding is ongoing or collecting inside. So here comes the modification, Chhattisgarh catheter. It is again very easy to assemble. Just make 2 rubber bands from the Foley's itself, puncture the Foley's bulb, evert it, and then you slip the condom over the catheter and fix on both upper and lower end using the 2 rubber bands which we made from the Foley's itself. So these rubber band can be used, and very important point here is to cut the tip so that we can have a drainage channel. And here I would like to emphasize that the filling port, if you see, the filling port is through the balloon port, not the usual drainage port. This has to be kept in mind when we are using this balloon, and it is very helpful for quantification of blood also, bleeding. So another option we have, this is Bakri balloon, which can be, it is made up of silicone. Again, it gives uterine tamponade, but it is a costlier option, costing around 9,500 rupees. So it can be done if available. This a very important thing I would like to demonstrate here. This is a vacuum retraction device using a PPH cannula. This is a stainless steel cannula which uses the principle of contraction and retraction. It is a stainless steel cannula. As you can see, the upper part is perforated, and this goes inside the uterine cavity once the placenta has delivered. If you can see, we can just insert it inside the cervical canal, guided by our fingers, reach the fundus and slightly withdraw, and then you can start put on the vacuum. As you can see in the picture, this goes inside the uterine cavity. Once you put on the vacuum machine up to 700 millimeters of mercury, it gradually sucks all the blood, and gradually the vacuum causes myometrium to retract over the PPH, this stainless steel cannula, and you can actually quantify whole of the blood. So blood loss measurement is also very easy with this device, and I have very good experience of using it. I have been using it as a prophylaxis in severe anemia cases delivering at our center while we are awaiting deliveries, and you will be surprised to know that the blood loss is only 20 to 30 cc when I use it for prophylactic purpose. Atoning PPH, it works like wonder. So it is a very useful device. It costs only 800 rupees and it is reusable. You can just autoclave it and you can reuse it. So coming to bimanual compression, If nothing is working, you give bimanual compression, put the uterines to stretch, and it will decrease the bleeding. Another life-saving procedure is external aortic compression. It can be used to arrest bleeding at any stage. The correct method is to close a fist, give a downward pressure, keep it slightly to the left of the umbilicus, and you feel for the femoral pulses. If the femoral pulses has disappeared, it indicates the adequacy of your compression, and it is very useful while you are transporting the patient through from the labor room to OT. So it actually decreases blood loss. And if all these conservative measures fail to hemorrhage, start surgical hemostasis sooner rather than later. Important. Very important to record the sequence of events, time of sequence of administration of drugs, fluids, blood products, time of any surgical intervention, and the condition of the female throughout. A word about non-pneumatic anti-shock garment. This is a very important thing which can be used as a first aid, as it controls the bleeding through direct pressure, circumferential pressures. It gives 20 to 40 millimeter of pressure it generates, and it actually maintains the blood supply to the vital organs. And the most important point is you can actually perform various vaginal and abdominal procedures while NASG is in situ. So not only for the referrals from lower to higher center, but only when you are also when you are transporting the female from labor ward or emergency area to the OT while you are stabilizing the patient, it will help you a lot. So remember the golden hour of resuscitation, hemostasis algorithm. PPH tray must be kept ready to be used anytime in labor room, and perform regular PPH drills. So predict, prepare, and be ready to deal. It should be a teamwork. All steps should go hand in hand. Blood loss assessment, you can use simple tools like shock index, uterotonics, don't forget oxytocin and prostaglandins, tranexamic acid must be used. Timely transfer to tertiary unit must be considered. Don't forget to document. Don't forget the role of aortic compression or NASG wrap if you have, and timely decision for surgical intervention. So you have to act in the golden hour to save the female. Now this is a case scenario where our residents have prepared a drill. You can just see how perfectly they have done it. Mrs. Radha, 28 years old, book patient, third gravida, previous to normal delivery with term pregnancy, previous to normal deliveries without any complications. She arrived in emergency room and she has delivered on the way to hospital around 15 minutes back. Placenta is still undelivered. So just see how they have done it.
Mrs. Radha, are you fine? Patient is conscious, oriented, and clinically approved to be 10 grams protein. Dr. Seema, check the antinatal report for the patient, and Dr. Anshika, secure a IV line for this patient. Dr. Shweta, take the vitals for the patient. Antenatally, hemoglobin was 11 grams and her blood group was B positive, and there is no high risk as such now. Ma'am, her BP is 104/80 and phosphate is 104/80. And for adult examination, patient the uterus is at 20 weeks or at the level of the uterus. I can feel the placenta still written inside the vagina. Dr. Shweta, give 10 units into IM to this patient.
While oxytocin given, controlled contraction can be done to take out the placenta.
Placenta and membranes are completely delivered. Patient is still bleeding. I'll start with the uterine massage. Dr. Shweta, take the vitals for the patient. I'm emptying the bladder. Dr. Seema, inform the consultant on call as well as the anesthetist team. And Dr. Anshika, arrange 2-unit fracture for this patient and also take the consent from the relatives.
Ma'am, my BP is 80/50 and pulse is 128 and patient is static now.
Patient is still bleeding. Administer 20 units into 1 unit RL for this patient and start fluids from the second line. Consultant on call informed, OD team informed, and consent. I'll start with the cervical estimation.
Oxygen started, ma'am, at the rate of 8.
Oxytocin is started at around 20 minutes. Or you can induce this patient. Cervical expression done, cervix is normal. I'll start with the bimanual massage since the bleeding is still not stopped. Meanwhile, there is 2-unit transfer, 4-unit FFP and 4-unit TRP for this patient, and also take the consent from the attendant regarding the vaccine transfusion.
Our distribution has been sent already. Now the vitals of the patient are 80/50 is the BP and pulse rate is 148. Participants extended level.
It is still bleeding. I guess we need to insert the balloon temporal for this patient. Dr. Shweta, take the BP of the patient.
Ma'am, our BP is 70/40 and pulse rate is 148 now.
Dr. Anshika, kindly start the drip. If the bleeding is still not controlled, I think we should take the consent of the relative and inform them regarding that patient needs to be taken up in the OT. Get the trolley ready and ship the patient to OT stat, and along with it will be the aortic compression. Yes, ma'am.
So this patient has not responded to the medical treatment, and she will be wheeled in the OT where Dr. Achla will take care of her. So thank you for your kind attention. And I'm sorry for the technical glitch I had. Sorry.
Thank you, Dr. Divya ma'am. And now for the next video session.
Excellent, Divya. You did a really good job. I must compliment you.
Yes, ma'am.
Very good, very good. And all our residents have done a great job too. Now we are waiting for Dr. Achla to manage her.
So, ma'am, now I would like to invite Dr. Achla Batra, ma'am. She's a professor at the Department of Obs-Gynae, Safdarjung Hospital. She's president NARCHI and chairperson of the AOGD Urogynecology Committee. And she's a member of AOGD Rural Health Committee member. And PPH is a very dear topic to ma'am. She's always been training everyone from years. I have been here at Safdarjung. So, over to Achla, ma'am, for surgical management of this patient now.
Good afternoon. Are my slides visible?
No, ma'am, not yet, ma'am.
Not yet, not yet.
Now?
No, ma'am.
No?
You'll have to, I think, do it again.
Okay, I'll do it again. मेरे हिसाब से तो they were visible. Let me see. अभी भी नहीं आई?
No.
एक minute. So while I am waiting for my slides,
Yeah, now it's coming.
Yeah.
आ रहा है. हाँ,
Okay.
आ गया.
So while Divya has given me the patient to handle, and I hope today being Karwa Chauth, people would be there. Otherwise, it doesn't matter. You people are there to listen. Yeah.
No,
So
people
the
are very
learning.
much there. Sumit has just sent a message. There are 397 people logged in.
Good. So
Yeah.
what we are going
Ma'am,
to
please
do is,
make it screen share. Full screen.
okay, I'll do that. Okay. हो गया?
Yes.
हो गया?
Yes, हो गया.
Okay, so what we are going to do to this patient depends upon how she behaves further. So what are the things we can do? We can give her, because she's atonic PPH, we can give compression sutures. We can give further small compression sutures like CHO or square sutures. We can do stepwise devascularization. And if we have the facility to do it fast, we can do arterial embolization, and ultimately we might have to do hysterectomy for this patient. So before we start doing anything, we must take certain consent. Transfusion consent, I think Divya must have already taken. We have to take consent that this patient will have what all procedures possible, hysterectomy, injury to the bladder, vascular injury, any injury can happen, the high risk to her life because she's gone into shock. Very important thing which I keep telling every time, and I still feel sometimes people are not doing, position of the patient for doing surgery of atonic PPH or PPHs, it should not be supine. It's very difficult for you to see the blood loss. So the hips have to be flexed at 15 degree, and then you can give a slight Tenenberg. And this position is very important for starting a surgery. Now people keep asking me, what should we do first? The stepwise devascularization or compression sutures? I think you can do either, whatever you are comfortable with. If you don't have the expertise for stepwise, it's better to do compression first. Meanwhile, somebody can come. But WHO has given in 2012 that first do compression and then do devascularization. It doesn't really matter. Whatever you're more comfortable, do that first. And what you should have when you have to do surgery, you should have either a 70 round bodied needle, or you should have straight needle, which should be at least 6 centimeter long. And now we don't have chromic catgut in Delhi. We use Vicryl 1. Then before you apply compression suture, you must check, standing on the right side of the patient, put one hand beneath the uterus, one above the uterus, press the uterus for 2 to 3 minutes. And since the position is such, you can see how much bleeding is there. If the compression for 3 minutes stops the bleeding, go ahead with the compression suture. So compression suture is B-Lynch, we all know. And there are 6 points which are taken. Point A, point B, then point C, point D, point E, and point F. Everybody who is going in for doing these compression sutures must, even if they've done many, it's better to have a chart in OT and just revise before doing, because you may go wrong somewhere. So what I'm going to do is first show it on a model and then show it in the video. So just for the juniors to remember, it is always out, in. See, we've gone from 4 centimeter lateral to the wall and 3 centimeter below the incision, from out to in, again, in to out, go over the uterus, go back. Now this is point A and B taken care of. Now we are going back. From back, what we do is, again, now we were out, so we will go in. From the back side, same level, you go in. And after coming in, you again will go out. So I will fast forward it a bit. So you have come out anteriorly. Now, since you have come from out to in, you will go into out. So you've gone into out, again over the uterus, then out to in, and then into out. So this is how you do a compression suture. And now I'll show you a video of actually how we do it. This video is so you can see that we are going. First, I marked the point. These are 6 points which I showed you. Now, again, from the lower side, in, into out, and then over the uterus, at the back, out to in. Now you're inside. Again, from in to out, the other side, 4 centimeter, medial to the lateral border, and 3 centimeter. Again, you go over the uterus, and then now you have 2 sutures, then out to in and in to out, and then now this is out to in, and then you will go into out. Just remember, you will not go wrong, out to in, into out every time, and then you tie it. And when you tie it, just remember that before tying, must take the angle, because sometimes it becomes difficult, to get the angles. So now the next slide I'll take. Suppose this patient, I had shown you a B-Lynch in which the uterine cavity was open, or you can even open it to do it. But when we are doing it, like the patient Divya has given me, sometimes we feel, why should we open the cavity? The uterus has been explored, the cavity is empty. So we have Haven suture also, which is a modification in which what we are doing is, we are taking a suture from above the reflection of the bladder, passing through the uterus, going up, tying it, taking another suture. And for the lower part, we are taking 2 sutures, which are going from anterior all the way back. Then you come in and again tie it. I'll show you a video for this also. Again, I've made one video. This is, you go from anterior to posterior with a straight needle. It has to be at least 6 centimeters long. Sometimes they straighten up, and then you tie it on the top. So now I will show you the actual picture, but picture has been taken in a patient who had a cesarean, because so we are going above the reflection of the bladder, anterior to posterior, and then on top of the uterus. You can either tie the stitches right now, or you can keep it in an artery and do it later. In this, we have tied it, first, and then similarly, we'll do it on the other side also, which I'll just fast forward after one and show you how you can do something so that the suture doesn't slip. So we've done it on one side, then we'll do it on the other side similarly, from anterior to posterior, and it has gone back. Oh. It wants to show itself again and again. I was trying to save time, so that the other video could be shown. So this is the first stitch. I think I'll let it be, otherwise it's taking more time. Only thing I want to show is how you can avoid slipping of the two ligatures, because there's nothing to hold them. So the second stitch, again from anterior to posterior, and tie it on the top of the uterus again. An important thing to remember, which is that when you are tying these stitches, if you had noticed in the dummy I was showing, the uterus was being squeezed anterior posteriorly and down by the assistant all the time, so that the stitches don't become loose and you have a perfect brace. So what we are doing is we are tying one Haman with a knot, and then we'll go to the other Haman stitch and then tie the two stitches together so that they don't slip. Some people like to do it, some people don't like to do it. So generally I feel it is better to do it because it does help it. So this is the Haman suture. Now the next is, sometimes these sutures don't control the bleeding. So you can add on this a uterine sandwich technique, which has been used by many. And I think GTP people are using it a lot, that after putting the Haman stitches, they put in a balloon. But this balloon has to be only filled from 100 to 200 cc's, not like 400, 500. Otherwise, it will cause ischemia. So this is also a lot of people are doing. Then the other compression sutures which are required when it is, placental blood bleeding, we have square sutures, we have vertical or horizontal loop sutures. What the principle is that you're opposing the anterior and the posterior wall of the lower segment. So this is a square or a jaw suture. What we do is you go in, and the dotted line is that you've gone posteriorly and gone horizontally, and then you come again anterior, again vertical, then horizontal, tie it to form a square. So this will take care of the bleeding. Now I again tried to show by my this thing that you've gone from anterior to posterior, and then you take the needle has to be straight here for this also. So we've taken a vertical suture from anterior, posterior to anterior, and then after taking a vertical suture, we will take a horizontal suture. And after taking a horizontal suture, again we'll take a vertical suture. So what is the end result? You will see the end result is that you have sutures which are tight, but you don't have a square completely, but you will have two vertical lines and you will have two horizontal lines. So two vertical lines would be there anteriorly in this. It could be either way, and two horizontal lines posteriorly, so that it is just compressing the bed which was bleeding. I'll show you the suture after it is complete. Then these are square sutures. With Hemel sutures, you can also take, see, these are the two horizontal lines and two vertical lines. Then we have, then the compression doesn't help. Then these are longitudinal sutures. These are what you do is from the lateral wall, the lower segment, especially placenta previa bleeding, you go from anterior to posterior and tie it, just like, simple stitch mattress. So you can take two sutures like this, and still if the bleeding is there, you can take two more inside. They help in controlling the bleeding of the lower segment. This is how it will look in the section. I have not done it. I just found it on this thing, but I think I'm going to try it now. And this is another method in lower segment bleeding. You can just pick up the cervix with a sponge holder or a Alice and stitch it to anterior and posterior wall. It will stop the bleeding of previa or sometimes placenta accreta, which is bleeding. Now, when nothing helps, then you come to stepwise devascularization. So this is the uterine artery, and it gives a ascending branch and a descending branch, and it is continuing and anastomosing with the ovarian. So what we do is, first we are doing the ascending branch. After that, if the bleeding is from the lower segment, it's a good idea to do the descending branch also. Then we do the uterovarian. If that also doesn't control, then we do the internal. So this is a video. It is starting that this is the scar area. So you put 4 fingers beneath the broad, behind the broad ligament, and your thumb is anteriorly, and you can see the, you can see the uterine artery. So you, on the eye, what I prefer is when I'm doing on the left hand side, I grow from the avascular area towards the uterus, and you have to take a bite at least 2 centimeters of the uterus. So you are using a 1-0 vicryl, and you're going from avascular area in the bread ligament with your fingers behind, so that you don't take any other organ, a bowel or anything, and then 2 centimeters of the uterus, and you tie the stitch. Similarly, you will do it on the other side. And what I want to show is that when there is a bleeding from the lower segment, you can do double ligation. And here, 2 centimeters below the stitch you have taken, you take another stitch, that it controls the bleeding from the lower segment, from the cervix also, it can control. Now, this will control a lot of bleeding. Next you do is the ovarian artery ligation, anastomosis. So you pick up the tube with 2 backbox. Then there's an avascular area you can see here. So you have to take a bite from the uterus. You can go either from the avascular area to uterus or uterus. This we have done from uterus, anterior to posterior, then from posteriorly avascular area. And it has to be near the uterus and near the, just below the tube, and it has to be near the ovarian ligament also. So the plexus is covered. So this is one side, and now I'll show you on the other side the posterior part of it. How does it look when you're doing it? So this is from the, you've gone from anterior to posterior, again taking a bite from the uterus, now showing posterior view. Now you've come out. So you can even take a bite from the ovarian ligament if you don't find space to come out, and then again, you've gone anteriorly, and you never tie the plexus, separately without taking the uterus. Then nothing is controlled. Of course, the junior should know how to do it, but always by this time a senior would come who is well versed. So you are taking this retroperitoneal approach. What you are doing is you are taking an incision from the lateral end of the round ligament to the infundopelvic ligament. and the level of your incision should go till the promontory. You should feel, otherwise you may not be able to get the vessel. So you open this broad ligament, and by blunt dissection, after cutting the peritoneum with scissors, blunt dissection, you will try to read the, you'll be able to see external iliac, and then with blunt dissection with finger and seeing that the ureter is in the medial fold. Very important. I'll just show you the ureter in the medial fold. You can see it is pulsating, and lateral to this is the vessel which we have dissected, then put in our right angle, taken a thread through it, and then you don't cut it, you only tie it. So you can see we took a double thread, so we will tie it twice at a distance of some distance, so that it is securely closed. It will be anastomos later on, of course. And after tying, though in this you can clearly see internal and external. Sometimes patient is fat, and if you have any doubt, you must feel for the femoral after tying the internal iliac that you've not done anything wrong. So internal iliac controls, it is doing it. 90% of the blood supply to the uterus at this moment would be decreased. So the bleeding would be controlled. But if it is not controlled, and this is a diagram, you can see external, internal, and must remember that you have to go from lateral to medial. Otherwise, you can injure the veins which are below, which are very thin walls. So this also you always must remember. Must see the ureter, must go from lateral to medial. And whenever you are trying internal iliac, you should have somebody in loop, that in case of vascular injury, though it doesn't happen, but it can happen. So then we try to teach everybody, our junior, that you should know it, because this can really save uterus. It is initially difficult, but if you know the complication and you learn it, you will be able to do it. When we do it, when like this patient, refractory atonic PPH, broad ligament base bleeding is there, you can't find anything, side wall or vaginal angle bleeding, you are not able to see anything, rupture uterus with the uterine artery torn, or when the cervix has been torn very badly and during an instrumental delivery. Then, of course, I said selective artery embolization is not our field. If you have the facilities, a patient can have, especially in cases of placenta percretas, incretas, where we know beforehand that this patient may bleed, we can have the balloon in place and inflate it if possible. And then peripartum hysterectomy sooner than later. You must remember, you should not, like we have this golden hour, if you have a patient who is in shock for a long time and then you decide on hysterectomy, what will happen? After the hysterectomy, patient maybe after a few days will die of acute renal failure or lung injury. So it has to be done fast. You should not let a patient be in shock for more than half an hour on table. You should do it rapidly, and don't try to save the uterus and lose the mother. Of course, I'm a firm believer of saving the uterus, but not at the cost of mother. So what I want to say is, you must anticipate PPH. You have to be prepared. You have to be skilled and fast. And surgical intervention should be early in management, and conservative surgery only if condition of the patient permits. If it doesn't, then go for radical. And you should inform your seniors early when you have a PPH. See, averting maternal death is based on having a prepared team and preparation and a full range of possible therapies. And that was the purpose of this video session, to make you aware of all the possible methods which are there. Thank you.
Thank you, ma'am, for very beautifully highlighting all the surgical steps in management of PPH. And now we...
It was really a very, very wonderful video.
Yes, ma'am.
Thank you so much.
And now we move on to the next video, which is on resuscitation. And for that, I would like to invite Dr. Rekha Bharti, ma'am, and Dr. Shipra Agarwal from anesthesia. Dr. Rekha Bharti, ma'am, as she's the co-convener of this workshop, and she's a senior specialist and associate professor in Safdarjung Hospital. She's the editor in our chief, Delhi branch. And Dr. Shipra Agarwal, she's an associate professor in the Department of Anesthesia at Safdarjung Hospital, and she has many publications to her credit. And over to Rekha Bharti ma'am.
Rekha, we can't hear you. You are muted.
I'm not muted. Now, ma'am? Hello?
Yes. Yes, we can hear you now, Rekha.
Okay, fine. So we just start with the resuscitation of the pregnant woman. Okay, so welcome Shipra. I hope you are there.
Yes,
Shipra? Yeah, sure. So we are just going to start this, and I hope my team is also here. Deepti, she's a senior medical officer at Vardhman Mahavir Medical College and Safdarjung Hospital. Deepti, are you there?
Yes, ma'am.
Okay, fine. So Megha, she is a research officer at Safdarjung Hospital. She's also assistant director, editor of the Nachi. And Ankita Jain, she is a senior resident in Safdarjung Hospital. So now I'm just going to see, this is actually, I'm not having any theory here. So I would like the audience to watch this video very carefully. It is a 5 minutes video. And for some purpose, you know, this was not made ideal video. So there are some mistakes which have been done, which are very, very common in the clinical practice. And at the end of the video, we are just going to discuss what has gone wrong there. So just watch this video. I hope the audio is there. The audio is there, Dr. Jyotsna?
Ma'am, we can't hear anything.
Rekha,
okay, fine. Yeah, sure. I just forgot to do that. Just a minute. I remember now what Sumit had told us. Na? I think I should give it some time. Yeah.
Drill for resuscitation of women with maternal collapse. We are doing this drill in a stepwise manner slowly for learning purpose, but in real-time scenario, this is the teamwork and all team members are doing their work simultaneously and cordially. Mrs. Rani Devi, 26-year-old female, G2T1L1 with previous normal vaginal delivery with 8 months amenorrhea has been wheeled into emergency room with history of fits followed by loss of consciousness for 15 minutes. Dr. Megha is first doctor to attend and doing the primary survey of the patient.
Rani Devi, hosh mein ho Rani Devi, aankhein kholo.
There is no response to verbal stimulus, so Dr. Megha is checking for the airway, breathing and circulation.
Patient not breathing, carotid pulse not palpable. Dr. Ankita, call the team. Patient needs CPR. Dr. Joslita, Dr. Mona, please arrive fast. Patient has collapsed. We need CPR.
CPR becomes ineffective in pregnant women more than 20 weeks of pregnancy due to aortocaval compression. This is why they have done left uterine displacement. Dr. Megha pushes the uterus towards left side. Meanwhile, Dr. Ankita and team has arrived for help.
Ma'am, I have attached the monitors. I have secured an IV line and I have taken the samples. And I will inform the consultant obstetrician, anesthesiologist, the critical care intensivist, and now I'm going to counsel the patient and the relatives.
They have secured IV line and samples taken for CBC, LFT, KFT, serum electrolytes, ABG, BT-CT, PT-INR, and also sent blood for cross-match. As soon as there was no response to verbal stimulation and carotid pulse was not palpable, Dr. Josnika started cardiac massage and Dr. Mona started ventilation with bag and mask at the ratio of 30:2. The cardiac massage in pregnant women is done by pressing at the lower half of sternum, which is same as for the non-pregnant subjects. Now we will see how Dr. Mona is giving bag and mask ventilation.
Bag and mask ventilation is given in the sniffing position. This is achieved by the head tilt and chin lift or the jaw thrust maneuver. The bag is being held by the C and E technique, that is the compression and elevation technique. The compression is on the body of the bag and elevation is done by using the lateral 3 fingers, and the bag is being pressed in coordination with the compression of 30:2. Next switch over.
Now Dr. Mona is doing ventilation and Dr. Mona is doing cardiac massage and Dr. Josnika is started ventilation.
15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
It has been 2 minutes. Has the pulse returned?
No.
I think we need to see the defibrillator. I think we need to see the heart pattern. Ma'am, I've attached the defibrillator. It is an asystole.
Kindly give 1 ml adrenaline IV fast.
If there was a
given.
VF or VT pattern, they would have defibrillated the patient.
It has been 3.5 minutes since CPR started. Has the heartbeat returned?
No, the heartbeat hasn't returned.
Then prepare the patient for perimortem cesarean. Dr. Ankita, please call Dr. Deepthi from labor room. I've already informed Dr. Deepthi. She's already on her way. Here she comes.
6, 7, 8, 9, 10.
The perimortem cesarean section is very important for improving the maternal outcomes and should be performed within 4 minutes. And baby should be delivered by 5 minutes, irrespective of the presence of fetal heart or the gestational age. So the baby has been received and it requires only 2 artery forceps and 1 scalpel.
The pulse has now returned.
Patient to be shifted for closing to OT, covering the patient, and baby is handed over to pediatrician.
We are stopping the chest compression and bag mask ventilation. Now we will secure the airway via endotracheal tube by intubating the patient.
A secondary survey and management of underlying condition will be started now, and the relatives have been briefed, but they will be again briefed about the condition of the patient and the prognosis of the patient in detail. Thank you.
Thank you. Thank you.
A drill for resuscitation of
Rekha, you have to unmute yourself. Rekha, unmute yourself.
Yes, ma'am. So I have to, go on to the next slide. That option of, I think I have to, if the slide is actually playing again and again, it is.
a drill for resuscitation.
Yes. So now, yes, am I audible now?
Yes, yes.
So Dr. Shipra, she is the expert from anesthesia with me. So now we are just going to take up, you just saw this video, and this is a very common situation which happens. And just because we are not doing many drills, so we are not perfect and we keep doing certain mistakes. So, Dr. Shipra, now this was the first reaction of Megha when she saw that the patient was unresponsive. She was checking for breathing. So, what is your take on this?
Yes. So, as you had told that this primary patient, she has been received in gynae casualty, and the patient was found to be unresponsive. Now, the gynae resident, she has found that the patient has been unresponsive by tapping on the shoulder and by trying to communicate with the patient in patient's own language. Now, the patient is found to be unresponsive. As soon as the patient is found to be unresponsive in any emergent situation, then from there only we will start the basic life algorithm and the advanced cardiac life algorithm. Now the first step for that is that we have to immediately call for help by calling the resuscitation team from the anesthesia. This is the first step to be taken even before checking for breathing and carotid pulsations. Meanwhile, also the second most important step is the arrangement of the defibrillator, which has been done later here. So calling for help by the anesthesia team and arrangement of defibrillator has to be done immediately as soon as the patient is found to be unconsciousness in any gynae casualty or GRR.
So now, if you had closely observed the video, so what happened at 0.37 minute was that Megha found that the patient was unresponsive. Very rightly, she called for help. Then at 1:06 minutes, the anesthesia team arrived and they started the cardiac compression. So, like Shipra, is it okay? Because they thought that anesthetists are more competent, they have been trained very well than obstetricians. So, and we have this, in our hospital, generally we have OTs next to the emergency or the labor room, so they are there very fast. So, you think it was a good decision to make here?
No, I really don't think it was a good decision, because in any basic life algorithm or ACLS, the main and the gold standard to improve the patient prognosis is to minimize any delay in chest compression. We have meanwhile, the gynae resident had called for help from the anesthesia department, and she had checked that the patient was not breathing or there was a kind of gasping respiration. She should have checked for the carotid pulsations, and both breathing and carotid pulsations should have been checked over a time span of 5 to 10 seconds. Then she should have only started the chest compressions. Meanwhile, we were waiting for the anesthesia resuscitation team to arrive. This would have minimized the delay in initiation of chest compression and would have improved the patient prognosis and survival and brain hypoxia.
So this is very, very important. This is one point that we want to highlight. So nowadays, we know even paramedics, even general population is being trained to do the basic life support. So as doctors, as obstetricians, we cannot deny the patient of this care. So whenever you see patient is unresponsive, call for help, but at the same time, start chest compression. So now next thing, very rightly, Megha, you switched over to the lateral uterine displacement. Okay. So now I would just like to know, what are we trying to achieve basically by doing this left uterine displacement? Why it is important?
Ma'am, as we all know that uterus is dextro-rotated in gravid state. So to lift up the aortocaval compression, we tilt the uterus towards the left side so that the aortocaval compression can be relieved, and it will help us to give effective cardiac compressions and to increase the cardiac output of the patient, of the pregnant patient.
So there it was a dummy, so probably you couldn't position your hand very well.
Yes, ma'am.
So could you just describe the methods by which we can give this LUD can be given?
There are two techniques, ma'am. One is the pull technique and the other one is the push technique. The push technique is when you are standing on the right side of the patient, and then you have to push the uterus towards the left side, as depicted in the second picture, from one hand, keeping the palm of your one hand towards the right side, and then gradually tilting the uterus towards the left side. And other one is the pull technique, in which, if you are standing on the left side of the patient, you keep both your palms on the right side of the patient and pull the uterus towards the left side so as to relieve that aortocaval compression.
So although in the literature it is described that both techniques are very well, but I'll suggest you You can start it wherever you are standing by the pull or the push technique. But later on, we'll see, this is not written anywhere, but it is just a clinical experience that it is always better to stand on the left side. So we'll see further why it is so important. But one more thing, Megha, initially, previously we used to keep a wedge. So what do you think about keeping a wedge under the patient to tilt the uterus?
Ma'am, by convention, tilt wedge was used to create a tilt for the pregnant patient, and it was believed that one of the physician is now free to help and assist for the resuscitative measures. But it has been seen that with tilt, the heart also shift towards the lateral side, and the compressions which we are giving will be performed over the patients who are tilted as per the patient, or over the patients which are performed in the supine position with LUD is less effective with the tilt.
You so very rightly said, it is always better if you give LUD, though they say if you do not have an assistant, you can use the wedge, but then your compressions may not be as effective as they are when you are doing LUD. Okay. So, Dr. Shipra, so this is, the position of the anesthetist or the person who was first starting the cardiac compression. So, what do you have to say about this?
Yes. So actually, we should all know what is the right way of doing chest compressions, because it is the most important and the first component of initiation of cardiopulmonary cerebral resuscitation. Now, for the cardiac compressions, the anesthetist or any person who is about to start the compressions, the patient should lie on a flat and hard surface. The person who is about to give the chest compression should kneel by the side of the patient. Now, the elbows and the hand should be straight and they should be perpendicular to the chest, so that there is effective force transmitted from the resuscitator to the patient's heart, like as shown in the diagram. Now, the position where the chest compression is given is the lower half of the sternum. It is same in the pregnant as well as in the non-pregnant patients. Now, there are 4 basic rules which we have to follow while we give chest compressions. First is push hard, which means that we have to push to a depth of either 2 to 4 inches or 5 to 6 centimeters. Now, the principle behind this is that there is effective compression of the heart and improved forward heart flow. The second is push fast, that we have to push at a rate of 100 to 120 per minute. This is again to maximize the forward flow. The third is to improve chest recoil, as in when we are giving chest compressions, we have to allow chest to recoil back. This will help the venous return to come back and improve in the patient survival. And the last and the most important, which we don't have to forget, is that we have to minimize any kind of interruptions in giving chest compressions. Any delay should be less than 10 seconds. It should be less than 5 seconds ideally, but really not more than 10 seconds while we are attempting giving chest compressions.
So now this is, the anesthetist, this is a very common situation because our patients are not on the floor, they are on the table or they are on the trolley or the bed. So your position is not right when you start the compression, as was the case in this film. So the anesthetist quickly realized this and she shifted onto the bed to give effective compression. So this is very important, the position when you are giving the cardiac compression. So now this is the next thing which has been done here is the bag and mask ventilation. So Dr. Shipra, can you just describe, though it was beautifully described in the video also, but I would just like you to highlight 2 things on bag and mask ventilation.
Yeah. So we follow a sequence of CAB, which is compression, airway, and breathing in the BLS and ACLS algorithm. As we have seen the right way of doing chest compressions, then we'll see airway and breathing. Now, airway. Before starting with the breathing, we have to open the airway, which will be done by head tilt and chin lift. Now, after we have achieved head tilt and chin lift, then we'll place an ambu bag and a mask on the patient's face by a C and E technique. Now, C is for compression. We can remember it like that as shown here. Now, C will help the mask to be fit tightly on the patient's face, and E is the elevation of the mandible to open the airway. While making an E, we should remember that we should not compress the soft tissues of the neck because it will lead to obstruction of the airway rather than opening it. Okay, now once we have secured the C and E position of the mask, then we will give 2 breaths.
Now the two breaths are given over a period of 2 seconds each, one for inspiration and one for expiration, followed by a second breath simultaneously. Now, another important thing is that when you will have to give a breath, we will see for the chest rise. We don't have to over ventilate the patient. We will bag only just to see a visible chest rise. Over ventilating will decrease the venous return and will result in decreased effectiveness of chest compression. So this is a very important thing which we have to remember while bagging the patient.
So one thing, Shipra, like as we saw when they were giving chest compression, to give these two breaths, they stopped the chest compression. So is it right? This is what is to be followed?
Yes, ideally the chest compressions and ventilations have to be followed in a sequence of 30 compressions followed by 2 ventilatory breaths, whether there is a single rescuer or there is a 2 rescuer. So, and this have to be carried out in 5 sets over a period of 2 minutes. This will complete one cycle of CPCR. So once, as Dr. Joslita has given 30 chest compressions, Dr. Mona will give 2 ventilatory breaths. For that time, yes, you have to hold onto chest compressions, but as soon as 2 breaths are delivered, then again she will start with 30 compressions to complete the cycle.
So this is important. And second thing, what I would like to highlight from the point of obstetrics is that many a times we feel that patient needs intubation fast, and we don't give emphasis on bag and mask, and we try looking for the anesthetist to intubate the patient. So that is not very essential. So it is important that you should start the basic resuscitation and just don't wait for that patient needs to be intubated, only then it will be effective resuscitation. So this is a myth among obstetricians, that they feel that you call someone so that they intubate. Rather, while intubating in pregnant patient, intubations can be difficult also. So you may waste some time, and may not be giving chest compressions in that time. So that can be, so initial resuscitation, bag and mask should be started. Then later on, you should assess when you can go on to the intubation of the patient. So now this is one, a thing which I wanted to highlight, and that's why I said, if clinically you ask me, I would say you should stand on the left side of the patient and pull the uterus towards your side. Why? Because now the person has to shift to give the chest compression. As Dr. Shipra has already mentioned, it is very tiring to give good chest compression, because as she said, it has to be, the push has to be fast and it has to be hard. So after 2 minutes or 5 cycles of the cardiac compression, if you have given, it is very difficult to continue with the same enthusiasm and same aggression. So it is better to switch over. So while switching, because Megha was standing on the right side of the patient, so they started switching on the same side. So what do you have to say in this, Shipra? Is it a right thing because they didn't have space here, or should they have, left the uterine displacement and concentrated more on chest compressions?
Yes. So actually, after completion of 5 cycles of 30 compressions and 2 ventilations over a period of 2 minutes, then the next step is checking of carotid pulsations, which will be done by the person who was bagging. Now, rather than switching from the same side, ideally what is done is that person who is bagging will come and start giving chest compressions immediately from the alternate side, because there will be again minimum interruptions in chest compression. This will prevent any kind of interruptions in chest compression. The person who was giving chest compressions can later come to the head side and start bagging. That anyways have to be done after 30 chest compressions. So rather than switching from the same side, it is always a good idea to switch from the alternate sides and begin chest compressions first, rather than creating any kind of delay in chest compressions.
So rather than focusing on fixing the mask, we should focus on continuing with the cardiac compression. So unless your reliever has come towards your side to continue with the cardiac compression, you should not leave that position. Even respiration can be delayed, because it anyway has to be given after 3 cardiac compressions. So now, see, this is a very good decision which they took very timely. They thought of doing a resuscitative hysterotomy. And Dr. Deepti, I would just like to ask you, like, whenever a patient collapses or becomes unresponsive and you start the resuscitation of the pregnant woman, so when is the time basically you should start thinking of doing this resuscitative hysterotomy, or we call it as perimortem cesarean section? Deepti, are you there? I think Deepthi was in the hospital. Has she not joined, Megha?
She had joined, ma'am.
Okay, so Megha, can you tell us that when should we start thinking of doing a perimortem cesarean section? Unmute yourself, Megha.
Ma'am, even after 4 minutes of good cardiopulmonary resuscitation, patient was not responsive. So as to relieve even if with the LUD, the complete aortocaval compression is not done. So to remove the products of gravid uterus, we resuscitative hysterectomy or the perimortem cesarean is the need of the if after the 4 minutes is the adequate time. If after CPR the uh, pulse or the breathing pattern, there is no reversal of spontaneous circulation in patient.
So very rightly said, Megha. At 4 minutes, you should start doing the hysterectomy. But then if you have to start at 4 minutes, because by 5 minutes, you should have accomplished it. So you should start preparing for it at least from 2 to 3 minutes, because you have to call the obstetrician if it is not available,
Yes.
or some working hands
Yes.
which you need. So this is there. So next thing is, Ankita, so when we are doing perimortem cesarean section, so how do you take care of the asepsis? How do you clean and drape the patient? What are the guidelines on that?
Ma'am, it is said that time should not be wasted on abdominal preparation. However, if an antiseptic solution is available, it can be poured onto the abdomen. Otherwise, if drapes are not available at the site, or if the antiseptic solution is not available, time should not be wasted in procuring it.
So this is very important, you know. So most of the times in labor room, we do have betadine available. Just pour it on the abdomen. Don't waste time in cleaning and draping. So what all instruments we would like to have with us for doing this? Do we need to have the tray available for cesarean in our labor rooms and emergency rooms?
Ideally, ma'am, a tray should be available for such an emergency in which we have a scalpel with a number 10 blade and at least 2 artery forceps.
So only 2 artery forceps and a scalpel and blade, which is there in all the wards also, because it is a part of the cut down tray also. So it is available. So only you need a scalpel and a blade and 2 artery forceps, and that's all. I think that's all which we require. So do not much of the thing is to be needed for this. So now, Megha, when we have done this perimortem cesarean and all, so what is the role of taking consent from the attendants? Like you are going to perform a surgery on the patient, and we lay so much of emphasis on taking consent and all. So what is the consent taking in this condition?
Ma'am, perimortem cesarean is a part of resuscitation of maternal collapse. So it is this resuscitation is it calls for implied consent. There is no written consent needs to be taken. Though we as emergency practitioners, we should give equal importance to informed consent, which can be taken after we have done this procedure, so as to tell them what procedures or what is the prediction for the patient, what will be the prognosis for the patient.
So no written consent is required, and so that is why, you know, nowadays we don't call it as perimortem cesarean section, we call it as resuscitative hysterotomy, so that you don't have to take a written consent. But yes, as if you have a working hand available, and if you are informing the attendants the condition of the patient, that patient has collapsed, you are doing resuscitation, you can just mention about that this will be done. If patient is not we are not able to revive the patient within 3 minutes time, we'll start preparing for this. But you do not need any consent for this. Okay, it is implied consent. So now we were, very lucky that our patient was revived after your efforts. So what is the next thing to do?
So, ma'am, once we've had return of spontaneous circulation, so in this case, we've done perimortem cesarean delivery for this patient. So we will first establish a definitive airway. So anesthetist will intubate the patient, and then this patient will be, after covering the abdomen of the patient will be first shifted to OT, where we can close the abdomen, and then after this, patient will be shifted to an obstetric ICU, which is in our facility we have an obstetric ICU, so we will shift the patient there, and it calls for a secondary survey, and we have to reverse the underlying condition. So there are it is given by ABCD. So A is for anesthetic complications, like for example high spinal or aspiration. or accident, or the cause can be due to bleeding. B stands for bleeding. So it could be due to antepartum hemorrhage due to abruption or placenta previa or placenta accreta, or it could be due to coagulopathy. Then C stands for some cardiovascular cause, for example, cardiomyopathy or a myocardial infarction in such a patient. D stands for drugs. So from an obstetric point of view, the importance is even oxytocin or magnesium can lead to such a collapse, which is important. Then E stands for embolic causes. For example, pulmonary embolism or amniotic fluid embolism, which is quite, we have seen so many patients succumbing to that and collapsing. Then F stands for fever. G stands for your general H and T causes like tamponade and hypertension. H stands for hypertensive disorders of pregnancy. So we have to do the secondary survey and know the cause of collapse and reverse the cause. So we have to treat that.
Yes, very important thing is that you don't go on to the knowing the cause and all when the patient is collapsed. It is only after you have been able to revive the patient, or if you have someone who's simultaneously taking the history and trying to find out the cause. Otherwise, our focus should be on reviving the patient. And very correctly said that don't shift the patient like this unless you have secured the airway. So till now, if we didn't have the anesthetists here, now is the time that anesthetists should be here. Anesthetist should intubate the patient, and only then we should wheel out the patient to the OT. Okay. So now, Shipra, like just something we would like to have from you on defibrillation, because it is very important. You also said that we also were late in arranging for defibrillation. So as soon as you find that the patient is unresponsive, one person should ask for defibrillator. So what is like this role of defibrillator in resuscitation?
Yes. So arranging defibrillation should be actually the first step after you have found that the patient is found unresponsive in a casualty. So after you have arranged for defibrillator, then what is the next step? Then you will attach ECG electrodes on the patient. Now there are two types of rhythms which you will find in an unconscious and unresponsive patient. One is the flat line, which you also known as asystole. In asystole, there will be continuation of CPR, and there will be giving of 1 milligram of epinephrine followed by 20 ml of flush and elevation of the limb extremity every 3 to 5 minutes. This is asystole. But there are other kinds of rhythm which are also known as shockable rhythm. These rhythms are either ventricular fibrillation or pulseless ventricular tachycardia. If we are finding these rhythms on the monitor, then the next step is to defibrillator, or we commonly say as giving shock to the patient. Now, what will defibrillation do? It will synchronize the bizarre electrical activity of the heart into a synchronized one. So now how you have to prepare for giving a shock. The next step is that you have to select for energy. Now, majority of the people don't know, and it actually depends on model to model, what kind of energy you have to give for shock. Now, the rule of the thumb is if you really don't know, select the highest energy which is available and which is around 360 joules. After selecting 360 joules as an energy to deliver shock, then you apply jelly on the pads. Now, first pad will be kept below the right clavicle, and the second pad will be kept left to the left nipple. Then you will say, I clear, you clear, everyone clear. And it should be both a verbal and visual inspection before you deliver a shock. Then you will give shock to the patient. As soon as you have given shock, then immediately there should be resumption of chest compression. There should be again not a delay in chest compressions. So that is why defibrillation is a very important and should be an early step in resuscitation of any patient which should be found unconscious and unresponsive.
So Shipra, from our internship days, we know of two drugs whenever a patient has collapsed: adrenaline and atropine. And I know till now the practice is whenever a patient is unresponsive or you are doing CPR, we say give adrenaline, give atropine. And one very important thing which you highlighted, which many people do not take care of, is when you are giving adrenaline, it is very important to flush and elevate the limb, because the circulation is not there. How will it reach the heart? So this is very important thing which everyone has to take care of when you are giving adrenaline. So what is the role of atropine in these patients who are being revived?
No, actually, there is no role of atropine if there is asystole. Atropine is only given if there is bradycardia, which is heart rate less than 50, and the patient is awake and there are signs of hypotension which are present like giddiness. If a patient is having asystole or pulseless electrical activity, atropine has no role, and adrenaline 1 milligram should be given, and it should be repeated after 3 to 5 minutes.
So this is about the drugs which we have talked about. So, and I would like to thank my team who worked on this video, and they really had put in a lot of efforts in making the video. And Dr. Mona and Dr. Joslita, they are the senior resident from anesthesia side, and very enthusiastic senior residents have really worked hard in making this video, but for some reason they could not have joined us here. So thank you, Shipra, for being there and for describing it so well for the audience.
Dr. Rekha, can I say something?
Yes, please.
Very nice video. I just want to congratulate Ankita and her colleague. I just wanted to add that it is very important when they are conducting drill. It was beautifully done, but it is very, very important to keep on briefing the relatives also and debrief at the end. So whatever resuscitative measures have been done, you have to debrief the patient's relative at the end of your resuscitative measures, whatever you have taken. And if you will not keep on informing the relatives at intervals, they will keep on troubling you. So that is also very, very important. Debriefing
Yeah,
is
very right. Very rightly said, Dr. Anita. Otherwise, we'll have to be there with 2 security men to finally, you know, tell the relatives. So very important thing you have highlighted. Thank you so much for your inputs. So now I hand over to, we have Sheba. Can you want to take Dr. Jyotsna? Do we have some time or do we have some important questions in the chat box that we have?
I think we'll answer them in the chat box. We are already 1.5 hours late. So I think we should, all good things are come to an end, and this also. So I invite Dr. Rekha to propose the vote of thanks. And I think any important questions will be handled in the chat box, or we can even personally, we are all very, very contactable. We can be asked by anyone who has any query. We will be very happy to answer.
So now it is the final thing, vote of thanks. On the behalf of the organizing team of post-conference workshop on critical care obstetrics, first and foremost, I would like to thank the organizing committee of 42nd Annual and First Virtual AOGD Conference, organizing chairperson and president AOGD, Dr. Mala Srivastava, organizing co-chairperson and vice president AOGD, Dr. Kanika Jain, the secretary, Dr. Mamta Dagar, for entrusting our team from BMMC and Safdarjung Hospital for organizing this post-conference workshop on critical care obstetrics. I am thankful to Dr. Alpesh Gandhi, President FOXI, for sparing valuable time from his busy schedule to address our audience on a very pertinent issue. I also extend special thanks to our external experts, Dr. J.C. Suri, the Doyen in Pulmonary Critical Care and Sleep Medicine. Sir, thank you for being our mentor for critical care obstetrics. I am grateful to Dr. G. Usha, Head of Anesthesia Department, for providing her faculty and residents to be a part of our workshop. My special thanks to Dr. Shipra Agarwal, Associate Professor, Anesthesia Department, and her team, Dr. Mona and Dr. Joslita, for their immense contribution. I would also like to extend special thanks to Dr. Pratima Mittal for being an advisor, not only for this workshop, but for all our academic ventures. My heartfelt thanks to Dr. Anjali Dabral, Head of the Department, BMMC and Safdarjung Hospital, for being a pillar of support. I am grateful to all the chairperson, panelists, and all the experts for their valuable contribution to the workshop. My special thanks to the most vital contributors of the workshop, our audience. Without their participation, these workshops are meaningless. I'm also thankful to Plus Life Science for sponsoring keynote address. And I'm grateful to Mr. Sumit and his team for helping us conduct this workshop smoothly. Thank you all for being a part of this workshop.
Thank you.
Yeah.
I think all of us deserve a big applause. All of you have done very well. So congratulations to all.
So can we, Sumit, do they have they wanted to run plus Life Sciences wanted to run their.
Dear doctor, pregnancy is a beautiful journey in a woman's life. A journey where she needs care and your expert advice. As her body goes through a 9-month-long transformation, she requires extensive nutrition. Nutrition that nurtures her growing baby and helps her navigate through some unpleasant experiences of pregnancy. Introducing TrimaCare, 9 months of extraordinary care for an extraordinary role. A prenatal pill designed to fulfill complete nutritional needs of Indian pregnant mothers. TrimaCare 1, 2 and 3 are specially designed for each trimester of pregnancy and the growing needs of mother and child at each stage. TrimaCare is formulated by experts following the ICMR guidelines. It's made with iron, folate, calcium, vitamin D, omega and more than 25 nutrients essential for a healthy pregnancy. TrimaCare adheres to multi-micronutrient supplementation known to reduce risks of low birth weight, preterm births and babies born small for gestational age, and also helps in fetal neurodevelopment. With the right ingredients, TrimaCare helps reduce commonly experienced symptoms in pregnancy like nausea, vomiting, morning sickness, constipation, UTI, leg cramps, and hypertension. TrimaCare is free from allergens, is non-GMO, has higher absorption value, is gentle on the stomach, is 100% vegetarian, and is made with premium ingredients. Dear doctor, now no more trouble of prescribing multiple pills to your pregnant patients. Choose trimester-wise care. Choose the right nutrition for Indian pregnant mothers. Choose TrimaCare.
Thank you, ma'am.
Thank you so much.
Thank you.
Sorry
I
for
think now
singing.
we all can.
Yeah, we can all go and do our puja and happy
Puja.
Karwa Chauth
Preparation
and
for
Right.
puja.
Happy Karwa Chauth.
happy feasting
Everyone.
after happy fasting to everybody.
Yeah, thank you, ma'am. Same to you. Okay, bye, ma'am.
Okay,
Very
bye
good.
bye.
The
Bye,
whole
ma'am.
thing is
Thank you, ma'am.
done. Bye. Bye.
Bye.
Thank you, ma'am. Bye, ma'am.
Bye, Ankita. Thank you.
Megha and all our youngsters have done very well. Ankita, Megha,
Thank
all
you so much, ma'am.
well done.
Thank you, ma'am, for giving us an opportunity to be a part of this academic treat.
Okay, bye-bye.
Bye, ma'am. Happy Karwa Chauth.